urinary cancers year in review. This is a unique concept which we started 3 years back, and the first 2 years were basically online because of the COVID. And we had a very good experience for the first 2 years. There's a concept in which we bring all our colleagues from surgical, radiation, and medical oncology all together, and we discuss the abstracts and the papers which have been presented or published in last 1 year. The idea is to keep everyone updated and keep abreast about the latest happening in the field of uro-oncology. And I welcome you all for this first physical meet this time. And this was the brainchild of Dr. Kumar Prabhash. I wanted to thank him, and also my co-organizers, Dr. Randeep, Dr. Harry, and Dr. Aditi. And we have been working on this for last 3 years. So without waiting further, I'll just start the proceedings and invite our chairpersons for the first session. So to chair the first session on prostate, non-metastatic prostate cancer, I would like to request our chairpersons to come on dais. Dr. S.N. Hukku sir, please. He is a chairman and senior consultant radiation oncology from B.L. Kapoor Hospital, New Delhi. Dr. N.P. Gupta is just joining us in 5 minutes. He is the chairman, academic and research urology in Medanta Hospital, Gurgaon. And Dr. Ganesh Bakshi is a professor, Department of Uro-Oncology at PD Hinduja Hospital, Mumbai. Sir, I would request you to please invite the speakers and start the proceedings.
Good afternoon. नहीं चल रहा। So as usual, we start with the diagnostic part first, and the first presentation is MRI targeted or standard biopsy in prostate cancer screening by Dr. Srivatsan Ramani, who is consultant uro-oncologist and robotic surgery lead, Apollo Hospital, Chennai. I would request all the speakers to keep their time.
Sure. A very good afternoon to one and all. I thank the organizers for giving me this opportunity. The paper that has been given to me is the MRI targeted or standard biopsy in prostate cancer screening. Now, this is a topic of interest to all of us. I think all of us have come into the the purpose of doing MP-MRIs prior to any prostatic biopsy. The problem is that as a screening process is what they are trying to evaluate. This is a Swedish study from the Public Health Center of the Sweden, Stockholm. So what is the purpose of this study? Whether the overdiagnosis of prostate cancer while screening for it, is it possible to avoid? Whether MRI with targeted biopsy with a higher positive predictive value can be used to overcome it. Can we reduce the number of detection of insignificant cancers while picking up the significant ones? Or rather, can we even avoid biopsy in certain things? Now, this is a prospective RCT. It's a non-inferiority trial. It's a paired positive trial. The duration of the trial was from 18 to 21. Now, this is something I learned new in this paper. This is the study. The short form is the STHLM3 MRI trial. Now, it basically uses a paired screen positive step. That is, there are 2 screening tests that is used and a random assignment done later in order to divide it into the categories of whether to undergo MP-MRI followed by a systemic, targeted biopsy, or directly go for a trust-guided systemic biopsy. Now, the 2 screening tests that was used was the PSA, obviously, and the second was a Stockholm 3 test. Now, this is something new which I learned from this paper. The Stockholm 3 test, very similar to the PHI that we have heard about, is a risk prediction model that's based on clinical variables, including age, first-degree history, prostate previous biopsies, blood markers like PSA, free PSA, the ratio, human HK2, macrophage inhibiting cytokine, and so many other things. They also include a polygenic risk score, depending on which can predict of Gleason score above 7. Now, the study population was the general population of Stockholm, 50 to 74 years from, they were invited by mail. PSA of value more than 3, and this is something slightly different as well. They have taken a 3 as the lower end of the, the screening purposes. The method that was used was that they were randomly assigned in a 2:3 ratio to undergo either a standard biopsy group, or they will enter into an MRI group followed by the targeted plus a systemic biopsy as well. So what was the purpose is that if the lower boundary for the 95% of the two-sided confidence interval is the absolute difference in the significant cancer between the two groups, if it is more than -4, then the experimental strategy would be considered as a non-inferior trial. However, if it is greater than 0, then we know that the experimental design is actually superior to the trial. So let's get on to the various protocols that they followed, which is quite standard to what we guys do as well. So it was, the biopsy was performed by an experienced urologist, having the typical template that we use. The experimental biopsy group, which is the group that we are targeting, basically they underwent the multiparametric MRI with the use of both biparametric later, and it was a combined T2 and diffusion weighted without contrast enhancement. They were again classified according to the PIRADS 2 and 2.1, the latest scoring system. A maximum of 3 clinically significant lesions were identified per participant and delineated for the targeted biopsy with the use of dedicated software as well. Again, they were all, external quality purposes were all followed, and they were reviewed again by a second radiologist as well. Coming to the pathological assessment, Gleason score, the number of millimeters of cancer in each biopsy, everything was done according to the ISUP 2014 guidelines. Again, everything was again rechecked by another qualified uropathologist as well. Now let's get on to the outcomes. What were they aiming to get at the end of the study? The primary outcome that they aimed at was the detection of proportion of men with intention to treat population in whom clinically significant cancers of grade than 7 was diagnosed. The secondary intention of all this study was to detect clinically insignificant cancer, whether that could be avoided, detection of proportion of benign biopsy that was done in spite of it, cancers of grade more than 3, and serious adverse effects due to the biopsy, and so forth. Now, this was the trial actual. So we have 49,118 men who were sent mail to invite to participate, of which almost most of them refused to participate. 12,750 provided blood samples and were included in the study, of which 8,442 were excluded due to various reasons, including blood sample problems and so forth. So 4,308 people had PSA more than 1.5, of which 2,008 had PSA less than 3 and a Stockholm score of less than 11. So they will be excluded, obviously, from this trial. 2,300 had PSA more than 3 nanogram per ml and a Stockholm of more than 11. And these are the patients who will be targeted, whether to divide into the 2 subgroups that we are talking about. One will go a randomization, 3:2 ratio, of which 761 were excluded because of having a PSA of less than 3 and Stockholm 3 and re-evaluation. So finally, we had a cohort of 1,532 people, of which they were all having a more than PSA of 3. Now, after reassigning by randomization, we have 928 who were assigned to the experimental biopsy group, and we had 603 who underwent the biopsy straight away trust guided. So these are the numbers that they have given of the 929 who were assigned to the experimental group. They all had their MP MRIs. Various other reasons, there was some attrition. 75 did not have an MRI or a biopsy, had an abnormal MRI but no biopsy, and so forth. There were attrition as noted. So finally, 790 were included in the per protocol analysis. So finally, as a shortened version, this was the final this thing. So this is the final tabulation of all the data that you can see. It is almost comparable, the experimental group as well as the standard biopsy group. Okay, so because of the time constraint, I'll just go on to the explanation of it. So what is the strength of the study? This is the first study to actually investigate the cost effectiveness of the combination of PSA and the Stockholm scoring, as well as the MRI with PSA and MRI alone. Another strength is that the natural history model has been calibrated carefully and good validity for comparison between the screening interventions. In addition, the health state values were comparable to the Swedish protocol. So they were happy with that. However, there was a random selection of patients. There was no history taking before as to what was the UTI, prostatitis, and any other reason of PSA and so many other things. There was no questionnaire for LUTS. What about the expense of MRI? This is a state-sponsored health system, so we are not able to compare it with that. A significant non-acceptance rate, again, which is not explained by the paper as well. Again, there is no norm to consider the lower limit of PSA as 3 nanogram per ml. And there were also multiple levels of lab which was used to test the PSA levels as well. Finally, they concluded is that the MRI with targeted and standard biopsy in men with MRI results suggestive of prostate cancer was non-inferior to the standard biopsy, which was done already in detecting the clinically significant in a population-based setting. Also, it showed that there is a lower detection of clinically insignificant cancer in MRI with targeted and testing. This means that you can, by doing an MRI, avoid clinically insignificant cancers from getting a biopsy done as well. I reviewed a few articles which has come post this paper, and this was one of their own Stockholm-based, where they evaluated the cost effectiveness of this test as well as the MRI. They said the screening strategy were predicted to reduce the cancer prostate deaths by 7 to 9% across a lifetime. According to them, a PSA of more than 2 was supposed to have a better outcome in their cost effectiveness. And the Stockholm 3 strategy was cost effective with a probability of 70% at a cost about 5 million Swedish kronor probably. Now, this is again, I should warn you that this is a state-sponsored this thing. If you see the curves of various 1.5 level, 2 level, and PSA of 3 level, they found the PSA of 2 with the screening test of Stockholm 3, there was a good outcome in the cost effectiveness. Coming to our own review of this paper, this was published in IJU of 2022. Now, they have commented from AIIMS Bhubaneswar that in a developing country like India, where the health insurance is not covered, MRI will surely avoid unnecessary biopsies. However, who is going to bear the cost of the MRI and so forth? In such cases, probably the usage of Stockholm 3 may be useful. Again, the validity of these the screening test in deciding the MRI requirement is still of not much use here. Thank you.
Thank you, Doctor. Thank you, Dr. Srivatsan Ramani, for your presentation. We will have discussion at the end, actually, So we'll invite Dr. Sunil Pasricha to give his talk on an artificial intelligence based support tool for automation and standardization of Gleason grading in prostatic biopsy. Dr. Sunil Pasricha is a senior consultant pathology from Rajiv Gandhi Cancer Institute.
So good afternoon, everybody. It's a pleasure to be here with all of you. And first of all, I would like to thank the organizers for giving me this opportunity. So I'll be talking about discussing this paper, an artificial intelligence-based support tool for automation and standardization of Gleason grading in prostate biopsy, that was published last year in European Urology Focus. So as we are all familiarized that Gleason grading is an important prognostic parameter in prostatic cancer, and it has really stood a test of time, and it is utilized for risk stratification and guides further management. At the same time, it's problematic due to variation in the grading practice and large inter-observer variability, which is attributed to the lack of the trained histopathologist and oncopathologist in urology. So new technologies may aid in standardizing, optimizing, and shortening and refining this diagnostic process. The application of artificial intelligence to the histological images, they have shown a promise in the cancer detection. The initial studies were simple on prostatic carcinoma tissue, and they were aimed at just distinguishing a cancer from a non-cancer region. Recently, the studies on automated Gleason grading have emerged. So the objective of this paper was to develop the algorithm and to evaluate the robustness of the reproducible Gleason grading algorithm trained on annotated prostatic biopsy scans. And importantly, this was the first study to evaluate the reproducibility of the same slide which were scanned on another set of scanner. So this was the study design. Randomly selected prostatic biopsy slides. They were selected from the Skåne University Hospital, Sweden, between this five years period. The scanning and image annotations were done. The training cohort slides, they were scanned on Aspirio CS2 scanner from Leica and digitally annotated by two senior consultant pathologists, P1 and P2. for the group grade. The training cohort in totality, it was comprised of 698 slides derived from 174 patients, while the testing cohort comprised of 37 slides derived from 21 patients, and they were scanned on one more additional slide scanner, that is Hamamatsu. This is the scanner, the same we are using at RGCI RC in Delhi also. And they were annotated again by two pathologists. Now, pathologist 1 repeated the annotations on the same slide after 1 year, that is P1-1 initially, and P1-2, that is after 1 year, by the same pathologist to look for the intra-observer variability also. So this was the workflow for the development of the algorithm. So two different convoluted neural networks, they were actually trained. The first one for the prototype algorithm, which utilized a small network, while the second CNN was for the final algorithm, which has a very prodigious or a very huge network. So in the algorithm training, you have an input layer, which sees the raw data, and then there is an output layer. In between, you have a multiple hidden layers in between. So the neurons in the one layer, it interacts with the specific neurons in the second layer to give a final output. So this was the quantification of the algorithm output, and the pathologist annotations gave the percentage, the Gleason grade 3, 4, 5 on each of the slide. So the benign part was not marked. So whatever pink is seen, you can see is the that's the benign part. So the calculation of performance and statistical analysis was done on the SPSS software, and following parameters were measured. The most important was the intra-class correlation coefficient, ICC, that was used to compare the algorithm performance with that of the pathologist and between the pathologists. The Cohen'S Kappa was used to calculate the agreement that was based on the group grade. Then calculation of the specificity and sensitivity for the detection of cancer or each Gleason pattern was calculated for algorithm versus the pathologist, and agreement index was also calculated between the algorithm and each pathologist at pixel level for each annotation. So this was the result, which has shown the percentage of the cancer detected by the pathologist and the algorithm on both the original scan and the new scan of each biopsy sections, and which shows a very good concordance, which can be seen in more clarity over here. So the percentage of the cancer detected by the algorithm, it's strongly correlated with the amount of cancer detected by the pathologist, with the intra-class correlation coefficient of more than 0.97, as we can see in this blue rectangle. The areas of Gleason pattern 3 and 4 identified by the algorithm, they correlated well with the pathologist interpretation, as seen in this black rectangle. However, for the Gleason grade 5, the algorithm correlated well with the one pathologist, but not with the second pathologist, as can see in the red rectangle. However, the result of algorithm on the images from two different scanners were very similar and concordant, as we can see in this green rectangle. So this was algorithm 1 with the algorithm on scan 2. So the algorithm was highly sensitive in detecting the cancer, and it was 100% sensitive and identifying the correct Gleason pattern, ranging from 80 to 91% depending upon the Gleason grade. The specificity in detecting the cancer was 68%, and for identifying the correct Gleason pattern was 77 to 98%, again depending upon the Gleason grade. Now, algorithm identified cancer areas on 4 out of 13 benign sections, but so these were the false positive, and all the false positive that detected the area was very small, that was less than 1.2%. And these regions were identified by pathologists as a pattern that actually mimicked cancer, like atrophy or adenosis on the biopsy or some other artifacts. So the Cohen'S Kappa was used to calculate the agreement. The highest overall agreement was between the 2 time points of the pathologist 1, between the two pathologists, as well as between the algorithm and the pathologist 2, as seen in this red rectangle. The Cohen'S Kappa actually evaluates the agreement about the presence of cancer and group grade pattern, but it does not take into account whether the cancer was identified in the correct area, pixel by pixel. So to verify this, the author has designed a special feature, and they calculated the agreement index, which actually calculated the correct annotations pixel by pixel. So the agreement was very high for the benign biopsies, as you can see in this green rectangle. However, as the grade increases, the agreement index decreases. So in the group grade 5, we can see that the agreement index has decreased. So that's visible on this figure also. So here, if you can see. So this is the high agreement index. So one can see the color annotations are absolutely similar, while when the low agreement was there, so one can see that the color coding was different. Like for the green, it was for grade 3, for yellow, it was grade 4, and for this is the red is for grade 5. So regarding the discussion and comments, the algorithm trained in the presented study is similar to many others that trained for the same application using a convoluted neural networks. The algorithm is highly sensitive for detecting the cancer, including the stratification into the different Gleason grade patterns. The cancer versus non-cancer areas detected by algorithm were highly correlated with both the pathologists. The algorithm overestimated the cancer presence on several benign biopsy, reducing the specificity. So this was the limitation, the amount of training and the testing data, and also the number of the annotated slides, the samples, particularly with the Gleason pattern 5 were actually less, and it should have been more. So to conclude and the future perspectives, the authors have proposed a sensitive tool to facilitate the diagnostic process in the prostatic carcinoma and holds promise to improve the reproducibility and to reduce the inter-observer as well as intra-observer variability. The clinical applicability of the artificial intelligence algorithm would be best tested on the cohorts with a long-term oncology follow-up, providing the prognostic and predictive information. Thank you.
Thank you, Dr. Sunil. I think we'll go to the next presentation by Dr. Himesh Gandhi, robotic surgeon and consultant uro-oncologist at Ruby Hall Clinic, Pune. This topic is Neurosafe frozen section during RARP, peri-op and histopathological outcomes from the Neurosafe Proof Feasibility RCT.
Good afternoon, everybody, and greetings from Pune, from Ruby Hall. Without wasting much time, I'll start with the presentation. So basically, this Neurosafe protocol has been developed to increase the chance of patients having preservation of the erectile dysfunction after robotic radical prostatectomy, as well as early return of urinary incontinence. So they are planning to conduct a randomized control trial, and before the trial begins, they wanted to conduct a feasibility study. So ideally, in ideal recommendation, this forms as a phase 2 exploration study. So what is the purpose of this study? It was mainly to improve the preservation of neurovascular bundles without having increase in positive surgical margins while preserving the neurovascular bundle. Neurosafe is only technique which is right now available and which is quite established, where they use the intraoperative frozen section analysis for preservation of the neurovascular bundle. What does this mean regarding this study? So it will form a base of for a larger RCT, as well as they can do this study in a multi-center setting after having an established protocol. So like we know that erectile dysfunction is very common, and Neurosafe has been there since quite a time, and started in Martini Clinic in Germany. And since then, multiple different modes have been used for establishing protocols, and this study takes into this consideration, and using intraoperative frozen section analysis, they are trying to establish a protocol. Hello. Mic is not working. So aim is, hello. This is also not. I'm audible, right? So basically, the aim is to have a detailed description of the technique, then how to process the intraoperative frozen section, and what is there any adverse perioperative outcomes while we are doing this technique. So it was like 1-to-1 randomization, and it is a feasibility study. The criteria for inclusion was the patient should have a localized prostate cancer proven on MRI, pre-biopsy MRI settings. There should be no meds and should have a good erectile function. Primary and secondary outcomes were also defined. Ethical committee approval was taken, and written consent of the patient was taken. So this is the pathway. And here you can see that the patient has been randomized into a Neurosafe prostatectomy group and a standard prostatectomy group. Patient had 4 to 5 visits, and the interval of the visits were also given. The exclusion was the patient unfit for the surgery, having overactive bladder because their chance of having urge urinary incontinence was there. Any previous treatment for prostate cancer, any hormonal treatment, and if the disease is more than T3B. And primary outcome was to just check the feasibility of conducting a multicentric RCT. And secondary outcomes was to correlation of the histopathological data with and the perioperative outcomes, so that they can calculate the power of the study for the RCT. So this was the protocol. First visit is the treatment visit, that is they do the RALP, and then subsequently at visit 2, 3, and 4, multiple parameters were checked based on the outcomes which they have defined. The technique involved a standard robotic radical prostatectomy, and once the nose sparing was done, the surgeon has to grade the nose sparing, and subsequently the specimen, which was the prostate specimen, was then delivered out of the body, and then an Alexis port was used, and the rest of the procedure was continued, and the specimen was sent for frozen section analysis. So the surgeon has to stain the specimen inside the theater, and the orientation he has to define. Subsequently, in the lab, the pathologist will take the posterolateral margin of the prostate, and then they will take a 5 mm strip, which will be subsequently put in a cryostamp, and then subsequently a cryostat was used, and the 5 micron sections was taken before they could stain into the histopath analysis. So based on this all technique, the pathologists were able to mention whether the margin was clear, whether it was narrowly clear margin, and whether the patient has a positive margin. So these are the specimens, how it looked on the histopathological examination. So final conclusion was, whenever the patient has a negative margin, you don't need to do any resection of the remaining neurovascular bundle. When the patient has a positive margin, then whether the patient positive margin is only in one section or there are more than one section, whether the length is less than 2 mm or it is more than 2 mm length, and any adverse features are there or not. That is the multiple positive margins. In those case scenario, where there was a positive margins and multicentric, full secondary resection of the neurovascular bundle is to be done. So this was the protocol which was established, and whether to do a partial secondary resection or a full secondary resection, that decision was taken by the operating surgeon once he gets back the intraoperative frozen section report. So in both the groups, there was no significant variation in terms of the MRI stage, the number of lymph node performed, the final grading. However, the operating time was quite different, where it was increased by 1 hour in the Neurosafe group, and this was quite significant. The incidence of complications graded by the Clement-Dindo was almost the same in both the groups. So when this concordance was checked between the intraoperative frozen section and when the final pathology, we could see that the sensitivity was reaching 100%, specificity was 98.7, positive predictive value was almost 97, and negative predictive value was 100%. So this has a significant impact. So whatever you are detecting in an intraoperative frozen section, the final pathology will also show the same thing. So this is a quite significant finding, and this forms the basis for a randomized control trial where intraoperatively a surgeon can take a decision. These are the things which total out of 49 patients, one patient was couldn't continue the trial. So out of 49 patients, 11 patients had a positive surgical margins, and then secondary resection was performed, and then subsequently those patients had a biochemical recurrence when they were followed up after 1 year in the patients who had positive margins. So here we the data clearly shows that the intraoperative frozen section and final histopath has a great sensitivity and specificity, and the indication what came out from this was like a patient having multiple sections on positive surgical margins, and if the positive surgical margin is more than 2 mm. However, there is some limitation of this study, and the limitation was that in this study the histological grade was not mentioned. So if we see the positive margin, if it is less than if it is less than or equal to grade 3, means it's grade 3, then you don't need to do a secondary resection. However, when the positive margin has grade 4, then you need to do a secondary resection. So this was the take home from this study, and thus it shows that a randomized RCT is possible, power can be calculated, concordance is good, so it can be a determining factor for further long-term trials. And there is no harm to the patient when the OR time is increased, and it is a developmental tool for further RCTs. Thank you.
Thank you, Himesh, for your presentation. We may request Dr. Saurabh Patil to give his presentation on does prior transurethral resection of prostate affect the functional and oncological outcomes of robot-assisted radical prostatectomy, a matched pair analysis. Dr. Saurabh, please.
Thank you, sir. Good afternoon, respected chairpersons, all seniors and my dear colleagues. Am I audible? Okay, so the topic I'm presenting today is the effect of prior prostate surgery on the functional and oncological outcomes of radical prostatectomy. Sorry. So we all know that the diagnosis of this prostate cancer has shown an upward trend in last few years, thanks to the widespread adoption of opportunistic screening of by PSA and the awareness amongst general public. And with that, we are able to diagnose this cancer at an quite early stage and offer patients curative treatment in form of radical prostatectomy and radiation therapy. Again, with the advent of surgical robots, more and more cases are being performed by minimal invasive technique by robotic approach, and more and more surgeons is getting comfortable operating this complex surgery. But whatever advantage this robot is giving to us, there are few scenarios in which we definitely consider or think twice before contemplating this surgery. One of such scenario is prior prostatectomy or prior prostatic surgeries. Most commonly encountered in our clinical practice is prior transurethral resection of prostate. It gives a significant challenge secondary to extravasation of fluid, capsular perforation, which causes the dense periprostatic adhesions and altered tissue planes. It causes distorted inelastic bladder, neck, and friable urethral stump, which causes difficulty in anastomosis. And because of that, we have to consider a few challenges during this surgery, and accordingly, we need to counsel the patient about the perioperative, postoperative, and the final outcomes. There are few studies discussed in the literature. However, the level is low, and almost all of them are retrospective. Number is low, and there are only 3 studies in Indian scenarios which have been discussed. I'm discussing one of those Indian study performed by Dr. Gagan Gautam et al. With a matched pair analysis. So basically, this is a retrospective study, retrospective analysis of prospectively maintained database of around 640 patients who underwent radical prostatectomy last 8 years by a single surgeon. That was 2:1 propensity score matching was done and compared with TURP against without TURP. Men with other forms of ablative surgeries like laser, TULEP, HOLEP, UroLift, RESM, radiation therapy were excluded from this surgery. So only transurethral resection of prostate surgeries were included. Post-operative continence was defined as the use of no pad, 0 pad, or 1 septic pad per day. Follow-up was at 1, 3, 6, 9, and 12 months. In results, 72 men without previous prior TURP again were matched with 36 2:1 ratio, 36 prior TURP patients. Baseline parameters, age, BMI, risk stratification, Gleason grade were comparable. Mean age was 67 years. More than 50% were into DMECO high-risk population. The median follow-up was around 1 year. So the significant findings which author found were the requirement of bladder neck reconstruction, which was almost twice in the TURP prior TURP group compared to non-TURP group, which was statistically significant, and the median duration of catheter was longer in cases of TURP group compared to non-TURP group. There are a few other findings like estimated blood loss and positive surgical margin and biochemical recurrence, which was higher in prior TURP group. However, that was not clinically significant, and no patient required any blood transfusion in the perioperative period. Post-operative complications were similar. The continence rates at 1, 3, 6, 12 months in TURP against non-TURP group were almost comparable. No patient had anastomotic stricture. Overall, only 3 male had sexually active previously, so they did not take potency into the comparison. However, on multivariate analysis, this prior TURP was not associated with any higher risk of biochemical recurrence, significant margins, or incontinence after radical prostatectomy. So in discussion, there are limited studies available, especially in our Indian scenario. There are almost all our retrospectives assessed. There are 2 Indian studies, one by Gupta sir himself, who compared the 26 TURP patients again 132 non-TURP in 2011. However, they found almost all the parameters against robotic surgery, almost everything like blood loss, conversion rate, bladder neck reconstruction, biochemical recurrence, anastomosis, stricture, and incontinence were higher in prior TURP group. Recently, AIMS group published one study in 2022, who also found that continence rate, operative time, and blood loss were higher in prior TURP group. However, oncological outcome, that means positive surgical margin and biochemical recurrence, and potency rates were comparable. So these are the outcomes in multiple studies. These are the variable results. Most important factors for surgeon to consider in practice are, we have to consider this a challenging scenario, whatever said and done. We have to expect the longer operative time, higher blood loss, difficulty in dissection, especially posterior dissection, nerve sparing, bladder neck dissection, higher need for bladder neck reconstruction, higher rates of positive surgical margins and recurrence, longer catheter time, and continence recovery. And accordingly, we need to counsel the patient about this surgery. There are a few limitations. I'll just go through it first. And then the authors concluded that the RARP, or radical prostatectomy, after prior TURP is a safe in experienced hands. Post-TURP may experience similar oncological and functional outcomes, and overall outcome in post-TURP scenario is improving with advent of robotic system and increasing in the surgical experience. However, though this paper gives a good insight on the feasibility and safety, especially in Indian patients, for each patient, we need to individualize this treatment, and we need to look into our own data before finalizing or committing any results. So though robot offer a good tool for us to operate, we need to consider that this TURP setting is really challenging. We need to anticipate that the operative time, blood loss may be higher. There must be difficult dissection in the periprostatic dissection and nerve sparing. We need to have a higher risk of bladder neck reconstruction. And accordingly, we need to plan and counsel the patients about the functional and long-term oncological outcome, so that they should have realistic expectation after this surgery. Thank you.
Thank you, Dr. Patil. We now go to the next lecture, next paper presentation, that is by Dr. Indranil Banerjee from Apollo Clinicals Hospital, Calcutta. Preservation of endopelvic fascia, effects on postoperative incontinence and sexual function, a randomized clinical trial. Dr. Banerjee.
Good afternoon, everyone. It's a privilege to be here today, and thank you, organizer, for the kind invitation. There's a lot of buzz going on about the endopelvic fascia preserving robotic radical prostatectomy. Now we have a level 1 data, whether it works or not in terms of continence outcome or sexual function outcome. It's not where this one. कौन सा दे दो कौन सा है ये हाँ ये okay, sorry about this. So this technique was first done by Dr. Coelho from Brazil in 5 years back in August, as in the form of a case report. The basic concept about is the pubo-vesical ligaments or the pubo-prostatic ligament with the endopelvic fascia supports the external urethral sphincter. And dorsal venous complex and along with small arteries running through the plexus have accessory blood supply to the striatus sphincter. And if we preserve this anterior detrusor apron, we will preserve these nerves and vessels. There are data about prospective study of the same group, Rafael Coelho, that about 300 patients, the continuous outcomes were excellent at 1 and 3 months, 83%, 91%, and the margin positivity was only 6%. And recently, Dr. Ash Tiwari group has published the Hood technique on the same cost, based on the same concept, having excellent outcome. The objective of this randomized study to compare whether these two techniques have any difference in terms of continuous outcome and sexual function at 3, 6, and 12 months from surgery. It is a randomized 2-arm phase 3 trial and single institution based, which was based in Finland. It is a university hospital. The power calculation was done based on a previous study by Cohen et al. Published in Scandinavian Journal, based upon the continence results, and it was found that 80% per group will be adequate. This is the consort diagram. The patients were eligible, only a T1, T2 patient, localized prostate cancer, up to Gleason grade group 3 were included. And who were excluded? All the T3 patients, previous prostate surgery, radiation, hormone therapy, planned lymphadenectomy patients, and who didn't want to participate in the study. Mind you, all the patients didn't have the MRI pre-op, only 40 or 50% patient had MRI. And of the 158 patients, 78 had endopelvic fascia preserving RALF and 80 patients had standard RALF. Primary endpoint was urinary incontinence sexual functions 12 months after robotic prostatectomy, and it was measured by APIX 26 short form at 3, 6, and 12 months. Broadly, there were no significant difference in both arms. But let's dive a little deep and find out the baseline characteristics. If you look at the comorbidities in the both groups, a few patients have neurological diseases in endopelvic fascia preserving group. Few patients were on dutasteride or finasteride. And also few patients, more patients in the fascia preserving group were on aspirin. Now about the surgical outcome results, if you see the T3A patients were excluded from the study, but we didn't have any MRI in the study pre-op. So around 40% patients in both arms were T3A or higher. If you see the margin positivity is around 30%, which is much higher than the Coelho study of 6% of margin positivity in this kind of surgeries. Again, if you see the both arms in terms of blood loss, although not statistically significant, the endopelvic fascia preserving group had less blood loss, but they used more hemostatics in endopelvic fascia preserving group. Compared with the urinary outcome, there was no statistically significant differences in the EPIC scores. But if you see the baseline values, the preserved group has more EPIC score, and which was statistically significantly more as compared to the control group. And if you see the urinary outcome, the patient who never or completely continued at 3 months was a slightly higher, although not statistically significant at 3 months and 6 months. Now coming to the sexual function, again, no difference in the EPIC scores, but EPIC score is just a score. Let's see what's the clinical findings. Firm enough for intercourse. If you see the endopelvic fascia preserving slightly better at 6 months and 12 months as compared to the standard. So the strength of the study is a first randomized study in this setting, and it's a single surgeon, so less chance of bias. But if you see the drawbacks of these studies, there was a baseline urinary problems were more in standard group as compared to the endopelvic fascia preserving group. The power was calculated based on the continence data of previous study. That was a retrospective study and not on sexual functional data. MRI prostate was not done, and hence in endopelvic fascia preserving, most of the group has mentioned that the anterior tumor should be excluded, which was not there. Maybe that is the reason for margin positivity. And in all the patients of standard group, the puboposterior ligaments were divided. So the standard definition also varies from different studies. Usually it is not divided in standard robotic radical prostatectomy, even if you divide the endopelvic fascia. And it was a subjective assessment of the urinary continence. Objective assessment was not done, like pad test, how many pads the patients are using. So just a score doesn't give you any idea. And also learning curve effect, this was published by Dr. Tamankar et al. About you need 80 cases a year or maybe 300 cases for robotic prostatectomy to achieve a level so that you can do a job properly. Here, the surgeon perform only 50 cases of endopelvic fissure preserving surgery before doing these procedures. And they have used the S robot. Maybe they're using the XI robot to decrease the surgical duration. It has already been proven in previous studies, and quality control was not there. When the surgery was done by the surgeon, whether the endopelvic fissure was properly preserved or not. So quality control from a different surgeon or a third party was not done in this paper. And no mention about the oncological outcome. So to conclude that we have a phase 1 data in this space now, but still we need more randomized trial that will compare the radius sparing approach versus the endopelvic fissure preserving approach, because we know the radius sparing approach has better continence and sexual function. Thank you.
Thank you, Dr. Indranil. We now move on to the next presentation by Dr. Sandeep Batra on randomized phase 2 trial of neoadjuvant abiraterone plus and minus cabazitaxel in high-risk prostate cancer. And he's the Director of Medical Oncology, Max Super Specialty Hospital, New Delhi. Dr. Batra, please.
Yeah, good afternoon, everyone. Thank you, Chair, and thank you, organizers. This is a short and sweet study, the way my presentation is going to be. However, this was inspired from another trial in a metastatic castration-resistant setting, which is still enrolling patients, and had they had waited for the result of that trial, probably this trial would not have been done. How to go forward in this? Sir, can you, which button? Green one. Thank you. Okay, so this was a phase 2 trial, which was neoadjuvant therapy prior to radical prostatectomy in high-risk prostate cancer. Till date, preoperative neoadjuvant androgen deprivation therapy, although it has proven pathological results in high-risk locally advanced prostate cancers by decreasing the margin positivity, but still has not proven oncological benefit by reducing the by increasing the overall survival or the relapse-free survival. So this particular study was investigational use of abiraterone acetate, which is a newer anti-hormonal therapy, prednisolone and leprolide, totally combined as androgen deprivation therapy, with or without cabazitaxel prior to radical prostatectomy in high-risk patients. The dose used of the drugs was standard. The cabazitaxel was used on a lower dose, 20 milligram per meter square, which usually as a standalone dose is 25 milligram per meter square, 3 weekly. And this combination was given for 6 months prior to surgery in both the groups. One with the ADT plus abiraterone, one was ADT plus abiraterone plus cabazitaxel. So 2 groups. The primary endpoint was rate of pathological complete response. In other solid tumors, pathological CRs have been correlated with improved survival outcomes, but has not been proven in the prostate cancer. So pathological complete response rates and minimal residual disease, these were the primary endpoints. And MRD for this trial was defined as less than 5% of the prostate volume involved by tumor. The authors presented surgical pathological outcomes, safety signals, and early biochemical response data. So this was the schema. Arm A was with cabazitaxel, arm B was without cabazitaxel. Both the group received the treatment, active treatment for 6 months, followed by surgery, and then the pathological assessment was done. In total, there were 77 randomized patients, of which 70 were able to complete the treatment and they were included for analysis. Baseline characteristics were almost similar with the mean PSA of 37, with one standard deviation of 51. 63% of patients had a high Gleason score between 8 to 10. So out of these 70 patients, in total 31, that is 44% patients achieved either CR or minimal residual disease, of which 43% were in the arm A, that is the active arm, cabazitaxel group, 45% with the abiraterone alone, that is no cabazitaxel. So almost similar, rather the one with the cabazitaxel had a lower percentage. 5 men had a pathological complete response, 2 in the cabazitaxel plus arm, 3 in the cabazitaxel minus arm. So again, abiraterone fared better. 26 men had evidence of minimal residual disease with 15 in arm A. So probably 3-drug combo helped in decreasing the tumor bulk and necrosis, increase in necrosis. 11 in the arm B. P-value was not significant at 1, so there was no significant difference. In terms of biochemical free survival, the authors found no difference between the treatment groups, and patients who achieved a CR or MRD experienced longer biochemical free survival. That was something expected based on data from other solid tumors. And these were the survival curves. And if you see, not survival curves, the response rates, so almost similar. So there was no significant difference between the arm A and B. So based on this, they concluded that there was a significant tumor response with intense neoadjuvant therapy, but it was same whether you added cabazitaxel or not. So effectively, it was a negative trial. There was no use of addition of cabazitaxel to simple ADT with abiraterone. So I will conclude this short trial with this by saying that even though theoretically it looks very appealing to combine everything at one go to improve the results, but ultimately if we increase the toxicity, the financial as well as the real toxicity patient, and do not improve the survival outcomes, that doesn't do a good thing to the patient. So with this, I will end this paper. Thank you. Thank you, chairs.
Thank you so much, Dr. Sandeep. I think we proceed with the panel discussion. So following this, there will be a panel which is being moderated by Dr. Amandeep Arora, who is a consultant and a fellow at Tata Memorial Hospital Department of Uro-Oncology. The panelists are Dr. Amitabh Singh from Rajiv Gandhi Cancer Institute, Dr. Gagan Saini, Director of Radiation Oncology at Max Super Speciality, Delhi NCR, Dr. Sandeep Batra, who is already on the stage and just had the talk, Dr. Saurabh Vashisht, Consultant, Department of Urology, Renal Transplant at Manipal Hospitals, Bangalore, Dr. Sunil Pasricha, Senior Consultant, Department of Pathology, RGCI, and Dr. Rajesh Pasricha, Professor and Head, Radiation Oncology, AIIMS Bhopal.
Pointer or some point. Very good afternoon to everyone. I'm Amandeep from Tata Hospital. I'm delighted that I've been given this opportunity to conduct this panel discussion, and we'll just begin now. It's on the recent papers that have just been presented right now. Yeah, so on the panel today, I have an eminent panel. I think Dr. Amitabh Singh is not here, but we have Dr. Saurabh Vashisht from Bangalore. We have Dr. Gagan Saini, Dr. Rajesh Pasricha, Dr. Sunil Pasricha, and Dr. Sandeep Batra. So we have people from the entire spectrum of uro-oncology here today. So we'll come to the first paper that was presented. Just to recap the paper in one slide. So we know that that big European trial showed that prostate cancer mortality is reduced with organized screening. However, that screening comes with high rates of overdiagnosis and overtreatment, and that is why it is not routinely implemented worldwide. So this paper actually tried to reduce the side effects of routine screening by using an MRI-based approach, which has previously been shown by the Precision and the Promise trials. So they invited men, they did their PSA more than 3, they randomized them to either undergo an MRI and then a biopsy, or a biopsy straight away. So what they found was that the MRI-based approach was non-inferior to detect significant cancer, which is good. It detected less insignificant cancers, much better. And 60% of patients avoided the biopsy as the MRI was negative. So it was really good. Now, is this applicable to our setting? So coming to screening in India, sir, I would just want to ask you, I would take this to Dr. Vasishta. You have a 60-year-old male. Would you ask for a PSA in the following settings? He has lower urinary tract symptoms. Can we have a mic there?
So before going only for the lower urinary tract symptoms, I will also like to consider the digital rectal examination finding.
Right.
And along with that, the family history of cancer prostate.
Correct, sir.
So in this scenario, with the LUTs, we may like to have. However, not only for the purpose of cancer prostate, but definitely there are certain situations where either LUTs is a manifestation of chronic prostatitis,
correct,
or it can be the cause of the chronic prostatitis, I may like to have PSA, but not with the intent of diagnosing CA
Okay,
prostate.
so
or
here the
screening.
intent is not to pick up the cancer.
No, that is
Okay,
intent.
that is one of the intents. That is
Intent,
one of the
but
intents. to pick
should
up the
not be
cancer.
the only intent.
Not the only intent. Okay. Now, would you do it if that patient has just come to you with a 1 centimeter renal calculus, does not come to you with LUTs?
So again, if the examination findings are normal and no family history of CA prostate, I don't think so.
So would you do a DRE in a patient
Yes,
of 1
everybody.
centimeter?
If you are not putting your finger there, your head will be inside.
So a patient who does not have LUTs but has just walked into your clinic with a 1 centimeter renal calculus, just because he's 60 years old, you would do a DRE in him?
In every patient who is coming to us, we should do the DRE.
Okay. Would you do it? Would you do a PSA for your relative at home with no medical complaints who's 60 years old?
No, I don't think so. But they will definitely going to have.
Okay. Sir, please.
See, we have to take the history of the patient plus whether he has got a PSA done or not. So the practice, what we are following now, any man above the age of 50 years, at least he should have one PSA done.
Okay.
So that is the standard practice.
Right. So this is more than opportunistic screening.
Yes, a
Right.
little bit
Okay.
more than opportunistic.
Yeah.
So that is our current practice, what he said,
Mhm.
that anybody coming to our clinic and he's 60-year-old, I certainly like to have at least one PSA.
One PSA.
According to the value of that PSA, we will decide what is to be done next, when he should repeat, maybe after 5 years, 2 years, or yearly, whatsoever it is,
Mhm.
So that one value is necessary.
Okay, so you want to set a baseline value for the patient who has come to you. Okay,
And I think it is more also correct if the gland size is more and we are planning to add dutasteride in the coming future time only for the BPH point of view, then also we require
Okay,
it.
so apart from the cancer, there are multiple things which have made you do the PSA in him. Great. Okay. So significant family history we've spoken of. Now, so if you want to ask for the PSA, we have heard this word shared decision making. Hello, sir. We've heard this word shared decision making. So what is this shared decision making? What do you tell your patient? What do you inform them? And what are their inputs in that decision making? Or are they like, sir, aapko jo theek lagta hai, so we can do the PSA if you wish so?
Okay, so in shared decision making, we need to discuss first of thing ki if we'll get PSA, then there are chances that you might have a high PSA. Then probably you will end up in getting trust biopsy or MR fusion biopsy, whatever, depending on the MRI biopsy report. So ultimately, there are chances that you will get diagnosed with the clinically insignificant cancer also, like 3+3. So depending on that, there are multiple options whether you will be put on this active surveillance or radical treatments, whatever. So now, if he got diagnosed with the clinically insignificant prostate cancer, so it may add to his anxiety also.
Right.
So it all depends on his psyche also, how he takes the disease status and how he understand it well or not. So depending on his psychological status, social background and everything. So that's why I think it's very important to discuss before getting PSA to the patient and their family.
Exactly.
So these are the aspects of getting PSA done.
Okay, great. Thank you so much. So now we've asked for a PSA. We discussed about the DRE. So we have the answers to these questions. We would do them for probably all these patients, but not for our relative at home. Okay. Now, when would you do the DRE? Would you do it at the time of asking for the PSA? And if later, then would you omit the DRE if the PSA comes back as less than 4? Or are they both complementary?
No, in my practice, I do DRE in all the patient in my first visit.
Okay.
And depending upon the DRE findings and the clinical picture and the family history, and if I looking forward that the gland size is more and I will definitely going to require a combination therapy, I will definitely ask PSA. So there is no question of omitting DRE in any scenario.
All right. Thank you so much. Now coming to screening in India. Now this is one recent consensus paper published just recently last month. And it is kind of, the Indian counterpart of APCCC, where it was an expert survey about different management options. And the panelists were asked about, what is their preferred modality of screening that should be recommended for India. And as you can see there, 76% people said that it should be opportunistic screening, where individual case finding is done by the physician as and when deemed correct. Now the PSA is 7.5. Sir, what would you want to do next?
Let me say one thing. If you look at the cancer registry data, prostate is climbing very fast, and now in most of the cancer registry in India, it is 2 or 3.
Yes, sir.
So I think we need to change our mindset. And of course, he may be right in his practice, but what Dr. Gupta said, that at least one PSA baseline for all the patients who are coming should be done, especially if they are over 60.
Right. So a little more than opportunistic screening, but still not a routine screening for the entire population.
Yes.
Okay. Yeah. So now what do you do with the PSA 7.5 in the clinic?
Okay, so actually, if the
So he has no
options-
other contributory family history or something. He's just
Okay.
a patient with a PSA 7.5.
So what are his lower urinary tract symptom? Basically, they are obstructive or they are irritative.
Mhm.
So if like suppose these lower urinary tract symptoms are very irritative, mostly,
Right.
then probably you might consider getting urine routine microscopy at least.
Okay.
At least.
Okay.
So if you'll see the reports, so they are saying if PSA is like between 4 to 10 and he's having irritative lower urinary tract symptom, and if like urine routine microscopy is showing pus cells,
Mhm.
then although it is always better to have a express prostatic secretion or like 3
Okay.
after prostatic expression secretion, you get the urine culture from the voided volume after prostatic massage. So
Okay.
if like they are showing there is a positive infection, then probably you can start first of all antibiotics in those patients.
Mhm.
But there are a lot of patients who doesn't present with the acute prostatitis.
Yeah.
They are having incumbent or like incipient this chronic prostatitis as well.
So if it is just a 7.5 picked up on a routine health checkup done for someone.
So I think MRI is very good investigation right now. So
Right.
because it can tell you about the chances of having prostate malignancy. Depending on that, you can counsel him getting a biopsy,
Correct.
either trust biopsy or MR fusion biopsy,
Right.
and it can give you a guide about whether he is having chronic prostatitis as well.
Right.
Apart from the.
Yes, completely agree. Yeah.
I will like to differ with Amitabh in this, because only symptoms we can't rely upon, because sometimes like if the patient is, even though if they are not having any symptoms, and if you just evaluate them, you find that there is straining pattern of the uroflow or prolonged voiding or high PVR or the bladder wall thickness, they are also the indirect evidences that patient is already having this. So in this scenario, rather than jumping from direct MRI, which can again give you a fallacious report and will going to create a confusion, it is always better to treat the patient first, get a repeat PSA done after 4 to 6 weeks, and then accordingly you decide. Because we have seen so many times that with the single PSA, patient has got the MRI done and they reported that it's a suggestive of pyrite 4 and 5, and the patient come to us for the biopsy, and when we counsel them, no, wait for the biopsy, you don't require it, so they become panic.
Okay.
That how you can ask
So
us
if you have symptoms, you would treat the symptoms, then repeat the PSA.
even if there is no symptoms, but the findings are suggestive of straining pattern and all those things.
Okay.
Because symptoms are totally depending. It's a subjective phenomenon. You
Okay.
can't objectify the symptoms.
Right. Sir, you have a comment.
No, I like to tell, just to complete the topic, one single PSA has got no meaning. So after that PSA, you get a urine test. If infection, you can give by course of antibiotic, repeat the PSA, maybe 4 weeks, 6 weeks, whatever duration you want. Anyway, subsequent PSA is also high.
Right.
Then you must counsel the patient. The consequences of doing the PSA should have been told earlier. Now, if you are going for MRI, he should be mentally ready that what to do after the MRI.
Agree.
So he should be ready with biopsy and all that.
Okay.
One more point. So I partially agree with sir's statement, because there are various reports, like if there is a patient who is having a high PSA, and if you start him on the antibiotic and anti-inflammatory medications, so you may get a decrease in PSA level, but still there are chances of having positive malignancy in the prostate. So you can't rely on this decrease in PSA after starting antibiotic and anti-inflammatory. So that's why it is always just to see whether express prostate secretion is positive, or voiding this voided urine after prostatic secretion is positive or not for the urine infection or not.
Okay.
If there is no definite evidence of urine tract infection, then I think MRI is very good investigation. So it can tell you very obviously whether he is having a suspicious malignancy or not, or whether he is having chronic prostatitis as well.
Okay.
I will like to add one point. I think the MRI has come to the light only with this intention to avoid unnecessary biopsies.
Yes.
And if we are not actually utilizing that thing, because by this, again, we are going to land, then what is the role of MRI?
Okay.
Because with every high PSA is a surrogate marker for the cancer health. So if there is an infection, if there is an inflammation, if there is a malignancy, it will going to have some of the abnormal findings. And if we have to direct decision of the biopsy only on the basis of MRI findings, then there is no role of doing even any PSA. Why not to get a MRI of every patient?
Yes, sir.
No, I like to add what Amitabh has said, that after your antibiotic, even if PSA has come down, but not come down less than 4, that is the cutoff point what we follow in India. So if somebody has remained 5 or 5.5, then certainly we have to counsel him that he need a further investigation by MRI and biopsy.
Okay, sir. So this question was asked in that consensus paper. And as you can see, 61% said that they would repeat the PSA. but a fair enough 20% still said that they would go ahead with the MRI with this one single PSA. So now what does this study bring to light? So we already have evidence for doing a MRI prior to biopsy with these 4 trials. Now what did this study say was that the study population of this study was at a lower risk of cancer compared to the above trials. So the median PSA in this study was just 4.3. And so even in screen detected raised PSA, which is lower than the opportunistic screening PSA, an MRI before biopsy helps. And you can avoid a biopsy in a considerable proportion of patients and mitigate the adverse effects of screening. Now, does it change practice here? Not really, because we have been performing MRI for our patients with raised PSA prior to the biopsy. Routine screening is not practiced in our country. We base our biopsy decisions on PSA, DRE, and MRI mostly. And if we are still equivocal about things, these are the other things that we look at: family history, age, PSA density, free PSA, and maybe some biomarkers which are coming in right now. These are our co-primary endpoints, if you might call them. You want to avoid missing clinically significant cancer and at the same time avoid detection of insignificant cancer. And our shared decision making has to happen at the time of prescribing the PSA and not while deciding for the biopsy. The biopsy decision is by the doctor. The decision to do the PSA or not is a shared one between the patient and the doctor. And if a patient has been counseled well, if his biopsy comes back as 3+3, he should rather be relieved rather than being worried. So we've taken around 15 minutes for this paper. We'll move on to the next one. So just to recap it again fast, so the most important aspect of prostate cancer biopsy report is the Gleason grade. Inter-observer variation exists, lack of trained pathologists is there are delays in reporting. So artificial intelligence came to the rescue. The authors trained the algorithm with some biopsy sections. They tested them and they found that it has sensitivity of 100%, which means that it is not missing cancer. It has specificity of 68%, which means that some benign cases may be labeled as cancer by the algorithm. Accuracy of Gleason's grade was pretty good. Now, to the clinicians here, are we, to the first to the pathologist, is the pathologist comfortable with issuing such a report? Is the algorithm replacing you or supplementing you?
So as of now, there is no cogent evidence, to say that algorithm can replace, because as we have seen here, of the specificity is really not up to the mark.
Yes, sir.
So sensitivity as it is concerned, so even a PSA is a good sensitive tool, but the same problem is that it has a compromised specificity.
Correct.
So as of now, there is no, it can, at this time, it can augment, or it can, the artificial intelligence can augment the human brain.
But it cannot replace
But it cannot replace.
Not right at the moment. Okay. Now, is the clinician comfortable with treating a patient based on such a report, or would you want your pathology colleague to have a look at the slides in spite of whatever the report might say?
I don't think based upon one study, and that too was supervised learning, where the pathologists already mark the area and then they are training the algorithm. So means artificial intelligence is all about the big data. 174 patient is not a big data, especially when you're looking at the patient which are positive, they are still lesser. So I will not at all, looking at this report, I will not at all comfortable, and because it's still there's lot of things to be done. It's a long way to go. But yes, being a scientific person, we should be aware of things which are going on. But right now, straight answer is no.
Great. Okay. So is the patient going to be comfortable? Time will tell. Now, these are some upsides of having this. Sir, if you could just comment on them. It would streamline workflow in a busy center because it does not miss cancer. So all your biopsy benign slides are screened out by that algorithm.
No harm. We can subject these slides for if there is algorithm is there, so at least it can flag the slides which needs to be introspected thoroughly.
Yes,
but definitely the artificial intelligence, that is a problem, because the algorithm will give the decision what it has been fed and how it has been trained, but it cannot take into account what the human brain takes the issues, like the intuitions, the judgmental call that you have to take in a relevant clinical context. So that AI will not take.
All right. So it would definitely ensure quicker delivery of reports if you're completely relying on it.
Definitely.
It might, eliminate a second opinion if you have validated the algorithm and somebody in a tier 2 city wants to, run his samples through that algorithm. And it would be helpful in non-high volume centers. Now, the downsides are the cost of the algorithm, the cost of digitizing the images, because these are very high intensity images, as you said.
Digitizing the image is not it's a one-time investment. Like we have that Hamamatsu scanner that has been used in this study also.
Okay.
So that can scan 210 slides. So it's an initial, it's the initial investment, not that the running cost is not there for digitizing the slides.
Okay. Are future pathologists' jobs at stake?
we'll cross the bridge when it comes, but as of now, there is no evidence that that it can replace the.
So what I would want to tell you is such a report is available as of now in our country today. It is available by this particular lab. I'm not sure of what the cost is. And this is how they are marketing it. It eliminates the need of a second opinion for prostate cancer with the power of artificial intelligence. Yeah, so it eliminates a second opinion. So that is the first opinion, and they're saying that is the opinion. So how does it change practice here? It does not change it today. It may change it in the future. Various algorithms might become available in the market, and there will be competition and cost. Will mostly matter in certain scenarios where, you know, it is a decision of whether you treat or not. If the AI says Gleason 4+4, it does not matter, you know, whether you're going to treat or not. You are going to treat that patient. But if the AI says it's picked up 3+3 in one core, I would definitely want my pathologist to have a look and confirm whether that is the quantum of disease that we're dealing with or not.
Yes, because in the study also I have alluded this point that like focus like adenosis or even
Yes.
atrophic glands. So
Yes.
we have to many times subject the sections to the immunohistochemistry. We demonstrate the loss of the basal cells and we stain for AMACAR.
Right.
So even on morphology, we cannot be many times sure. So we take some supplementary ancillary study for
Right.
that.
So the introduction of the paper said that they don't have enough trained histopathologists. So if you don't have enough trained people, should you invest in solving the problem and training more people, or you just obviate the problem itself by, you know, hiring a robot? So in the future, Gleason will be given by the AI, Pirates will be given by AI, PSMA report will be given by AI. I just hope the surgery is not done, you know, without the surgeons.
I just want to know one question. In such scenario, what will be the legal implication of those
Exactly.
reports?
Yeah. So
who will going to take the responsibility? Because you will definitely say that
that report will definitely be signed by an oncopathologist. I think it will be the responsibility of that person.
So that's what I said. So then what is the fun? Again, he is spending the same time because
it is probably reducing the time that that person has taken to go through those slides.
No, but then in that condition, he has to again invest the same time because he want to save his skin. He don't want to miss any cancer significant.
So the thing is that if you have 12 slides to read and the AI has told you 5+5 in one slide, and if he checks only that one slide, he does not have to check the other slides. It is probably saving out some time, but not completely replacing his work.
Any one of us will like to have treatment on the basis of
completely
pathology
report.
report.
See,
given by AI.
Saurabh, science is going to progress, so we should accept that. We should have the knowledge that this technology is also available. But question, even that private sector which is announced, so they are for second opinion. So it is very clear that sometime when a patient comes to us with outside slide, we also take second opinion from our pathologists. So in similar way, we can, if there is any doubt, we can say go for AI reporting also. That's all, nothing else.
We can just augment the diagnostic work.
Mhm. Right. So we'll move on to the next one. It was about preserving the endopelvic fascia. Yeah, 15 minutes. Yeah. So preservation of endopelvic fascia in a radical prostatectomy. So it has been said that you preserve the fascia and improve continence and erectile outcomes, but it was all non-randomized data. So these authors did an RCT. They compared patients, they preserved endopelvic fascia in one group, and they found that there is no difference in continence outcomes at any time point, no difference in sexual outcomes at any time point. This was the gist of the paper. Now, what the procedure actually is, now we've been taught that we need to incise the endopelvic fascia to reach the prostate. If you see the solid black line, that is what is the traditional teaching of cutting the endopelvic fascia. But these people are saying that you have something called as the fascia levator ani, which you keep on the levator muscle, and you keep the lateral prostatic fascia on the prostate, and you go in between those two fascia. So you do not bear the levator muscle. So this is an open dissection where you can see that the dotted arrow is the fascia over the levator ani, and the solid arrow is the fascia over the prostate. Now there is no blood here because this is a cadaver. This area can get really messy, especially in open surgery. That is how it should look according to the authors. A fascia is preserved over the levator ani. So they say that you incise over the blue lines and not over the red lines. If you incise over the red lines, the levator ani gets bared as shown in the left image. If you incise over the blue lines, fascia is preserved over the levator ani. So some nerves fibers are preserved and contributes to better continence. Now, in this paper, all patients for Gleason 6 or 7, they did a full bilateral nerve sparing in 80%. None of the patients underwent non-nerve sparing surgery. So they already preserved the nerve pedicles where the nerves are in bulk. I do not know what was the added outcome of preserving a few nerve fibers over the levator ani. And 33% margin positivity in spite of having almost all organ confined Gleason 6 and 7 patients. Now, sir, what do you use this technique, and what techniques do you employ in your practice when you are trying to augment the continence outcomes for our patients? Just a quick word on these. Yeah.
So to be in short, we are using Redges sparing
Mhm.
to provide him better continence.
Right.
And if patient is like eligible for neurosparing also, then we go for the neurosparing.
Okay. And about this particular technique, do you think if you cut too medially, there is a chance of causing more bleeding because of those dilated veins that are present over the lateral surface of the prostate?
Yes, definitely.
Yeah. Okay. And can this be replicated in open surgery where you find that thin fascia and keep it over the levator? Sometimes, these two fascia are kind of fused
I think
over the prostate
difficult
and
because of
yeah.
the loss of magnification.
Okay. All right. Yes.
We are doing robotic radical prostatectomy last 15 years. And I have heard a lot of debates about this fascia preservation, 3 types of fascia, interfacial, intrafacial, and fascia excision. So these are all terminologies which are go on changing.
Right, sir.
But actual scenario, what you said, that a cadaver picture is not like that.
Yes, sir.
When we are operating,
there's a lot of blood there.
so lot of now factors you have to consider. MRI is very important. Beforehand, you have information,
Yeah.
age of the patient, clinically palpable gland. So, and whether he like to have a preservation of sex or not. So all these factors make us to decide what kind of fascia preservation we have to do. It is not like this 1 or 2. This paper is published because somebody has given this new name, fascia preservation, and published one paper.
Right, sir.
That's all.
Right, sir. So it does not really change practice. There is no reason to start doing it. There is no reason to stop doing it if you're doing it. And this technique was described long back, but it's not widely adopted as the other techniques are. And our patient population is much different than that has been presented in this paper. And inherent factors also matter a lot in continence outcomes. Coming to this paper about prior TURP impacting RARP. Now, recapping the paper, there is sparse data on this topic. So they matched 36 men with prior TURP versus 72 men. 2 significant findings. Bladder neck recon was more commonly required in the TURP group, longer duration of catheterization by just 2 more days in the TURP group. That was statistically significant. I don't know how clinically significant that 2 more days is. And no difference in oncological or continence outcomes. Now, we need to realize that this is from a single high volume surgeon. 5 patients in the TURP group had received NHT. It is not clear whether it was started by the primary surgeon after the diagnosis who had done the TURP and found cancer, or it was started by the authors who wanted to buy some time till they did the RARP actually. These tumors, we need to realize, are not indolent because 50 to 60% of these patients were high risk and 60% had a BCR at 1 year. And 11 out of 36 had a positive margin. Now, sir, if a patient comes to you with a TURP done with a Gleason 3+3, do you stop there? Do you think that is the quantum of disease in him, or do you want to investigate him more to find out more disease inside him? Sir, yeah.
It all depends on like what was the percentage of tissue submitted, and that was positive for 3+3.
Okay. So are you convinced there is only 3+3 in this patient, or would you want to search for a Gleason 4 or 5 in him because he has 3 somewhere?
So exactly, because in TURP you don't go to the peripheral zone. You just take out the central gland and transition zone. That's it.
Right.
And most of the cancer, they rise from the peripheral zone.
Exactly.
So if even if like suppose if you are having only 2%, 3%, 5+5, you don't expect to have a prostate clinical signal prostate cancer in that patient.
Okay.
But his volume is very good, then probably you require MP MRI just to characterize whether is the the
okay. And how long would you wait before you do their MRI?
So usually we wait at least minimum 1 month.
Okay. Okay. And if there's, yes, sir.
No, actually, in this scenario, we like to wait for 3 months minimum.
For the MR?
No.
Even proceeding to the RARP?
No. Just patient. We have done a TURP. Report has come 3+3.
Right, sir.
As you mentioned, and what he said is right. We see how many cores are positive and all that. If less than 5, then chips, then we don't consider very significant. We wait.
Yes, sir.
We get a PSA.
Right, sir.
And we again compare with the baseline PSA before surgery. Normally, everybody has that PSA done.
Right, sir.
If that PSA is coming 0 point something, then we are not much bothered for this patient. We will like to wait. Repeat PSA every 3 months. Moment we see PSA is going up, 1, 2, 3, like that, then we go for MP MRI, and then we counsel him for further treatment.
Okay, so you're not going to chase every patient of
3+3. I'm not talking of 4, 5, and
exactly. So if it is more than 3+3, you're definitely going to consider this patient as a CA prostate patient and manage him accordingly. Okay, but you're not going to chase every 3+3. Sir, could you just tell us some difficulties that you might encounter technically in this? how long would you wait if lower intermediate risk? If high risk, would you prefer the RT pathway because you're going to wait for 3 months?
So basically, in such scenario, we have to discuss the patient in thoroughly that number one, that what are the problems we will going to encounter after RARP because of the previous TURP. And we have to also see that where the TURP actually has been done, because it is the post-op outcomes and complications are also going to depend on how badly the initial TURP has been done. And in such scenario, we will also like to have a pre-op cystoscopy to assess the bladder neck and other issues. And definitely we should discuss the patient about the multimodality treatment with the RT and hormonal therapy, especially if the patient has a high expectation and he don't want to have complications, which are definitely possibility of having more in the post-op TURP patients.
All right. Okay, so thank you. Any interrupt tips for the bladder neck, because your catheter is not going to stop at the bladder neck when the assistant gives the tug?
Yeah, so definitely it is more of your experience, but definitely there are chances that eventually we'll end up in a large bladder neck, which will require recon and all those things.
All right. Now, only 3 out of the 108 men in this study were even sexually active. This is absolutely dismal compared to what is reported in the Western literature. What percentage of patients, sir, are sexually active? How many are concerned about post-op ED? And suppose you have a 3+3 disease, but the patient is not sexually active, would you go ahead to save the nerves? Do you believe nerve sparing contributes to continence outcomes, or it is just about erectile function?
Honestly speaking, we don't discuss this issue to every patient, honestly speaking. So it all depends on the age of the patient also. Those patients who are coming at age of like 55, 60, 65 between, then we always discuss this issue with them. But if patient is like 70, 75, then we don't discuss all these things to the patient. And even they don't like to discuss in the OPD also. So definitely in younger patient, we do discuss.
No, before surgery, as he said, not in the OPD, but before surgery, when we go for our round previous evening, we like to discuss with him.
Right, sir.
Now, the problem is what we have, our experience again coming here, that initially they say, no, we have come for cancer. Please do my surgery in such a way that there should not be any cancer left in the body. And he's right, because we are operating for cancer control. We are not operating anything for the sex. But what happens later on? After 1 year or 2 years, his PSA remains 0, 0, 0. And then he thinks that I'm going to survive for 10 years. Then they start asking for, Dr. Saab, now I'm interested in the sex.
Right, sir.
So, ideally speaking, we must ask before surgery in privacy, obviously. Record it also, so that tomorrow he may not go into the court, because that scenario is also coming. Somebody may come and claim that this surgery has made me impotent, like that.
Right,
so recording is very important. Then we have got scoring system, and we always document this in our file.
Right, sir. Yes, sir. Yes, sir.
Like, do you really think so that we know that we are operating on a localized cancer, and there is no need for sacrificing the nerve bundle?
No, sir.
So we are going to sacrifice the nerve bundle only on this ground that patient is not a sexually active, because it's very proven fact that apart from the erectile function, it also contribute to the early continence and other factors. And definitely, even if he is not a sexually active person, if we are not compromising the oncological outcome, and if he can do it, why not? Like just like then in partial nephrectomy, if he can do it, why should not? Even if the patient is not CKD, not hypertensive, not blood pressure.
No, as we discussed in the fascia preservation, similarly about this nerve sparing, a lot of debate is going on. Grade 1, grade 2, grade 3, 4, 5, lot of names have been given. So Saurabh, always some nerves are going to be damaged, irrespective of your best practice, whatsoever you do. The question is where it is possible to save, certainly you would like to save. Okay. And in some cases where you cannot save it actually.
Right,
so
sir.
you have to, again, my focus at least is, because I have seen patients coming after the surgery, when they see histopathology report, margin positive, their face goes down. They say, sir, I have come here for cancer surgery and my cancer is left in the body.
Right,
what reply you will give it to him at that time? So what I'm saying is, again, cancer control is the prime importance of radical prostatectomy.
Right, sir. Gagan sir, could you just speak about RT and ED? What do you tell your patients? What ED can they expect?
So as Amitabh was saying that, this is a very seldom addressed issue in the clinic. Unfortunately, I wish it was better addressed. But yes, we do ask them about their sexual activity and, whatever their expectations are. But at the end of the day, most of the patients, they start with ADT, and in any case, that thing is flailing. So it's really not a very it's really not something very positive to look at. And especially if the patient is slightly older, and I know that even when you stop ADT later on, the recovery is not going to be much. But then we do tell the younger patients that, okay, fine, that you have a possibility of getting better once the ADT is stopped. We do tell that, we do mention that, but ED is there.
So just like a passing remark, this paper, about 50 patients were given RT instead of RARP post TURP, and they did pretty well compared with regards to geotoxicity and stricture rates. Now, this paper provides evidence that RARP following TURP is feasible, safe, and has comparable continence outcomes. You may need to recon the bladder neck more, and you need expertise to do it. Now, coming to this paper about neoadjuvant abiraterone plus minus cabazitaxel. So neoadjuvant therapy for prostate is not yet defined properly. So they did this trial, abira in one group, abira plus cabazi in the other group. Duration 6 months before surgery. 44% achieved path CR, which is a good number for high risk and very high risk cancer. And rate of path CR was similar in both groups, suggesting that addition of cabazitaxel over abiraterone was not leading to any benefit. Sir, do you use neoadjuvant therapy in your practice? Are patients referred to you for neoadjuvant therapy from the surgical colleagues?
No.
No, not
even
yet.
if they are sent for that purpose, we counsel them not to go ahead with that.
Great. Okay. And so sometimes patients, have been started on ADT by their primary physician who has done the diagnosis of prostate cancer. And so the answer is no. So if yes, that question is redundant now. Okay. Now, sir, does a history of the patient being given ADT bring about any technical challenges to the surgery? We've heard that, it gives more negative margins, but is there any technical challenge?
So actually, if any patient who had been on ADT as a neoadjuvant treatment, then definitely you get a bit more dysplasia around the prostate, periprostatic fat that get stuck on the capsule of the prostate. And especially if you're intent for the nerve sparing, then it becomes more difficult to all these patients. And if, like, suppose the patient had T3B disease initially before giving hormonal treatment, like some analog cycles were involved, then after getting this ADT, they become very fibrotic, very small, and sometimes the dissection of seminal cycle becomes very difficult. Even sometimes you can identify where is the seminal cycle. So definitely after getting ADT, you face some challenges for RA.
And if this practice,
this type of study, I mean, I was just thinking about it. What is the actual point, sir? Is this some sort of a feasibility study where later on maybe it will help us?
So basically what they wanted to see was whether in the short term we are achieving good pathological response rate. It will culminate down into a good survival outcome or not. I think probably, as I said, that they should have waited for Charter 2 results, in which it is being tried in the castration resistant sensitive. If the OS is improved in the castration resistant sensitive, then probably it should have been looked into this trial. So, but obviously this has spared a lot of money that they should not go into a phase 3 trial with this combination because it is not going to work.
Okay. So I think you spoke about toxicity, tolerability, and affordability in your presentation. If we have to involve medical oncologists now, if this practice just comes in.
What Gagan is asking is that whether a medical oncologist will be involved anytime in this setup in a neoadjuvant setting in a prostate or not. I think that is whether that situation will ever arise.
Yeah. So at any point, if we have to
pre-surgical,
yeah. So if we have to start a drug, we would definitely involve the medical oncologist. But, yeah.
Which scenario will be there in as the science is evolving that we give neoadjuvant prior surgery, because right now there is no neoadjuvant therapy.
Yeah, so there is no evidence.
Surgery.
This is like a phase 2 trial. There are multiple phase 3 trials which are ongoing with a lot of combinations, and the data is only going to be good. You give more therapy, you're going to get better outcomes, at least from the BCR free and the MFS free
So my
point
question
of
is
view.
very different. It is to the surgical colleagues that will they refer any, what will be the subset which you will refer to
the high risk and the very high risk.
Preoperative docetaxel or anything. I mean, it may not be only AB, it may be docetaxel or anything.
Can I make comment?
Yes, sir.
See, there are certain big hospitals, their tumor board is sitting and every patient is seen in the tumor board. Then it was decided, then it is decided whether they should go for surgery, radiation or medical oncology. So in those places, it is possible that the medical oncologist will come into the discussion actually, whereas individual practice is a different matter.
I just like to raise a point. Should we really call it as a neoadjuvant hormonal therapy, or it should be a preoperative hormone therapy? Because ideally, if you say by the terminology, neoadjuvant treatment, any sort of, whether it's a hormonal, chemo or radiation, is doing when there is a clear-cut indication that after the completion of this treatment, patient will be offered a definitive surgical or radiation treatment, and there will be no question of denying for that definitive treatment. Here, what we are doing, we are giving in some high risk patients, which we feel that they are not surgically amenable right now, and we are looking forward to make them surgically amenable. And there are set of patients where we are refusing them the surgery. So I think first of all, the terminology should be changed to a preoperative hormonal therapy rather than neoadjuvant hormonal therapy. And in this condition, it is being offered to those patients who are very much aggressive in the treatment, who don't want to have any risk regarding the without surgery.
So when you say preoperative, that means you are already committed that you are going to operate in future.
Sir, ideally the neoadjuvant terminology should be used only when we are giving any treatment modality before the definitive treatment modality with the intention of cure. Here we are not intent.
So in a localized disease, whether it is high risk, you are going to with the intention of cure.
One question that I want to ask.
Surgery gets spoiled after any neoadjuvant therapy, so maybe we just can't do it.
Question
No,
is,
so one
medical
question we
oncologists are
ask
much
is-
later. Most of the urologists do not involve radiation oncologists also. Sir, what you said, tumor, it is only for talking.
No,
but it does not
sir,
exist.
So the practical question is that in today's practice, if you have a patient of high risk prostate cancer with PSA above 20 and there is some periprostatic involvement, seminal vesicle involvement, will you offer surgery at any point of time for this patient, or would you want neoadjuvant hormonal therapy followed by RT? Outside of a trial setting, would you be offering surgery or not? Because this is one of the questions, and surprisingly, I have found certain patients being operated by certain big centers of India, and some big urologists going ahead with surgery, even in high risk prostate cancer patients now. So as a tumor board, are we doing this thing on a trial basis, or outside of trial also are we recommending this, and what evidence do we have to do this?
No, I like to make two comments on this. One is, as far as the indication of radical prostatectomy in high risk disease, yes, there is definitely a role, and I don't want to discuss on that. That is a full topic for the debate. We can do it some other time. The second thing is, sometime in clinical practice, what the scenario you have given us, patient is not able to make up his mind whether he want to go for a surgery or he want to go for radiation. At that time, we tell the patient, don't worry, because radiation therapist will also start radiation after 3 months or 6 months of the hormonal therapy. So patient has to wait. So I said, don't worry, have an injection, wait for 3 months, come back, we'll see your PSA level. If required, we'll repeat a MRI, and then we can take our decision. So you see, the clinical scenario is different from just talking all these things. And I can also debate about that role of radical prostatectomy in high risk disease. We have published papers on that.
Right. So it is probably about intensifying treatment for, this patient deserves more than just a surgery, probably deserves more systemic therapy, and we're just intensifying the systemic therapy by adding abiraterone or some other agent to the ADT alone, because ADT alone has not shown any benefit when added just to surgery in the neoadjuvant setting. So this is one place where, India can actually generate evidence, because we have a lot of these patients and not just Gleason 6 and 7. Coming to the last paper, the Neurosafe paper. Okay, we'll just rush through it. They said that doing Neurosafe is feasible. I will not go through this. And there are some other ways by which you can do frozen section. We'll let that be also. Now, about the practicality of the procedure, the thing is, you need to remove the prostate midway. How many of us are able to do that with the patient in steep Trundle-Lindbergh? Are we going to dedock the robot? How many of us have integrated table motion? How is that feasible and possible?
So it is feasible actually. So what you can do, you just give a periumbilical incision, a small incision, and you can put a Alexis retractor.
With the patient in steep Trundle-Lindbergh with the robot dock?
Yeah,
Okay.
definitely. You
And
can
then
do it.
close the incision?
No, so what you do, you just apply the cap of the Alexis retractor. It will create a very beautiful pneumo without any air leak. You just do the radical prostatectomy. Then you dedock the robot, you take out the specimen and send for the frozen section analysis. And by that time, you can go for the pelvic lymph node
dissection, if that is planned.
Okay. And in case, suppose in this slide, if you don't want to do pelvic lymph node dissection, then this patient is not for the radical prostatectomy as well.
Okay.
So if you are doing radical prostatectomy, then you need to take out the lymph node also, because that means the patient is having clinically insignificant disease.
Okay.
So what actually we thought about doing this Neurosafe at least 2 months back, I discussed with Dr. Gurudat sir also, because it is not feasible for us to have a 32 section, because you need to have a separate frozen section machine also, because you have a limitation for one machine. And in one hospital, you have a head neck department also, and some other departments also, which are sending the simultaneous frozen section analysis. So what we thought about doing, you just see the MP MRI and you just localize the tumor location and just send the section over that target index lesion. That's
Right,
it.
right.
And if you feel during dissection where like it can come as a positive, then you can just mark that area also.
So again, with the discussion that we had, our number of patients for this, eligible patients for, our nerve sparing are probably a little less. If you have any doubt of wanting to sacrifice the nerves, you would probably go ahead and sacrifice it for the oncological outcome. Would you want to use the intra-frozen section for the apex and the base? Because that is somewhere where we do get margins positive.
So if there is
And
a
if you could-
disease, if
yeah.
there is a disease in MPMRI, then definitely I would.
So you would want a frozen to tell you whether the apex margin is free or not.
See, I'll add what Amitabh said. This is exactly what we are also following. It is feasible. Second thing is, idea of this Neurosafe is only to reduce the margin positivity rate.
Correct.
And index lesion, wherever we have a doubt, at that particular site, surgeon sends that tissue for histopathology. And while we are waiting, we can do lymphadenectomy.
Right,
and if suppose frozen section come positive, at that particular site, they do a wider resection of that nerve actually. So idea is to reduce the margin positivity rate, nothing else.
Okay.
So only the area of interest can be just addressed at that time, because the whole surface of the prostate is a margin, right, from
Yes.
apex to base and the all around.
Right.
So it's not feasible, as Dr. Amitabh also alluded.
Cost of almost 50,000.
Right.
It's not about cost only, because the technique will also take a lot of time, because we have to subject more than 20 sections for this.
Right.
So can you give the margin if it comes positive at the apex? Yes.
Yes, without as much as possible, without, yeah.
And that at the particular point where the margin
this
is
is just-
just positive, to demonstrate the the anatomical congruence, that from where it has come positive, it's also a challenge.
Yeah, so it's just a final slide. It has been adopted at some centers. Definitely,
Hello.
it's being done regularly at Bangalore.
I just
Yeah.
like to add one thing.
Yeah.
It is for erectile function preservation.
Yes.
So
And
your
to
margin
retain-
positivity is basically just just making a sure shot that what
You're
the
not
MRI image
yeah.
is there, plus what is the final pathology. So this IFS is a midway step just to confirm, so that erectile preservation is perfect.
Exactly. So it's probably the best way to balance the oncological and functional outcome. You are not compromising oncological outcome by preserving nerves, and you are preserving the nerves where it is oncologically possible to do it. And the long term from the RCT is awaited. It requires some standardization, coordination. Thank you so much. We've overshot our time by 10 minutes, but we've had a very fruitful discussion. Thank you so much. Thank you.
So thank you, chairpersons, and thank you, panelists and all the speakers of the previous session. It was a really interesting and interactive discussion on the surgical part of management of non-metastatic prostate. So now moving to the next session, which is the radiation management of non-metastatic carcinoma prostate. I would request Dr. N.P. Gupta sir to stay on dais, and I would request Dr. Jaskaran Singh Sethi, sir is Senior Consultant and Chief of GI, HPB and Pediatric Radiation Oncology at RGCI, to come to dais for chairing the session. So the list of speakers is here. Yes, sir.
Hello. Aye. Good afternoon. we will welcome you for this session, and we will invite Dr. Sayan Paul. He is a senior consultant, radiation oncology, Apollo Hospital from Kolkata. He is going to talk on primary endpoint analysis of a randomized phase 3 trial of hypofractionated versus conventional post-prostatectomy radiotherapy. Dr. Sayan Paul, please.
Thank you, organizers, for inviting me. So I have an abstract to present, which is very interesting for radiation oncologist, a primary endpoint analysis of a randomized phase 3 trial of hyperfractionated versus conventional post-prostatectomy radiotherapy. It's an energy oncology study. So for the non-radiation oncologist colleagues, as we know, the radiobiology of prostate is the alpha by beta is 1.5 to 2. So though I have not much time, so I just in grossly I explain if the alpha by beta is less, that those cancers can will give better result if we do hyperfractionation or give more dose per fraction and reduce the number of fractions. So prostate cancer is one of that. And for radical treatments, it is now hyperfractionation is the standard of care. And as per the CHIP trial, we treat the patient with 60 gain 20 fractions. But and this study actually deals with the cases post-radical prostatectomy, and it is a patient reported outcome analysis of a study, and their objective was to determine if hyperfractionated postoperative prostate bed radiotherapy does not increase the patient reported genitourinary and GI toxicity over conventional fractionated postoperative radiotherapy. Though for radical prostate radiotherapy, many people have adopted the hyperfractionated regime, but for postoperative radiotherapy, it is still people are using the conventional fractionation, most of the people. So the eligibility criteria were an undetectable PSA that is less than 0.1 nanogram per ml with either margin negative PT3 PN0 or NX or margin positive T2 PN0NX adenocarcinoma of the prostate, or a detectable PSA that is more than equal to 0.1 nanogram per ml and PT2 or PT3 N0 NX disease. So in hypo-RT arm, they have used 62.5 gray to the prostate bed in 25 fractions, that is 2.5 gray per fraction. And in conventional post-op RT, they have used 66.6 gray in 37 fractions of 1.8 gray per fraction. Here, lymph node radiation was not allowed, and ADT of less than equal to 6 months was allowed. So patient was stratified according to the baseline expanded prostate cancer index composite score, EPIC score, and ADT use, and then randomized 1:1. The co-primary endpoint were based on change scores, 25-month score minus baseline score from GU and GI domain of the EPIC. And the hypothesis is that the mean change score at 24 months are no worse than hypo-RT than it is for conventional RT. The non-inferiority margin are based on 0.5 standard error at Energy Oncology 0415 trial, -5 for GU and -6 for GI. So 282 patients provided greater than equal to 90% power with one-sided alpha of 0.025 for each domain while inflating for non-compliance or loss to follow-up. So this is the EPIC score. I'm not going into the detail. So between July 2017 and July 2018, 298 patients were screened and 296 were randomized. 144 was in hypo-RT arm and 152 was in conventional post-op RT arm. The compliance with the EPIC was 100% at baseline, 83% at the end of RT, 77% at 6 months, 78% at 12 months, and 73% at 24 months. So now the results. So at the end of RT, the hypo-RT and conventional RT mean GU change score were neither clinically significant nor significantly different and remained so at 6 and 12 months. The mean GI change score for hypo-RT and conventional RT were both clinically significant and significantly different at the end of RT. So hypo-RT mean GI was -15 versus conventional GI was -6.8 and p-value was significant. However, Both the hypo-RT and conventional RT mean GI change score, clinically and statistically significant differences are resolved at 6 and 12 months. The 24 months mean GU and GI score for hypo-RT and conventional post-op RT remain neither clinically significant nor statistically significant. So hypo-RT mean GU was minus 5.2 versus conventional mean GU was minus 3, P was 0.81, and hypo-RT mean GI was minus 2.2 versus conventional mean GI was minus 1.5, and P is 0.12. So with a median follow-up for censored patient at 2.1, there was no difference between hypo-RT versus conventional RT for biochemical failure, which was defined as a PSA of greater than equal to 0.4 nanogram per ml, followed by a value higher than the first by any amount. So 2-year actuarial was 12% versus 8% and non-significant p-value, or there is any difference in the local failure. 2-year actuarial was 0.7% versus 0.8% with a non-significant p-value. So they concluded that hypo-RT is non-inferior to conventional post-op RT in terms of late patient-reported GU and GI toxicity. More follow-up is needed to appropriately assess disease control endpoints because this was not their primary endpoints. In some clinic scenarios, hypo-RT may be considered an acceptable practice standard. As we all know that because after prostatectomy, the bladder and rectum comes closer and the area, so we are more concerned about the toxicities. So this was a much needed article. The patient reported outcome analysis of post-operative hypofractionated RT, and it is showing that it is similar at 24 months. So this can be, I think, in future, this will become the standard of care. So thank you for your attention.
Thank you, Dr. Paul. And we would like now to call Dr. Sajal Kakkar, who's a good friend, and he's Associate Director, Radiation Oncology at Max Hospital, Chandigarh. And he'll be speaking on prostate radiotherapy with ADT, improves the metastatic free survival compared to neoadjuvant ADT.
A very good afternoon to all of you. At the outset, I would like to thank the organizers for this opportunity. The abstract I'm going to discuss is prostate radiotherapy with adjuvant RT. Adjuvant ADT improves metastatic free survival compared to neoadjuvant androgen suppression and individual patient data meta-analysis. So this is the study I'm going to discuss. It was presented in JCO in 2020. This would be the flow of presentation. So adjuvant, ADT with radiotherapy is one of the standard treatment approach in localized or locally advanced prostate cancers. There are umpteen randomized trials which have tried to discuss the issue of use as well as the duration of ADT. But what is scarcely discussed is the sequencing of adjuvant this ADT with radiation, whether in the neoadjuvant setting or in the adjuvant setting. Sequencing is highly variable as far as the clinical practice is concerned if we consider neoadjuvant hormone therapy and radiation. Some cooperative groups like RTOG advocates using 2 months of neoadjuvant hormone therapy before RT, and some groups like EORTC, they don't advocate using NAHT at all along with radiation. So the authors in this meta-analysis tried to address this issue of sequencing of ADT in localized prostate cancer, as well as to analyze the role of neoadjuvant vis-a-vis adjuvant short-term androgen suppression along with prostate-directed radiotherapy. So this is an individual patient data meta-analysis. And the 2 randomized trials were included in this meta-analysis. One is first RTOG 9413 trial, and another is a Canadian study, 101 published in JCO 2019. So this is the consort diagram. The Canadian study, as you can see here, was randomized into 2 groups, neoadjuvant and concurrent ADT and concurrent and adjuvant ADT. RTOG 9413, which was published way back in 2003, had 2x2 factorial design where whole pelvic RT and prostate only RT, as well as neoadjuvant and adjuvant hormone therapy were compared. To sync the data with this Canadian study, the whole pelvic RT arm was excluded from this meta-analysis. So neoadjuvant and concurrent ADT in one arm and adjuvant ADT with prostate RT in another arm in RTOG 9413 were included. So there were 500 odd patients in both arms. So coming to RTOG 9413 first, if we see this study published in JCO 2003, a 2x2 factorial, as I told you, clinically localized prostate cancer, PSA up to 100 nanogram per ml. So quite a bulky disease, significant burden of disease was included in this study. Median PSA was 23 in the patient cohort. NAST arm 2 months before and 2 months during RT, the androgen suppression was done. Adjuvant hormone therapy arm, RT, followed by 4 months of adjuvant ADT. So 4 months in both the arms. In NAST, it's 2 months before and 2 months along with RT. And as you can see here, these are the 4 arms in this study. With a median follow-up of 59 months, 4-year progression-free survival was significant in whole pelvic RT arm. And the neoadjuvant hormone therapy plus whole pelvic RT scored significantly better as well as PFS was concerned. This study was updated in 2007 and very recently in 2018, the long-term data was published. Now with a median follow-up of 8.8 years in all patients and almost 14 years in living patients, there was significant PFS benefit in neoadjuvant hormone therapy and whole pelvic RT arm as compared to NST plus prostate only RT or adjuvant hormone therapy plus whole pelvic RT. A bit confusing. There was similar PFS benefit between neoadjuvant hormone and whole pelvic RT and adjuvant hormone therapy plus prostate only RT. In this study, in the updated result, there was a benefit more in the adjuvant hormone therapy group and prostate only RT, but it was not significant. And only prostate directed RT was used in the meta-analysis, as I already discussed. In the second study, the Canadian study, 4 months of neoadjuvant hormone followed by concurrent RT and ADT. And the arm 2 was RT with ADT followed by 4 months of adjuvant androgen deprivation. There was no significant benefit both amongst the arm, but there was a trend towards benefit in arm 2. Outcomes, primary outcome of PFS, late toxicities are also analyzed. If we see the data now with a median follow-up of almost 15 years, there was significant benefit in progression-free survival as well as metastasis-free survival in adjuvant hormone therapy arm. Incidence of biochemical failure and distant metastasis again was significantly low in adjuvant hormone therapy arm as compared to neoadjuvant hormone therapy. And the results were consistent across all the subgroups, be it Gleason score, PSA if we segregate, and there was no significant difference in GI or late GI or GU toxicities. These are the Kaplan-Meier survival curves. So the study results are quite surprising. We all know that neoadjuvant hormone therapy is a traditional standard practice. It leads to downstaging of the disease and probably helps to reduce the toxicities associated with radiation. We never expected that adjuvant hormone therapy will show such a significant results. So why this is happening? Let's see if prolongation of neoadjuvant hormone therapy duration gives us some idea. So if there are several trials, but they have not shown if you increase the duration of NAST, the outcomes are similar. So it doesn't help if you increase the duration of neoadjuvant hormone therapy. Now, this is a very important study. If prolongation of androgen suppression helps. So in this DiMarco group, they pooled data of 3 randomized controlled trials and divided the patient's cohort into 2 arms. First arm, the duration of androgen suppression was 3 to 4 months, where it was predominantly NAST with 1 month of ADT with RT. The second duration was 6 months in one trial, where it was 4 months of neoadjuvant hormone therapy and 2 months of adjuvant hormone therapy. And when this data was published in 2011, there was significant reduction in the risk of prostate cancer specific mortality with 6 months of adjuvant suppression. So the authors concluded that probably 6 months of therapy should be the standard of care, and especially in patients with GS7. This cohort had most of the patients for Gleason score 7. So at that time in 2011, when it was published, it was thought probably duration matters more, that is 6 months as compared to 4 months. But if we see in retrospect, considering this meta-analysis which was published 2 years back, is this the new duration which matters? Probably the adjuvant hormone therapy is causing the outcome to be different. And hence the sequencing is more important, because probably adjuvant hormone suppression leads to prolonged testosterone suppression, which is very much important. To support this, this is another Princess Margaret data, a randomized trial, intermediate risk patients, EBRT with and without neoadjuvant anti-androgen therapy. So they used anti-androgen, bicalutamide was used, obviously, as you know, and no adjuvant was given. So in this study, there was no improvement in any of the outcomes. So this shows this probably it's not the new adjuvant which is causing the benefit. It is the prolonged testosterone suppression, which happens when you give adjuvant ADT rather than anti-androgen. And why this is important is a lot of molecular studies have shown post RT, in post RT patient, there is a lot of upregulation of androgen receptors, which leads to overexpression of DNA repair genes. So probably prolonged testosterone suppression helps in improving and giving us better outcomes. On the contrary, this data is a retrospective data from Cleveland Clinic. If you see this data, intermediate risk and high risk patients, neoadjuvant and adjuvant hormone therapy was compared. There was no difference between neoadjuvant and adjuvant. So there are limitations of this meta-analysis. Only 2 trials are included. There is a lot of heterogeneity. If you see the trials, RTOG 9413 had whole pelvic RT arm, which was not included in this analysis. RT dose was suboptimal, only 70 gray was given. And the disease was more bulky. As you know, PSA up to 100 were taken in this RTOG 9413 analysis. So the take home is use of neoadjuvant ADT and hence delay in initiating RT. Is it necessary for all patients? Probably no. Considering this data, there might be some cohort of patients where there is no need to give neoadjuvant ADT and wait for 2 to 3 months before starting RT. Short-term androgen adjuvant ADT has shown superior outcomes as compared to neoadjuvant and concurrent ADT. This data is thought-provoking, but definitely right now it is not practice-changing. Thank you.
Thank you, Dr. Sajal Kakkar. Now we invite Dr. Priyam Vada Matre from Tata Memorial Hospital, Mumbai, and she is going to talk prostate only versus whole pelvic radiation therapy in high and very high risk prostate cancer outcome from phase 3 randomized controlled trial. Dr. Priyam Vada.
Very good afternoon, everyone. Thank you, organizers, for giving me this opportunity to present this landmark paper from our institute. Sorry. Yeah. So this paper from our institute was published in the Journal of Clinical Oncology last year. The prostate only versus whole pelvic radiotherapy in high risk and very high risk prostate cancer, the POP-RT trial. The PI for this trial is Professor Vedang Murthy, and this trial aimed to compare the outcomes between the whole pelvic and prostate only radiotherapy for high risk and very high risk prostate cancer. We are all familiar with the risk groups in the prostate cancer, the low, intermediate, and the high risk groups. The high risk ones are the tumors which are T3A or above, or a Gleason's of 8 to 10, or a PSA of more than 20. And for these high risk patients, there is a simple equation for estimating the risk of nodal involvement. That is the Roche formula published way back in 1994. And the question for these node negative patients has been whether the pelvic node should be electively irradiated or not. This has been a long debated issue in light of the anticipated increased toxicity with pelvic radiotherapy, vis-a-vis hope for better biochemical control and possibly improved survival outcomes. So there were 2 randomized trials from the 1990s which have already looked at this issue. One from the RTOG, that is the 9413 trial, which Dr. Kakkar just spoke about, and another from GETEC group. Both of these trials actually failed to show any benefit of pelvic radiotherapy. Please bear in mind that they were the pre-dose escalation era trials. Most of the radiotherapy was delivered using 4-field box techniques, and there were issues with patient selection as well. So what the POP-RT trial did was to select very high or high risk prostate cancers with an estimated pelvic nodal risk of at least 20% by the Roche formula, or T3B to T4A disease. These patients were randomized to either prostate only radiotherapy given to a dose of 68 gray in 25 fractions, that is moderate hypofractionation, or the whole pelvic radiotherapy to the dose of 50 gray in 25 fractions delivered simultaneously. Importantly, these patients were staged using MRI pelvis, and most of them had a PSMA PET-CT at baseline, which is reflective of our modern practice. They were stratified according to ADT type, Gleason score, PSA at baseline, and a prior history of TURP. And daily image guidance along with use of IMRT was mandatory for everyone. All patients got at least 2 years of ADT, and the nodal levels were extended superiorly up to L4, L5 region. Primary endpoint for this trial was 5-year biochemical failure-free survival. So this was a quite high-risk cohort. Most of the patients had a risk of around 30 to 40%. Almost 50% had a Gleason group of 4 to 5, and almost 50% had a tumor stage of T3B to T4A. After a median follow-up of 68 months, there was significant improvement in biochemical failure-free survival and disease-free survival in the pelvic radiotherapy arm. The hazard ratio for BFFS was 0.23, that is 80% in favor of pelvic radiotherapy. 5-year BFFS was 95% in the pelvic RT arm versus 81% in the prostate-only RT arm. For the metastasis-free survival and overall survival, there was significant improvement in metastasis-free survival for pelvic radiotherapy, but no difference was observed among the overall survival outcomes. So the 5-year MFS was 95% versus 88%, which in itself is quite good for this high to very high risk population. So where the benefit of pelvic radiotherapy was most seen, when we look at the table of recurrences, most of the patients in prostate only arm relapsed either in the pelvis with or without distant metastasis. And in the whole pelvic arm, by giving a good pelvic control, even the incidence of distant metastasis was reduced. When we did a subgroup analysis for the known prognostic factors of PSA, Gleason, T-stage, etc., we could not identify any subgroup which did not benefit. So in essence, most of the patients benefited from the pelvic radiotherapy. How was this trial different from the previous trials? Mainly in the patient selection, we selected a very high risk cohort, which was at increased risk of pelvic nodal micrometastasis. And these patients were staged with contemporary imaging techniques. They all received the standard of radiotherapy that we practice in our clinics today. And everyone received at least 2 years of ADT, which is risk appropriate for this group. There have been concerns regarding toxicity of pelvic radiotherapy. So the detailed toxicity outcomes were published separately 2 years back. With pelvic radiotherapy, there was no significant difference in the acute toxicity. However, for late urinary toxicity, there was a difference with pelvic radiotherapy, 20% versus 9%. I would just like to point out that these are grade 2 urinary toxicities, most of which are manageable on outpatient basis with oral medications. Grade 3 toxicity was quite low and there was no grade 4 toxicity. We attribute this to the bowel sparing effect of IMRT, strict planning constraints, and mandatory image guidance. What has been the impact on practice from this trial? Last year, this editorial in Lancet Oncology discussed our trial extensively, and they highlighted that even though the patients were treated up to a higher nodal level superiorly, there was no increase in the toxicity which was anticipated. We were also flattered to receive a letter from Dr. D'Amico himself, where he discussed the impact of our trial on practice. And now many of the global guidelines are incorporating these results into their recommendations. To conclude, I would just like to highlight that although we did not observe an overall survival difference at 5 years, in literature, the 5-year MFS has strongly correlated with overall survival eventually. So we will just have to wait for a longer follow-up to see the final impact on overall survival. However, these are all PSMA negative patients. So we really cannot use PSMA as a guide to omit pelvic radiotherapy in these patients, because it is in this cohort where the pelvic radiotherapy has shown benefit in biochemical control, disease-free survival, and metastasis-free survival. From a previous survey from India, we know that most of us use IMRT to give the prostate radiotherapy. So the type of radiotherapy which is used in this trial is deliverable with all our standard techniques. And finally, the benefit of pelvic radiotherapy outweighs the toxicity concerns in this population of high risk to very high risk prostate cancer. We would like to acknowledge TRAC and Terry Fox Foundation for the funding for this trial, constant support from the Department of Radiation Oncology, our fantastic team of trial coordinators, Dr. Sudeep Gupta, and the trust from the patient and their families. On behalf of the PI, Dr. Murthy, who would have really liked to be present here to show these results to you in person, but he is at ISRO presenting further data from prostate cancer for the GG5 collaboration study, of which some of you are part of. Thank you.
Thank you, Dr. Maitre. Really nice to have some Indian data coming up, showing us the way in prostate cancer. Now, next speaker is Dr. Arpita Bindal, Consultant Radiation Oncology at Fortis, Delhi. And she'll be speaking on randomized trial of external beam radiotherapy alone or with HDR brachytherapy for prostate cancer, 12-year data.
Good afternoon, everybody. At the outset, I would like to thank Dr. Aditi and all the organizers for inviting me to present this interesting data by Peter Hoskin. It's a randomized trial of external beam radiotherapy alone or with high-dose rate brachytherapy for prostate cancer. And this paper, published in Green Journal last year, presents the mature 12-year results. Now, this trial started way back in 1997, 25 years ago, and completed in 2005. The initial results were published in 2007, final 7-year results in 2012, and the mature 12-year results now in 2021. So the purpose of this trial was to see whether biological dose escalation by adding high dose rate brachytherapy boost in addition to external beam radiotherapy could lead to improved outcomes. The inclusion criteria was patients with a histological diagnosis of carcinoma prostate, stage 1, T1 to T3, M0 with a PSA of less than 50 and suitable for radical radiotherapy and fit for general anesthesia. The exclusion criteria was patients with metastatic disease or PSA more than 50, or who had any coexisting medical condition because of which they could not be given general anesthesia. So in this trial, patients who were treated with external beam radiotherapy were given 55 gray in 20 fractions. The technique at that time was 3D conformal radiotherapy. The initial 50% of the patients were treated with 3 fields, and later they moved to more conformal techniques, but IMRT was not used. And in the EBRT plus high dose rate brachytherapy boost arm, the external beam dose was 35.75 gray in 13 fractions at 2.75 gray per fraction. And within a week after completion of radiotherapy, patients were given high dose rate brachytherapy, 17 gray in 2 fractions delivered in 24 hours. Now, to bring to note, the BED for external beam arm is 156 gray, which is much less than what is given these days. And while for patients in whom brachytherapy was added, it amounted to 214 gray. The primary endpoint for the trial was to see the relapse-free survival, which was defined as PSA rise more than 2 points above the nodule, or clinical progression or death. And the secondary endpoints were overall survival, urinary toxicity, and bowel toxicity. So this is the consort flow diagram in which 218 patients were randomized, and out of which 106 were allocated to external beam radiotherapy and 110 were allocated to the experimental arm. There was no loss to follow up in this trial. Looking at the demographic details, most of the factors were well balanced in between the 2 arms with respect to age, T-stage, Gleason's, and PSA. More than 50% of the patients in both arms were high risk, and 75% of the patients received ADT. The exact duration of ADT is not mentioned, but the planned duration of ADT was well balanced between the 2 arms. Now, looking at the relapse-free survival for these patients, we see in the graph on the left that after 4 years, the curves begin to separate, and the median relapse-free survival was 7 years for the EBRT arm, while it was about 11 years for the EBRT plus high-dose rate brachytherapy arm. This effect persisted even at 12 years, and we see that with the addition of high-dose rate brachytherapy boost to external beam radiotherapy, there's a substantial 21% increase in relapse-free survival at 12 years. There was no difference seen in the overall survival. When a subgroup analysis was done for patients who received ADT versus who did not receive ADT, it was seen that the impact of dose escalation was seen in both groups of patients, but the magnitude of benefit was much more in patients who could not receive ADT for any reason. On multivariate analysis, it was seen that the treatment arm, risk category, and whether ADT was given or not were significant covariates for the risk for relapse. Coming to the toxicities, they have reported grade 3 GU and GI toxicities. The GI toxicities were, as reported in the other literature, not very significant. However, as compared to other trials, the GU toxicities reported are much greater, but they're comparable in both arms. The authors have ascribed this to the fact that most of the patients developed transient increase in symptoms which resolved, which is why the prevalence of grade 3 GU toxicities is about 7% or 13% in either arm, while the incidence was much higher. So to conclude, at 12 years, there remains a significant improvement in relapse-free survival after external beam radiotherapy with high-dose rate brachytherapy boost. And both treatments were equitoxic for severe late urinary and bowel events and urethral strictures. The criticisms for this trial are the use of 3D CRT for external beam radiotherapy, which is not the standard of care now. And secondly, the control arm received relatively low dose treatment, BED of about 155 Gray. And the relapse-free survival is relatively low as compared to other similar studies. Now, the way forward would be to combine modern IMRT with high dose rate brachytherapy boost. High dose rate brachytherapy boost in India is relatively less practice. So an alternative would be maybe SBRT boost, which I think would find wide acceptance in India. And when we are doing that, we also have to look at the safety and feasibility of urethral sparing in order to reduce GU toxicities. Thank you so much.
Thank you, Arpita. Now we invite Dr. Trinjan Basu, consultant radiation oncologist, HCG Cancer Center, Mumbai, and he is going to speak on salvage therapies for PSMA PET-CT positive nodal only recurrent prostate cancer, impact on survival, functional outcome, and health-related quality of life. Dr. Trinjan.
Thank you so much to the organizers. So I was given this abstract, which was presented in EAU last year, which is on salvage therapies for PSMA PET positive nodal only recurrent prostate cancer. They needed to see the impact on survival, the functional outcome, as well as the health related quality of life. So this was presented in the metastatic prostate cancer session in EAU last year from Munich. It took patients, those who are only PSMA PET-CT diagnosed nodal only recurrent prostate cancer. Because these are a controversial cohort, their managements are still being debated between whether to go for the salvage nodal dissection or salvage radiation. We all know that with a bit background information that the nodal only recurrence have better prognosis compared to bone or visceral, as published about half a decade back. There are systematic reviews published on salvage nodal dissection as well as on salvage radiation. And why this is so important also standing today, a couple of months back, there's a expert comment published in Red Journal from Rahul Tendulkar on the nodal recurrence, which are now to be seen as a curative treatment options. They're no more to be deemed as metastatic as such. So subsequently, in 2 months, the authors have published a full text also on the patient reported oncological outcomes on the similar lines. So the background was, it was taken patients from a single academic center between 2014 to 19 with PSMA PET-CT positive nodal only recurrent. All patients were previously post radical prostatectomy. Those who received previously radiation or ADT were excluded. The patients had to decide between the salvage nodal dissection or salvage radiation, with to look for survival, functional and health related quality of life outcomes. The functional being urinary incontinence by scoring method as well as erectile dysfunction, and health related quality of life by QLC30 and the prostate specific 25 score. Now, salvage radiation was elective nodal radiation by IMRT or VMAT techniques and with image guidance. So they have accounted for the modern treatment techniques with either a normal fractionated means of 1.8 to 2 Gray or a bit of hypofractionated with an simultaneous integrated boost to the PET positive prostatic bed uptake or to the gross node. They maintain standard bladder and rectal protocol as we do, and the contouring was done as per the RTOG Atlas. In terms of salvage lymph nodal dissection, it was an open approach. Dissected nodes were classified as per anatomical regions. They have sent for an immediate histopath evaluation and the complication as per the Clavin Dendo classification. The statistical analysis took primary endpoint to be PSA progression-free survival with more than 0.2 to be counted as a rising PSA, and similar standard survival analysis in statistical methods. So this is the table accounting for the salvage nodal dissection and salvage radiation with the patient parameters, which is more or less well balanced. So coming to the results, there were 138 patients with 71 in the nodal dissection arm and 67 in the radiation arm. Median follow-up for the nodal dissection was 33 months, whereas for the salvage radiation, it was more, 47 months. The median PSA at salvage treatment for the surgical arm was 2.56. For the radiation was 1.3 because they picked up early. There were 57% who all had prior prostate radiation in the nodal dissection arm. The median number of node dissected were 2 in the salvage lymph nodal, with the nodes positive, 2, with dissected about 9. 38% had bilateral nodal dissections. The median number of PSMA positive nodes in salvage radiations were 2, so more or less in the pelvis. The dose was 66 gray in 33 fraction with some boost to the prostatic bed or to the gross nodes, which is variable as per clinician's choice. Nearing about 90% salvage RT group also received ADT, which median duration was again 9 months, and it was less used in the salvage lymph nodal dissection group. Now, looking at the toxicity and quality of life, the acute grade 2 GI or GU was around 28%, and grade 3 was about 1.5%, which is more or less related to the urethral stenosis. The late grade 2 grade 2 toxicities in general overall was around 36%. Mainly there are signs of erectile dysfunction and urinary frequency. Late grade 3 toxicities was around 37.3%. Most frequent being related to erectile dysfunction. There were no significant difference regarding general health related quality of life, daily pad usage, the incontinence scoring between either of the groups. So, and in the survival data, the biochemical recurrence rate were more in the lymph nodal dissection arm, amounting to nearing 87%, whereas in the salvage radiation, it was around 40.3%. The median PSA progression-free survival in salvage radiotherapy was 65 months, compared to lymph nodal dissection was only 2 months. The distant metastasis is around 30% in either of the groups. The overall metastasis-free survival was 70 months. In the salvage lymph nodal dissection, it was 39.5 months, whereas in the salvage RT, it was 57.6 months. So the authors have concluded that in their large contemporary series of patients with nodal only recurrent prostate cancer based on PSMA PET-CT staging, there's a significantly increased biochemical relapse-free survival in patients undergoing surgical treatment compared to radiation. However, there were no difference in terms of functional outcomes, health-related quality of life, or metastasis-free survival. So I sort of did a sort for this. So the strength of this publication was they compared the lymph nodal dissection and the salvage radiation in a very pertinent Indian scenario as well, with a decent follow-up, though a longer follow-up would also amount to better results maybe. That good number of patients well balanced between either of the arm, and also highlights functional and health related quality of life, which is a very important aspect. The weakness being it's a single center retrospective data. We need to await for long-term follow-up. They used open surgical techniques. Our colleagues would debate that they would opt for a robotic salvage lymph nodal dissection, which might give better results in terms of the quality of life, but keep in mind they were similar in both the arms. And the ADT implications were not accounted for, which after the JTAG data in the salvage scenario, a short course ADT is always given now. This also leads to windows of opportunity, like running a prospective evaluation between salvage lymph nodal and salvage RT, amounting both to be a more higher techniques, randomization between nodal status, residual disease, and the ADT usage with RT techniques, importance of adding the hormone, maybe a robotic salvage lymph node dissection data, and also maybe SBRT in nodal only salvage scenario. The threats of we should not rely on a single center data and start changing the practice. There are variability across the radiation dose in salvage scenario across many trials when you're still yet to reach a strong consensus, and concerns always remain for the late GI and GU toxicities. And also a very important aspect is omitting ADT in their data. So there are other trials going on these, one PEACE-5 data, another German data, which is again showed a salvage radiation was better than salvage lymph node dissection. And when it comes to radiation, our radiation colleagues would understand, even there's a lot of debate. This is from an Italian data from a consensus statement that what actually to be taken for a salvage lymph node, whether it's the node per se or a node with a certain margin or a nodal level of that level or bilateral or are doing a complete whole pelvic nodal radiation. So we will have to wait to come to conclusion of all these. Thank you.
Thank you, Dr. Basu. Now, next speaker would be Dr. Sumit Goel, my colleague from Rajiv Gandhi Cancer Institute, and he'll be talking about ADT alone or ADT with AA and NZ, recent update from the Stampede platform.
Thank you, Chairpersons. Good evening, everyone. First of all, I would like to thank the organizers for giving me this opportunity today. So I will be presenting this abstract, which was presented in ESMO 2021. So this was abiraterone acetate plus prednisolone with or without enzalutamide, which was added to the androgen deprivation therapy compared to ADT alone for men who had high-risk non-metastatic prostate cancer. It was primary combined analysis from 2 comparisons in Stampede platform protocol. So background, we know majority of men who die from prostate cancer in Europe and America are usually M0 at diagnosis. And high-risk M0 prostatic cancer, the standard of care is ADT for 3 years plus minus local RT, and post-treatment failures still remain high. And we know that metastasis-free survival is a valid surrogate of OS in M0 patients. So if we look at the docetaxel, we know docetaxel works well in the metastatic setting, but in M0 setting, we know that there is no improvement in either metastasis-free survival or in the OS. So we have 2 studies, either from Stampede and GTG-UG study, which did not show any benefit. So if we look at the second generation hormonal therapies in this subset of patients, we know there was uncertain benefit in M0 subset of patients in the Stampede trial. So same thing. So the authors tried to extrapolate whether there is a benefit of adding abiraterone acetate plus prednisolone in high-risk M0 prostatic cancer patients. So this was the study. The study was amended. So the M0 patients in the ARP group, which is basically prednisolone plus abiraterone acetate, they continued to follow up with no further treatment. And the study was split into 2, M1 and M0. And there was the standard group was ADT into 3 years plus radiation, and 1-to-1 randomized to standard of care plus abiraterone acetate plus prednisolone, and plus minus enzalutamide was added. So if we look at the patient population was M0 patients. There was no evidence of metastasis. This were basically the test that was done was conventional CT scans and bone scans. So they had M0 disease on these scans. They were either newly diagnosed patients, either they were node positive or node negative with high risk features, and either they had T3 or T4 stage of disease, PSA more than 40 nanogram per ml, and Gleason of 8 or more. So the previous relapsing patients were also taken into the study if they were node positive, and the PSA was rising, and the doubling time was less than 6 months, or the PSA was more than 20. And so they looked for 300 events in the ADT group alone, and the data was froze on 3rd of August 2021, and the analysis was done. So at the time of when the analysis was done, so they had 1974 patients. The median age was 68 years. The median PSA was 34 nanogram per ml, and 39% of the patients had node positive disease, and only 3% patients had either relapsed or they had received prior treatment. So in N0, almost all the patients had received radiation. In node positive patients, approximately 70% patients had received radiation. So the median follow was 72 months, and it was variable because in the experimental arm there was sequencing. So if we look at the time frame, in which they had taken the treatment. Abiraterone acetate plus prednisolone was taken for 23.7 months, and it was approximately similar in all the groups. So coming to the endpoints, the metastasis-free survival, if we look at the metastasis-free survival, the 6-year metastasis-free survival had improved from 69% to 82%, hazard ratio of 0.53, significant p-value. So if we split, the previous was combined ADT versus ADT plus abiraterone acetate plus prednisolone. Here they had tried to split between the two, either abiraterone acetate prednisolone alone or in combination with enzalutamide. In both the group, there was response in the combination where they have combined abiraterone acetate plus enzalutamide. The hazard ratio was even better, little better, but significant p-value. So in the subset analysis, they had shown it was probably beneficial in all the subsets, but more so in age group of less than 70, and PS status of 0 was more significant. If we look at the OS status, the 6-year survival improved from 77% to 86%, and hazard ratio of 0.6. Again, this was ADT alone versus the combination of ADT with newer generation hormonal agents. Again, they have tried to split it between abiraterone acetate plus prednisolone alone versus abiraterone acetate plus prednisolone plus enzalutamide. So again, there was benefit in the combination group. But so if we look at the secondary outcome measures, the 6-year prostate cancer survival was much more improved. It was improved from 85% to 93%. Hazard ratio of 0.5 and 49 and significant p-value. And in a combination group with enzalutamide, it was even better. So if we look at the adverse events were much less in the ADT alone group, but as we combined the other drugs to the ADT, the risks involved, the adverse events involved, and it was more with dual blockade. So limitations of this study, they have not reported long-term complications beyond 2 years. They have no data on treatment durations after 2 years, and relapse patients are underrepresented in this study. And there was no evidence of single agent androgen receptor antagonist efficacy. So the authors concluded the 2 years of androgen acetate, the abiraterone acetate plus prednisolone based therapy significantly improved metastasis-free survival and OS. If they had high-risk M0 subgroup starting on ADT and should be considered a new standard of care. But again, adding enzalutamide to abiraterone acetate plus prednisolone, definitely there was little more benefit, but the toxicity was also increased. And so that was the main conclusions. Thank you.
Thank you, Sumit. So this brings us to end of this session, and we will start the panel discussion. May I request Dr. Kaustubha Talapatra. He is the Director, Radiation Oncology, Nanavati Hospital, Mumbai. Can you invite your panelists, please?
It's no laptop. You don't have a laptop.
So may I call upon the panelists? Yes. This one. I have the list. I have the list. With the permission of chairs, may I call upon the panelists, please? So, Dr. Ajay Vyas, Principal Consultant, Nuclear Medicine, Max Healthcare Private Limited, Delhi. Dr. Thiruranjan Basu, Senior Consultant, Radiation Oncology at HCG, Mumbai. Dr. Robin Khosa, Clinical Consultant, Radiation Oncology at Indraprasth Apollo Hospital, New Delhi. Dr. Sajal Kakkar, Associate Director, Radiation Oncology at Max Super Specialty Hospital, Mohali, Dr. Ashwin Malya, Associate Consultant, Department of Uro-Oncology at Sir Gangaram Hospital, New Delhi, and Dr. Shaina Goel, Associate Consultant, Department of Medical Oncology at Medanta, the Medicity.
That's it.
So we start with the first presentation, that was primary endpoint analysis of a randomized phase 3 trial, which compared hypo-RT versus COPORT. COPORT is conventionally fractionated radiotherapy in post-prostatectomy setting. So my question is to the surgical oncologist first, that is Dr. Ashwin Malya. What is your take on post-prostatectomy radiation therapy? If you have those 3 high-risk features based on AUA, that is margin positive or extraprostatic extension or seminal vesicle positive, do you go for adjuvant radiotherapy? Do you wait for the PSA to write to salvage, or do you keep a track for early salvage?
So I think most of us who are practicing prostate cancer, surgical practice of prostate cancer, are nowadays moving towards keeping the patient on follow-up and depending more on the PSA rising and using radiation therapy as a salvage rather than a uniform process of adjuvant radiation therapy with any of these being positive.
Triranjan, strong proponent of adjuvant or salvage in high-risk features, any of the 3 high-risk features?
So if post-prostatectomy PSA has come to the less than 0.2, then if node negative, then we can wait for salvage
So
after
which
radicals.
situation adjuvant? You will just go for adjuvant.
The strong recommendation for adjuvant in today's time would be node positive. There is some data about if the pre-prostatectomy PSA is higher, like higher is again doubtful,
Close margin,
50, 60.
very close margin.
Now close
or
margin,
tumor on margin.
very debatable, very debatable, very debatable. If you ask me frankly, also it's very debatable.
Sajal, put in.
I think post-prostatectomy RT definitely, if in the presence of high-risk features, especially I would try to assess the Kappa score. If the Kappa score shows more than 7 or 8, then probably definitely I would go for immediate RT rather than waiting for a salvage to happen.
Sorry.
No, actually it is these 3 factors what you mentioned. It depends upon whether patient has 1 factor positive, 2 factor positive, or all the 3. Plus, I also like to see the Gleason scoring of the pathology specimen. If it is higher, 4, 5, then I will go for adjuvant. Otherwise, then I will go for early salvage.
Right. So 2 important points have come from this discussion. One, as sir has mentioned, the number of factors being positive is very important. And we have some objective assessment tests like Kappa scoring, which Sajal has mentioned about. And we have to be judicious about not giving adjuvant to all the patients, because we can say spare radiation therapy in a significant proportion of patients to the tune of around 35% to 40%. And I think the ball is shifting towards early salvage than adjuvant. Of course, adjuvant in the groups which have been mentioned, but we are more or less shifting towards early salvage. Now coming to this particular trial, hypo-RT, how comfortable are we in an adjuvant setting? Robin?
Frankly speaking, I have been doing hypo-RT for upfront patients, but not for the post-op patients. And I currently stick on to the conventional fractionation arms.
What are your concerns, Robin?
I think, again, the rectal and the bladder, they are already disturbed areas because of the post surgeries.
Well, these guys say rectum and blood. So we have to remember that this particular trial did not include pelvic lymph node radiation. They did prostate only. Just Karan wanted to make a point here.
Yeah, you see, we must understand that these trials are under very strict surveillance. They are at standard conditions. What we do in our clinics may not imitate that. The bladder bowel protocol, all these things, they're sometimes very difficult to actually hold on. So we should take all these trials with a little bit of pinch when we make it to a practice changing.
So even if we go through the evidence, there are not too much of randomized evidence available. There is one where the hypofractionated radiation dose biological equivalence was less, and rest of them are all retrospective study. Sayan, can I ask you to summarize? Since you have done extensive work on this paper, can you summarize? Are we ready for hypofractionated radiation as yet, or still there is some time to go?
Actually, we are not practicing hyperfractionated RT at present. The main reason is not being the quality assurance issues. What I feel, I have visited few of the centers outside India also. Our quality assurance in India is quite good. The way we treat the patients and how our technologists are trained and how they are matching every day is quite good. Rather, we are very strict on quality assurance, stricter than people who are doing outside India. The main concern is the data, the evidence. We don't have adequate evidence. It is not mature. It is maturing. Like this patient reported outcome data. So we need the toxicity data more. See, as per radiobiology, I feel it will be beneficial. The science says that hyperfractionation should be beneficial in prostate cancer, be it a radical setting or post-operative setting. But we need the toxicity data. That is the main concern, because after removal of prostate and the area is very small and some amount of bladder or rectum are going to get irradiated. So we need to know whether the toxicity is equal or not. If we have a long-term toxicity data, we can use hyperfractionated.
Priyambada, are you practicing it in Tata?
Post-op prostate RT is probably the only site where we are not doing hyperfractionation.
Having said that, the Tata Medical Center, Kolkata has some experience with it, right?
I think so, but I am not aware.
So we have, I mean, I think maybe we can conclude about this paper is that we have emerging evidence on it. It has still not become the standard of care. If we are doing it, should be treated prostate only patients, not very high Roche formula, not very high Roches or Gleasons, and do it with caution, be away from rectum, do it in individual patients, but it's still, we cannot say that it has become the standard of care. Do we agree on all this? Yeah.
Can we have any differentiation based on early adjuvant and late salvage? Maybe that helps in deciding that a late salvage is.
No, salvage is either salvage or if you have to successfully salvage a patient, it has to be early salvage only. You have to pick it up when the patient.
Say patients who fail late, say 2 years, 3 years, maybe in those cases it would be more comfortable considering this rather than upfront adjuvant within few months, and maybe they have much more toxicity.
So early salvage is based on the PSA rise. It is not only based on the duration, it is based on the PSA rise.
I am just creating a hypothetical situation where the early salvage maybe the patient requires after 1 year or 2 years or whatever, based on the PSA rise symptom.
Yeah, so you are saying
maybe the delayed cases, maybe.
But we do not have enough evidence for it as yet. We do not have. It is there. It is there. Tata Medical Center, Kolkata has some data on it. They have some data on it, and I think eventually we're heading towards there. Eventually, with some 4 or 5 years data, you will see it's all over the place. But currently, we are not yet ready. So we move.
Even the post-prostatectomy RT also is not immediately recommended. If at all, it is indicated. So it's always the time is given for the patient so that it recovers from the surgical toxicity, and then we take it forward. So we even now anyhow we wait even when we are planning for immediate post-op RT.
So I think we will move on to the next paper now. So
no, only just waiting means the incontinence part.
Yes.
Yeah.
So it is very important that their incontinence should be taken care of before starting radiation. So it may be 3 to 6 months.
3 to 6 months and not 6 weeks. It's another message in head and neck and in head and necks, and most of the other sites you start adjuvant in 6 weeks. Here you have to wait between 3 to 6 months. Next paper, Sajal, you presented this paper, right? So prostate radiotherapy with adjuvant androgen deprivation versus neoadjuvant and individual patient meta-analysis. Are you happy with what they have done with the meta-analysis, Sajal? I think they have jumbled up a lot. Here they had 4 groups. In the original RTOG 9413, your 4th group, that is post-op followed by 4 months of AHT, they had 30% progression-free survival rate, which has not been mentioned. And they have made a one-liner result saying neoadjuvant is better than adjuvant. Here, this meta-analysis has omitted the whole pelvis radiation. And now they are saying that adjuvant is better than neoadjuvant. Can you put it in perspective?
Yeah, actually, this is basically a good hypothesis generating. They at least tried and to analyze, but obviously these results were quite intriguing and surprising when they came saying adjuvant androgen deprivation is probably given superior outcomes as far as progression-free survival or metastatic-free survival is concerned. As you have already pointed out, RTOG 9413 was quite heterogeneous trial, suboptimal radiation dose. Patients had significant high burden of disease. PSA up to 100 were included. And whole pelvic RT versus prostate only RT. So there are a lot of issues going on with this RTOG 9413. Both of these trials obviously can't be synced together. There is a lot of heterogeneity in that.
I think they have done a lot of jumble up. They have included club 2 groups here, omitted this, omitted one group. Yeah. And
but
even
as the pop RT trial also says, whole pelvic RT is here to stay. So we can't just
for subgroups.
For the subgroup, yes, for the high risk. In RTOG 9413, there are a lot of majority of patients are high risk.
So do we take it?
I'd like to just clarify, because this is very confusing for us also to decide when to give hormone or when we started hormone, when to start radiation. So what is the consensus of the oncologist, radiation oncologist sitting here? What is your practice?
So we start with neoadjuvant hormone therapy. That's the traditional practice, to give 2 to 3 months of neoadjuvant hormone and then start over with radiation.
So wait 3 months, then start
2 to 3 months, yes.
And what is the total duration of hormone therapy? Short,
If
6
it's
months?
a high risk, then obviously it has to be 2 to 3 years, at least 2 years.
Yeah.
So in this RTOG 9413, even there were a lot of high risk patients, but still only 4 months of ADT was given. So that is another pitfall of this trial.
So again, there is enough data to suggest that for high and very high risk, 2 to 3 years of hormone therapy is better than 6 months of hormone therapy.
Unfavorable intermediate, no need to wait for 2 to 3 months. Maybe after 1 month or so, we can start.
I like to clarify one, if I can clarify, please, sir, because this is our confusing things I'm talking here. Will you like to continue bicalutamide tablet lifelong to these patients who have undergone radiation and this?
Dr.
Because
Shaina,
I
I
have
think
seen
we should
practice
ask
of
Dr.
some
Shaina once.
radiation oncologists like that, and we have a fight with them also, but I don't know.
What is the practice here? Shaina, can you just take this on?
So usually we'll start like Dr. Sajal said, so for intermediate risk and high risk, 6 months and 2 to 3 years for high risk. And we'll start some intermediate, high risk definitely start with neoadjuvant hormone therapy for 2 to 3 months and then assess. For some intermediate risk, after a discussion, we sometimes start with concurrent hormone therapy, ADT. And so for the bicalutamide, no, usually we don't have to continue, only if any patients has certain factors like which can cause cord compression or some suspected disease which can flare up. That is when we give concurrent ADT for a month or 2 months and then stop. We just continue the.
So in terms of evidence and level 1 evidence, I think Goserlin has the highest body of evidence. Do we agree with that? Goserlin has the highest body of evidence. And as she said, bicalutamide for a short period for flare is the maximum that we could continue, and not for prolonged period, which we keep seeing in our clinical practice.
I just want to ask one thing. Dr. Sajal mentioned in his slides also that there is always an upregulation of receptors once the radiation is done. So giving adjuvant means once your receptors are upregulated, so probably they are more sensitive to your androgen deprivation therapy.
Once the upregulation of AR receptors are happening, means you will get, there's a high chance of getting failures more.
No, but at that time, if you are giving them
the suppression, so that is why the advantage happens. That's what the authors propose. The adjuvant hormone therapy has a role to play, because post RT there is AR receptors overexpression, which is detrimental for the disease control. So that's why adjuvant suppression should be a part. And obviously in high-risk patients, we give at least for 2 years adjuvant suppression, which was not given in this RDO.
This trial was quite surprising.
So Thiruranjan, gentlemen, quick point from you, because we will have a final opinion from you only. That is adjuvant the way to go, or we are still happy with new adjuvant 3 months radiation and adjuvant up to 2 years for high and very high risk?
For high, very high, I think neoadjuvant, concurrent adjuvant should be the standard of care like we are doing till now.
And for intermediate risk, 6 months, you're
intermediate,
happy
maybe
with?
yeah, short term is good enough. What they made it confusing, like Dr. Sajal said very rightly, that once you know that the ARs are up regulating, then you have given a very short duration. Eventually, they've given only 4 months, 6 months. So neither they met up their own previous publications criteria for intermediate and high risk, nor they have compiled to what should have been done. So that's what is more confusing in this.
Right. So we have, it was presented by the trialist group, only Priyamvada was here. So prostate only versus whole pelvic radiation therapy. We heard about POP-RT. A sport, anyone wants to talk about short-term androgen deprivation therapy, about that trial? Priyamvada? A sport trial results are out, early results, and what is your take on it? That is 6 months of adjuvant androgen deprivation therapy with whole pelvic radiation, or the third arm is 6 months whole pelvis and prostate only, and prostate. So
are you referring to the post-operative setting, sir? The RTOG sport trial?
Sports.
Okay. So the major difference is that POP-RT is for definitive radiotherapy and the sport trial is for post-operative radiotherapy. And the benefit of pelvic RT has been seen in both the POP-RT trial and the sport trial also. Addition of 6 months of ADT, I would really like to see the full paper on that because all I know that the abstract is there and the main results are there. And for the POP-RT trial, we have given a uniform duration of ADT. So the question of ADT is not there in our trial. And for the sport trial, so based on those results, we are adding short-term ADT for the patients who have multiple high-risk features.
So, Thiruranjan, Robin, Sajal, radical setting, high risk, very high risk versus intermediate risk. Where would you be selecting whole pelvis radiation? All comers, only high risk and very high risk, and your policy to substantiate it?
High risk, undoubtedly, we have to treat pelvic nodes.
And what will be the benchmark? Roche formula, is it?
Yeah, Roche
Or
formula.
some-
We can also do, there's one MSKCC formula. We can also apply that. There's a modified Roche formula as well, because at the time of original Roche formula, the PSA detection was not ultra sensitive. So it is further strict, but with all available data, we should always treat pelvis in high risk.
Sajal?
For high risk and very high risk, I agree with Thiruranjan. We will go with the whole pelvic RT.
Adjuvant setting, when will you treat whole pelvis? And do the surgeons have a concern if they treat whole pelvis after that?
So I think we let that decision be taken by the radiation therapist. We really don't have much of a role to play once we refer the patient to the radiation therapist as such.
No, but patient will come back to you saying.
Yeah, I mean, definitely once in a while, we do have these discussions.
No, our concern is for the toxicity, GI toxicity actually, because I have seen a lot of patients coming back to us with rectal bleeding and all those kind of things, and plus also radiation cystitis.
But
quite a good number of patients are suffering because of that.
But the trend towards best results are actually in the high and very high risk. In the sport trial, or whatever you call it, sport, SPPORT, in adjuvant setting, is in the group which has received pelvic radiation, and that is towards the trend towards that.
I think with daily image guidance, if your bladder and rectal protocol is strict from the day of planning, I think Sai would agree, we hardly see bleeding PR. It's maybe grade 3 toxicity, maybe less than 2%. Even on long-term follow-ups, I'm working in my current center for 5 years. close to 70 prostate patients must be treating, combining radical and adjuvant. I have not at all encountered a single grade 3 toxicity.
Fine. So even
So
NCCNs.
I don't think it is at all a point of discussion in IG-IMRT era. This is not at all a point of discussion.
So
we are seeing the patient. Even one patient is there in my ward today. So what I'm trying to say, don't say it never happens or something like that. That never goes in practice.
That's less than 3% even across literature with IMRT series.
And
So one of the patients will have, sir, that's anecdotal.
And sir, it's
I know.
mostly
Other
because
thing
of
is,
the
other
primary
thing is, last RGCon again we had a similar debate where forget about the toxicity. People conceptually never believed in whole pelvic. They feel it's a metastatic disease, and if you are having to radiate pelvic nodes in radical setting, you are treating a metastatic disease. So either I treat prostate alone or whole pelvis. So Sajal, you have a take on that? And we'll have to move on to the next abstracts.
I think as far as the rectal bleeding is concerned, so it can happen even with prostate only RT if it all has to happen. So with whole pelvis, we are more worried about the bowel toxicity.
The bowel toxicity.
So with the kind of dose what we are using, 45 to 50 gray, I think, and with IMRT, probably bowel toxicity are not that of a major concern in whole pelvic RT.
It's not a major, it is of concern, not major concern, but it is of concern. It's of some concern.
So surgery has been done, so chances of subacute obstructions are always there.
It is. Anyway, so to call that abstract a day, NCCN has also said that for high risk and very high risk in radical setting, whole pelvic radiation, that means nodal radiation, should be considered. Adjuvant, of course, data we have discussed is emerging. Talking about just one word about this, brachytherapy. How many centers are doing brachytherapy in India? High dose rate brachytherapy. Actual physical brachytherapy and virtual brachytherapy. Virtual means only verbal brachytherapy. That is all virtual. So I mean, it's very few centers in India who are doing. So can we consider SBRT boost? What do we lose if we consider SBRT boost? Because the biological equivalent dose of the brachytherapy arm, Arpita, you can put in a word here, was much higher. So what happens if you put in a SBRT boost? Can we achieve similar controls? And is there any evidence to that?
There are phase 2 trials that are underway that are comparing HDR brachytherapy with SBRT. The primary concern with SBRT boost is urinary toxicity. So they're trying to see whether urethral sparing with SBRT may be safely delivered without any increase in relapses in that area.
NCCN is also very clever. They write everything. Everything is level 1 evidence. EBRT plus ADT is level 1. EBRT plus brachy with ADT is level 1. Abiraterone in Stampede trial has the data now, but that is also level 1. In fact, actually coming to abiraterone, I don't know why we are not recommending it. It is good data. Stampede is a good data. I think we should start. It's just become one option, but it is clearly shown that it has helped. Randeep, you think that it has significance, right?
I was aware of that data, but yes, that is quite encouraging. At 10% absolute advantage in overall survival makes a definite thing. And abiraterone is a very well tolerated drug. It does not add to toxicities in the post-operative setting.
So we should.
And we shall at least in a node positive patient who has been operated shall be subjected, and there is no interaction between abiraterone and radiation.
So I think now finally I can involve Dr. Ajay Vyas here. Yes. So Dr. Ajay, talking about this trial, when after surgery should you do PSMA PET? Should it only be PSMA PET? How frequently? Or you have any other radio tracers?
So at present, we have one of the best tracer is the PSMA PET CT right now. We have only few, like about 7 to 10%. We have a negative results because of the neuroendocrine component or very poorly differentiated carcinoma involved. So right now PSM is one of the best tracers we have available here. And the newer one is FAPI. Gallium FAPI is coming up, but it's for basically all the cancers, and even PSMA is very good even for the vessel metastasis. You have to pick up the vessel metastasis quite well.
Shaina, do you think PSMA PET should be for the diagnosis of all prostate cancer patients, and we should be offering PSMA, or it is just optional, as NCCN says it's optional?
So as a practice, we offer it for all patients except maybe low risk and very low risk. other than that, we have to evaluate. So bone scan was always a part of metastatic workup. So it's easier to do a PSMA PET scan, which would give better sensitivity.
And if you are doing a PSMA PET scan, irrespective of that for locally advanced disease, what we are discussing here, should we also perform a multi-parametric MRI, whether you have performed a PSMA PET CT or not?
Yes, for the local staging, yes.
It should be irrespective of a
Yeah.
PSMA PET CT,
Yes, sir.
right?
So I want to add one thing, sir. All the imaging modalities, they are, on the always a backbencher. If you see all the protocols, but this is definitely good if you compare with all other whatever's available you have. And one more thing, the FDA got approval of this tracer in September 2021. So fortunately, we got a FDA approval of this also.
Okay. So Dr. Vyas, Dr. Ashwin, sorry. Why do you think the surgery arm did badly in this or worse than radiation in this? Is it because a lot of them had initial pelvic lymph node dissection or incomplete pelvic lymph? So this was just to put it in perspective, it was a trial which isolated nodal recurrences after RP.
Yes.
And they were treated either with surgery, lymph nodal dissection, or with radiation, and the radiation did better. So do you think there was any surgical reason for which radiation to do better?
So my interpretation of the paper was that surgery did better, actually. Yeah, because I was going through.
I mean, 95% times, that is about 5%, we should also have some.
Yeah. So talking about for nodal recurrences, when we're looking at surgery, so if it all depends on the size of the node as well. Okay, and how well we can do a salvage lymph node dissection. Again, it depends on. So if you see the average number of nodes that were retrieved was around 9, and the number positive was around 2. Okay, so I feel it all depends on the quality of the surgical. So I don't know how homogeneous that was in this trial. So I think depends mainly on the size. If we can have a good template dissection in the salvage setting as well. And because in our radical prostatectomies, when we are doing extended pelvic lymph node dissections, we get around 15 to 25 nodes. So if there is a salvage, that I think we'll have to be more careful. The template
So
will
it
have
is
to be
about
increased.
good surgeons and bad surgeons.
I think it all depends on the learning curve of each center. And not all centers will have the same homogeneity. Probably the trial also has the same limitation.
No, I have experience of treating these patients of the positive lymph nodes after radical prostatectomy, and we have done the robotic salvage lymphadenectomy. The question is, at that time, I have some patients who have gone for treatment to US also. I reviewed the complete literature. So there is still confusion whether RT should be given to these patients or we should do salvage robotic lymphadenectomy. And then only lymphadenectomy alone may not be enough for these patients. It depends upon their initial grade of the tumor and all that. So you have to give adjuvant radiation as well as hormone therapy also. So this kind of treatment is some of my patients still taking, and after that they are doing well actually. But overall, the prognosis of these patients is not very good.
I think in the surgery arm, ADT was not given.
No. So they again here they fortified the radiation arm. Somehow it happened as if they wanted to make it better and happen. But having said that, they have used 66 grain 33 fraction. Why not have hypofractionated or a radiosurgical approach, Trinanjan? Do you think that works well? Oligo recurrence, and why not stereotaxis?
Probably the reason is because they were RT naive. So that was the radiation in them considered to be more like a salvage scenario with
better data for oligo.
Yes,
for
yes,
oligo recurrence with radiosurgery or
yes. In my last slide, that's what I put, that there are actually better data now with maybe because node only are curative.
And
as of
Trinanjan,
now.
word of wisdom from you about what to contour: only the node, the surrounding region, ipsilateral nodal stations, or the whole pelvic nodal stations?
Probably node with a certain margin. Probably I can limit to that if it's just a one node or maybe just a two node in the same nodal station. like say both internal iliac.
Once the nodal recurrence has happened, so it's better to
You
treat
should
that chain
treat the
and
whole
leave.
nodal chain.
When the
So
nodal
actually
can
the
give higher, with simultaneous boost, you can give higher dose.
we can do that, but there's no difference as of now in whatever prelim data available. The Italian group has done extensive. Yes, then we should treat the whole nodal level. I just want to, because you were discussing, put
I
one
don't know.
point that
Oh my God. That opens up a Pandora's box.
Yes.
So now you have a recurrence of 2 centimeters in the lung. Do you treat the ipsilateral nodal stations because that is going to be the highest possible nodal recurrence?
No, we don't do that.
Then why are you being so merciful to prostate?
Because see, this patient has never received RT, and as Sanjay said, if it is a
But this patient never needed to receive RT before. It was a surgical treatment, isn't it?
It was all
Did they
post
require
RT.
Yeah.
No.
No, I'm just playing the devil's advocate. I mean, I agree with you. Priyamada wants to say something. Yeah.
In which they have either treated the node only at recurrence or node plus a lower dose to the entire pelvis.
Chain, okay.
And they saw that the recurrence was less
With the nodal stations, right?
So I like to make a comment here, because what we are picking up by PSMA, PET CT, or by any other kind of imaging is usually when the lymph node is at least 0.5 centimeter. So micro metastasis in other lymph nodes will be there. So it is a wise thing that we should cover the complete chain or complete pelvis, according to me. If nodal recurrence I am talking, so better result will certainly be there, and she already endorsed on that point.
So we do not have robust evidence, but Priyamvada came with some evidence which talks about and the concept of micrometastasis versus the concept of, I mean, then you treat everything prophylactically. But it may be prudent to at least consider that, not only that node, but at least that station or the ipsilateral nodes. It is just a concept. It's not backed by evidence. Evidence is just emerging. Last abstract. Shaina, you can run us through the last abstract. What is your take on it?
So as Dr. Randeep sir said, so this is a very interesting data and quite encouraging, because we have we know that especially in high risk patients and the ones who have a Gleason score 9 and 10, those are the ones who would there was a meta-analysis which showed that even long-term ADT for them showed benefit. So therefore, with this intensifying our ADT 2 years, 3 years ADT with another 2 years of abiraterone, knowing that it is well tolerated, I think I would consider it for most of my patients.
And what about Enza?
So as the trial did not show, means adding Enza to abiraterone, it only increased toxicity and did not improve outcomes.
So there was no significant difference if you added Enza to abiraterone. Of course, there was a difference if you added the combined therapy group had a benefit, but adding Enza over abiraterone did not have a benefit.
So yeah, and the survival benefit was almost 9% with a metastasis free of 13%. So yes, this is a very encouraging data now.
So fine, I think we conclude here. Just one word, one quick comment from each panelist about locally advanced prostate cancer. Anything that you want to share with this thing? We can start with you, Shaina.
So from these abstracts that we discussed, I would like to make a small point about the initial data, which was on the sequence neoadjuvant ADT versus adjuvant. So I think that so intermediate risk is the one I think which needs to be studied further on using adjuvant ADT rather than neoadjuvant.
Sajal, one quick point.
As far as high risk and very high risk is concerned, neoadjuvant hormone therapy and followed by radiation and plus prolonged 2 years of ADT is the traditional practice.
Great.
In intermediate risk, as she has suggested, probably we need to discuss more whether neoadjuvant has any benefit or not.
I think for me, the sequencing was the new thing, and I think that should also be looked into. Yes, our current practice is neoadjuvant, but definitely that trial does have some meaning.
Okay, Nanjan.
For me, it would be for a radical setting, hypofractionated schemes are here to stay, and maybe further extreme hypofractionation for intermediate. We have good data by SBRT, and also slowly for high risk, also with pelvic nodal. Eventually SBRT would set in for prostate.
So from the surgical point of view, more and more data will be emerging on neoadjuvant hormone therapy and abiraterone as well prior to surgery in the locally advanced setting. So we'll have to watch out for that.
Dr. Vyas, from you.
So PSMA is one of the best tests available we have right now.
I hand over to the chairpersons for their final. Thank you.
No, I'll start the other way around. I agree with him. Now, when we see advanced cases or metastatic, we have a doubt, means PSA level is equally important. So there PSMA PET CT is the modality of imaging for us. As far as treatment is concerned, for patient counseling point of view, I'm talking, I always tell my patient that the high risk patients or locally advanced cases, you need a multi-modality treatment. One modality is not good enough for you, whether it is radiation, whether it is surgery, or it is hormone therapy and now chemotherapy and immunotherapy. So patient has to understand from day one that we are dealing with a high risk disease and he should be mentally ready. The sequencing, what you want to do, surgery, radiation, or which kind of hormone, that is an individual choice.
I think sir has summed it up very well. It's a multimodality treatment. From radiation perspective, I think we all have adopted moderate hypofractionation for our patients in definitive setting. It is going to come in for the post-operative setting also, and data for oligo nodal recurrences with the help of a little more extreme hypofractionation, I think will take some time to come up, but it will come up initially.
Earlier than 2 years in high risk or
In
very
high
high
risk.
risk. Yeah.
Not
Age,
tolerating well.
cardiovascular morbidity, any such factor?
Well, you have that Degarelix is available for that too. Yeah, let Randeep answer that.
This happens at a very long term. We have never seen when we follow these patients for 2 to 3 years subjecting to a cardiac, but yes, when they are in a metastatic settings, I have 2 or 3 patients who have suffered a myocardial infarction without a risk. But these are long-term patients. In 2 or 3 years, I think this will rarely happen unless someone is really, because of ADT, it will not happen. And Degarelix versus this is not having a major difference. In the initial phase, there is some data in the initial years, but later on, there is no difference in the long-term cardiac toxicity of Degarelix versus.
I would like to make a comment. Recently, I have come across with a new concept, which is known as oncocardiologist. So what they have come up, that they have identified one cardiologist who's looking. No, sir, this is fact that.
Yeah, I agree with you. I agree with
side
you.
effect of the ADT,
Of course.
most of the time they are more involved in other things. So they now, even if we are, first of all, as a urologist, we are not sending the patient, we are not counseling the patient. That okay, you require a regular cardiology evaluation, regular endocrinology evaluation, and even if they are going, they don't have any time. They simply ask us, why you send us? What should we do? So there is a new concept has come.
He is the driver of Cardio-Oncology Society
so
of India.
They have come up with this thing, and we have also tried the same thing in our hospital. We have identified one person, and we have tried to sending him, and we have told him that what all we want to see him, and hope so that in coming future the things will be better.
So actually, the advice is that if you are planning for a hormonal therapy, cardiac evaluation should always be done. That is our practice.
Sir, initial cardio evaluation is must, but it is a regular follow-up also required to identify the risk factors and to see the problems early, because it is not the only pre-existing cardiac problem, but it is the problem which will going to develop or worsen over a period of time because of the hormonal treatment. That also has to be seen properly.
So Vivek has taken a lot of effort into cardio-oncology. Let us hear from
So we have already started an Asian Cardio-Oncology Society. And currently, I'm looking after this society. And basically, in this society, we have already conducted multiple meetings, which are available on YouTube. And I remember we had a very good meeting on prostate cancer, where we discussed regarding the cardiovascular effects of this thing. It is important that there are established European society guidelines, which are already giving clear risk stratification of all prostate cancer patients based on what treatment you are planning. So there is a cardiac risk stratification already existing. And based on the cardiac risk stratification, there is already a tight follow-up or a tight medication control or a tight symptom control already suggested. So if it is not possible for a regular clinician or a regular medical oncologist or a radiation oncologist to be that specific. So just as we have a geriatric clinic to refer to look at the finer geriatric points. We have to develop cardio-oncologists in our own setups to look at these finer points. It is not possible, certainly, in a regular clinic to look at these finer points, but
So-
it definitely required.
I think we will need to close the session now because of constraint of time, but I think we had a wonderful session, very interactive. I thank the chairpersons, all the panelists and audience for all the participation they have done. Thank you. Sign is the sign.
आगे आ जाओ।
CMC will, right? Yeah.
I would like to thank the chairpersons, our speakers, moderator, Dr. Kostav, and all the panelists. It was really an interactive session. Though we were able to address a lot of controversies, but still so many more issues remain unaddressed. And I think future prospective trials will answer some of them in the next few years. So now we break for a short tea break, and we return for the next session on prostate cancer metastatic after 15 minutes.
फिर
वो प्रोजेक्टर पे वो बटन वाला फिर कुछ काम का ही नहीं होगा।
तो इधर दिख रहा है, इधर आना आप साइड क्या होता है
Mainly the people will look like this. मतलब full audience वहाँ बैठती है ना. You will continuously look on speak.
इसको elevate करा दो.
Look there. And दूसरा एक चीज है ना. इधर बैठे थे.
टेबल इसलिए रखा था बिकॉज़ वो हमने कंसोल वो जो
थोड़ा दूर रखना था. टेबल इधर लेते वो टेबल उधर ले.
इसको उठा देंगे ना. इसको उठा देंगे तो वैसे दिखने लगता है. अभी कर लो तो दिखता नहीं.
थोड़ा सा इधर बीच में से दिखेगा. थोड़ा उधर एटलीस्ट चेयरपर्सन सेंटर में बैठेगा अभी होता है तो एलिवेट करो.
इसको एलिवेट कर दोगे ना तो ये नॉर्मल
तो दिखता नहीं.
यहाँ से दिक्कत आ रहा है दिखने में. आगे रहता है ना,
इधर कंप्यूटर रहता है तो
तुम सामने देखते रहते हो. हाँ, क्योंकि स्लाइड हाँ इसको ऊपर कर दे.
बैठे तो दिखेगा नहीं। विजिबिलिटी होना चाहिए उधर नहीं है उधर लगा उधर नहीं है उधर शायद उसमें सीधर कर दिखता है वो उधर पीछे जाएगा तो डिस्टेंस ऑटोमेटिकली बढ़ जाता है
उधर चला जाएगा दिख जाएगा
हाँ
दिख जाएगा
कोई टेंशन
इधर से उनको ये छुप रहा है ना इसकी वजह से उधर जाएगा तो देखिएगा ना
वो यहाँ खड़े हो रहे हैं इसको थोड़ा सा एलिवेट करना है
पीछे जाएगा पीछे जाएगा
सर पीछे नहीं कराना प्रॉब्लम इज दैट कि उनका कहना ये है कि जब वो पोडियम पे खड़े रहते हैं तो लोग है ना से नीचे देख के ही बात कर रहे हैं वो बाकी के कंटेस्टेंट के साथ उनका अट्रैक्शन नहीं होता है मतलब यहाँ से ना वो नीचे देख देख के कर रहे हैं मतलब यहाँ पे कोई खड़ा है ना तो प्रॉब्लम इज दैट कि वो स्क्रीन दिख रहा है बट वो उनको उधर ही देख के बात करना पड़ रहा है दे कैन नॉट लुक अराउंड और एल्स उसको बीच में और एल्स उसको यहाँ पीछे करवा दो जहाँ पे सर खड़े हैं ना वो हाँ वहाँ पे करवा दो सो दैट दे कैन इंटरेक्ट विद पीपल ऐसा लग रहा है नीचे देख के बात कर रहे हैं फोटो में भी नीचे ही आ रहा है फिर वो वेस्ट हो जाएगा ना अभी इतना किया है लैपटॉप के लिए फिर वो नहीं वहां रख रहे वहां नहीं रख रहे
put in by my surgical and radiation colleagues. Like many other malignancies, the non-metastatic segment of patients in prostate cancer makes the tip of an iceberg only. So now let us meet the iceberg. For that, I request and invite our chairperson, Dr. Randeep Singh, Director and Senior Consultant, Narayana Super Specialty Hospital, Gurugram, to come on a chair and chair the session.
Thank you, Dr. Darling, and a warm welcome from the organizers side. I think we will start with the session. The session is mainly metastatic prostate cancer. And it is heartening to see that the first abstract in metastatic prostate cancer is being presented by a surgical oncologist and Dr. Ganesh Bakshi, sir, sharing the same alumni and being trained under the guidance of sir. Sir, over to you. He will be talking about oligometastatic prostate cancer, and he has 2 abstracts.
Yeah, thank you so much for giving this opportunity. The abstract is about cytoreductive surgery for oligometastatic prostate cancer. Now, we all technically know that radiation has a role here, clearly. It has been gone through HORAD's and STAMPEDE data. So for the background, the definition of oligometastasis, which itself is a big topic of debate, but we usually take up to 5 metastatic sites, but not visceral in those 5. And cytoreductive surgery is an extensive discussion. There is no consensus on that cytoreductive prostatectomy, if I mention like that. So this is a basic hypothesis, reduces body tumor burden to number of tumor cells and decreases the cytokines that promote tumor growth. It improves the sensitivity of follow-up endocrine or chemoradiation or whatever we can give to the patient, and basically also alleviates the local symptoms which may be due to obstruction, hematuria, caused by the growth of the prostate, and thereby it may improve a quality of life. So this is one of the papers published in 2021 World Journal of Surgery, and purpose was to evaluate the effect of cytoreductive surgery for oligometastasis. That they had a meta-analysis published. So this was the inclusion criteria. All patients confirmed of prostate cancer. Intervention measures were endocrine therapy versus endocrine therapy and surgery. So surgery is added in one group. Focus of the study was prognostic survival analysis, and sufficient follow-up data were used in this meta-study. Now, this is a meta-analysis, lot of studies selected and some finally selected for the actual analysis. So going through the whole papers, the 2 groups were actually the standard therapy and standard therapy plus surgery. Type of study was as mentioned, and exclusion criteria, review and other secondary literature case reports were all out. Animal research regarding prostate, which included metastasis, out. Other transition states that do not include the definition or fit the definition of oligometastasis, out, and the other literature which you don't get enough data, that was also out. The slide is going slightly outside, but this was the overall data or the rough data about the studies, the 10 studies finally selected. The outcome measures in this meta-analysis, primary was OS, secondary was cancer-specific survival, progression-free survival, and progression to castrate-resistant prostate cancer. There were 3948 records or literature studies which were initially selected, finally boiled down to 10 articles. 4 were included for the OS, 6 for the CSS, and 4 were used for the PFS, all retrospective. There were 449 patients in the tumor reduction group, 355 in the endocrine therapy group. Efficacy of cytoreductive surgery, what was seen actually? So overall survival, the result showed significant difference in OS between 2 groups, HR of 0.52, P 0.001. Tumor reduction can improve the OS in OMPC. If you see the CSS, cancer-specific survival, again, differences between the 2 groups with the HR of 0.33. So that is also quite significant. P is 0.001, suggested it would also improve CSS. It also improved the PFS actually with the HR of 0.45 and a P value of 0.001. Had no great difference in the progression to castration-resistant prostate cancer, however. So there the HR was 0.72 and the P value came in insignificant. So this was the forest plot for the OS, little bit on the cytoreductive surgery side, as with CSS, as with PFS actually. So if you see the diamonds everywhere, they are on the left of the line. The study meta-analysis did have a high credibility. They had applied all the procedures properly while doing the meta-analysis, and the results of this meta-analysis compared with only endocrine therapy, tumor reduction surgery could improve the OS, CSS and PFS of the patients with oligometastatic prostate cancer, suggesting finally that tumor reduction surgery may be a better method for treatment of oligometastatic prostate cancer. Now, there is no comparison anywhere here with radiation or anything. So it's not surgery against radiation or anything. This is plain addition of surgery in this stage of disease. So limitations where it was difficult to further get into the subgroup analysis of these results. Clinical stages were slightly different. There were 10 studies in the end. So some had lymph node mets, some had actual mets, some had bone mets, some had no bone mets. Some would have retroperitoneal lymph nodes. So the sites and everything was quite different. So the large samples, the two large samples in the studies used for the OS analysis did not have much information about the metastatic burden and site. Main source of patients included again were from Europe and USA. So it was all probably Western data. And again, it makes the guiding value of this study for Asia Pacific or other patients slightly difficult. Now, the other standard limitations are retrospective studies. There are selection, reporting, and follow-up bias. Then lastly, this literature was from 1997 to 2018. So again, there is a span of 20 years where a lot of definitions, investigations, treatment modalities, everything has changed. So maybe all this has some element in adding to the bias. More random clinical trials may be needed probably even after showing in this that tumor reduction surgery was quite effective. So this was the second paper published in BJUI, the trombone trial, feasibility and safety of radical prostatectomy for oligometastatic cancer, the testing radical prostatectomy in men with prostate cancer and oligometastasis to the bone only. So with this, the objective was to test the feasibility of RP plus pelvic lymphadenectomy in addition to SOC, that is standard of care, which we have today. Prospective, randomized, non-blinded feasibility clinical trial. 50 men were randomized over 8-month period, and to standard of care systemic therapy versus standard of care plus RP in the intervention arm. Patients had QOL questionnaires. After that, their clinico-pathological assessment was outlined to capture the adverse events and their QOL data, and peri-op parameters were recorded in the surgical arm. In the result, a total of 51 men were randomized within 14 months. QOL data showed high functioning, similarly high functioning in both study arms. Surgery for men with oligometastatic prostate cancer was found to be absolutely safe and had similar impact on early functional outcomes as surgery for standard indications. I mean, when we do surgery for other standard radical prostatectomy is done for standard indications, which we usually have. So this concluded it's feasible to randomize men with synchronous oligometastatic prostate cancer to a surgical intervention in addition to standard systemic therapies. So while surgery appeared safe with no substantial impact on the QOL in this feasibility study. So thank you.
So we will take questions later on. So the next abstract, can we have the slides, please, Pooja? The next two abstracts are quite, interesting, at least for the medical oncology and for the others also. This is about piece 1 and arrescence. It is about the triplet regimen and pushing or throwing everything at the time of diagnosis of a metastatic prostate cancer. Pooja, slides. So the okay. So the first paper will be the piece 1. This is abiraterone plus
prednisolone added to androgen deprivation therapy with docetaxel. So it's a triplet regimen: androgen deprivation therapy with docetaxel, with abiraterone or without abiraterone. 2x2 factorial design, phase 3 randomized trial. The inclusion criteria: all male patients above 18, confirmed de novo metastatic prostate cancer. So this is at diagnosis. The conventional radiological techniques were used for diagnosis. Performance status 1, and they were randomized 1:1:1. The total sample size is around 1:1:3. The standard of care, as we all know, in 2013 was androgen deprivation therapy for a metastatic prostate cancer, either surgical or LHRH agonist. This was in 2013. The first amendment happened after charted data in 2015, where the docetaxel was added to this standard of care. That is, ADT plus docetaxel became the standard, which is one of the control arm of the piece 1. The second randomization happened after the abiraterone of latitude data came. And then at this point of time, the investigators thought of checking whether you are giving ADT plus docetaxel as one standard versus ADT with docetaxel with abiraterone at the time of diagnosis. Also, radiotherapy was included. The radiotherapy results, because of the lack of immature follow-up data. I mean, there is an immature follow-up data, and those results of including radiotherapy in this setting is not being presented in this paper. This is a full text which has been published in the Lancet by Karim Fazazi et al. So the standard of care, as you can see, is alone ADT plus docetaxel. Then it is ADT plus docetaxel with abiraterone, and then it is with or without RT. So it is a bit of confusing. If you concentrate on the next slide, basically the trial aimed at giving standard of care with docetaxel as one arm, with or without abiraterone, and it is with or without RT. That is why it is called 2x2 factorial design. The primary endpoint is a dual co-primary endpoint of PFS and OS. The secondary endpoints are multiple, but they are majorly the endpoints such as PSA response rates, the prostate CRPC-free survival, the PSA specific survival. We will concentrate more on the primary endpoints in the interest of time. The inclusion criteria, the median age is quite favorable. As you see, it is 66, which I will see that it is favorable because the patients are being subjected to triplet therapy. The second important point is that they were majorly bone-only metastasis. Lymph node and visceral metastasis combined only were 20% in this subset. All were Gleason high grade. If you concentrate on the high and low burden, 50% of them were high burden disease and another 50 were low burden disease. Coming to the results, the first is the radiological progression-free survival. The statistical analysis and plan was in this way that if the overall population was showing a significant PFS, then the statistical analysis will be applied to the ADT with docetaxel population. So if you see the radiographic PFS, the p-value cutoff was 0.001 and it was met in the overall population. The red arm is a triplet regimen, that is LHRH analog with docetaxel with abiraterone, and the blue arm is without abiraterone. Also, when you give ADT with docetaxel with or without abiraterone, there is a significant radiological PFS. The OS in the overall population was also significant. The p-value which is written in the black bold is the cutoff p-value, which was 0.049 to be significant. ADT with docetaxel also met the significant overall survival advantage, and this is the primary endpoint, and this is a positive trial. Coming to the crux of the discussion, whether we use ADT with docetaxel with abiraterone in a low metastatic burden or a high metastatic burden disease. The classical charted criteria of low or high burden was used, that is visceral metastasis or 4 or more bony metastasis with 1 bony metastasis in the non-axial site. Now, when we see the overall survival in the low metastatic burden, the p-value was 0.66, which did not meet the significant the boundaries and the limits of the significance. But when we switch to high metastatic burden, though the curves are separating at 1.5 to 2 years, but the p-value was 0.019, which was significant again. So the median overall survival, if you talk about absolute terms as written below, median overall survival in high burden improved from 3.47 to 5.14 years. And I leave it to the discussion part that whether this is significant or not in a metastatic prostate cancer. Median OS cannot be interpreted in low burden because the immature data is there. And if you see the curve carefully, the median PFS has not been met in the red arm, it is still above 50% in the Kaplan-Meier curves. When we talk about median PFS, now the median PFS in low burden disease has increased from 1.6 to 4.1 year, which is around 3 years absolute PFS advantage. But because of immature data follow-up, this p-value was not significant. Whereas for high burden, the median PFS increased from, I am sorry, there is some figure missing in the high burden, but high burden PFS was also significant. Whereas the PFS for the low burden was not significant. 1.6 to 4.1 is the high burden disease. Whereas in the low burden, the median was not reached versus 2.7 years in the doublet arm. Coming to the Kaplan-Meier, I mean to the forest plot, the most of the diamonds are on the left-hand side favoring the triplet regimen. The one where you can see the confidence interval crossing unity was the physician decision, but that was just 42 patients out of the whole subset, and that is because of less patients, the confidence intervals are wide. I will just skip OS also. I will come to the side effects and then go to the second presentation. There were two significant side effects with the triplet regimen. One was hypertension, which was double, 13 versus 26%, and one was hepatotoxicity, which was 6 versus 1%. So there was a significant difference when you combine ADT, DOSI, and ABI. Coming to the next, I will just rush it in the interest of time because the schema is same. The drug here used is darolutamide. In the same, darolutamide is not available in India, but it is again a novel androgen receptor blockade. The schema is absolutely same. Docetaxel 6 cycles with darolutamide with gusorelin versus only docetaxel. Here the primary endpoint is only overall survival. Here 85% of the patients were de novo metastatic prostate cancer, but another 15% of the patients were those who were initially diagnosed as localized prostate cancer and then they metastasized. But the majority of the population contributing to this data set is de novo metastatic prostate cancer. Again, the overall survival, you can easily see the curve separating very well till the end. The hazard ratio is 0.68. That amounts to 32.5% reduction in the risk of death when the triplet is combined. Also, in the absolute terms, if you see, there is a 10% absolute survival advantage when the triplet is used. Coming to the forest plot, the lymph node metastasis was having a very wide confidence interval. Again, the numbers are only 5 out of 23 and 5 out of 16. That may be the reason. Whereas most of the other diamonds are in the favor of triplet regimen, with some of them do crossing the unity as far as the confidence interval is there. Coming to the de novo metastatic versus recurrent metastatic, there is no difference in the hazard ratios, 0.6, 0.7, but minded that the recurrent metastatic patients were only 15% in this trial. But if you have to believe in that data, yes, both de novo and recurrent, but these are all HSPCs, none is HRPC here. Other secondary endpoints, time to CRPC, time to pain progression, and there were another 7 secondary endpoints which were also there in the piece 1. All of them did show clinical as well as statistical significance. Majority of these patients who are showing overall survival, it comes to the mind of the house as well as when you read the paper that they, what other subjective, whether they were subjected to adequate systemic therapies or not. And if you concentrate on ADT plus docetaxel, they have been subjected to abiraterone 45%, enzalutamide 27%, cabazitaxel 18, docetaxel 18. So all of them have been subjected to sufficient effective systemic therapies. Coming to toxicity, I mean, the same thing is seen again here, hypertension and mild increase in SGPT, but the increase is not that much as we see with abiraterone triplet. Darolutamide triplet appears to be better tolerated, but as far as hypertension is there is again a significant difference, 6.4 versus 3%. So to conclude, these are author's conclusion and not mine. I will just read it as verbatim. Piece 1 is the first trial to show a triple systemic therapy consisting of ADT, docetaxel, and ABI, improving both RPFS and OS in patients with de novo metastatic castrate-sensitive prostate cancer without excessively increasing toxicity, minus hypertension and SGPT raise. Arasens, which also reveals that darolutamide in combination with ADT with DOSI improves overall survival, as well as multiple other clinically significant secondary endpoints in both de novo or recurrent metastatic HSPC patients. I would also like to make a comment here that there was some signals in the Enzamet trial, if you have gone through that, where enzalutamide was combined with ADT and docetaxel. But there, the main aim was not to do this. And that signals were already picked up by the researchers in 2013, 14, 15. And they could easily show that triplet regimen, at least for high risk burden, is the way to go forward. Thank you. I think we'll keep the discussion part for the later. I will now invite Dr. Vivek Agarwala, a dear colleague from Narayana Super Speciality Hospital, Calcutta. He will be talking about, again, metastatic HSPC, final overall survival of ARCHES. ARCHES is a randomized double-blind controlled trial of a doublet, enzalutamide with ADT.
Thank you, everyone. Good evening. And I thank the organizers for giving me this opportunity. Next slide. So today I'm presenting the final overall survival analysis from the ARCHES study, which was a phase 3 randomized double-blind placebo-controlled study of enzalutamide plus ADT in men with metastatic hormone-sensitive prostate cancer. So we all know in the current era, ADT alone is a suboptimal treatment for hormone-sensitive metastatic prostate cancers. And the way to go is addition to ADT of androgen pathway inhibitors like abiraterone, apalutamide or enzalutamide or docetaxel, or both of these agents, just as how Dr. Randeep described. And enzalutamide plus ADT is approved for metastatic HSPC as per the Enzamet study as well as the phase 3 ARCHES study. And ARCHES primary analysis was published in 2019, where enzalutamide plus ADT significantly reduced the risk of radiographic disease progression by 61%, which was the primary endpoint. It also improved multiple key secondary endpoints while maintaining a good high quality of life. And overall survival data was immature at that time. In this study, which was presented last year in ESMO, they presented the overall survival, which was a key pre-specified secondary endpoint, along with the updated safety analysis as well as time to subsequent new anti-neoplastic therapy. So this was the design. They included all metastatic HSPC patients whom they had received ADT within 3 months, or if they have received docetaxel within 6 months of receiving ADT. And patients were also stratified as per their volume of disease, high versus low, or whether they had received prior docetaxel or not. It was a 1:1 randomization, enzalutamide versus placebo plus ADT. And based on the clear benefit of enzalutamide, it's an interesting analysis that after the primary analysis, the study was unblinded to allow patients who had received placebo plus ADT to cross over to the enzalutamide arm as a part of an open label extension protocol, which still remains ongoing. So this is the most important slide as to what was the patient selection. So please note that although the high disease volume was almost more than 60% in both the arms, and Gleason score was more than or 8 in both the arms, the patients who had visceral disease was only 11%. Patients who had distant metastasis at diagnosis was 70%. That means 30% of the patient did not have distant metastasis at diagnosis. Patients who had received prior therapy, so almost 17-18% had received docetaxel, and median PSA was 5. So in your clinic, metastatic hormone sensitive prostate cancer de novo, how many patients would you have with PSA of 5? So just think about it. Yeah. Almost 25% had received prior local therapy in terms of surgery or radiation, and 15% of the patient had completed 6 cycles of docetaxel. 3 months of ADT was given to almost 20% patients, and median duration of prior ADT was 1.6, and previous use of anti-androgens was there in 35% of the patients. So these are important, baseline characteristics and patient selection things that you are seeing. And as we all know, patients who are de novo metastatic, they do poorly as compared to patients who had received prior localized therapy. And if you look at the other HSPC studies, they had all included more of de novo patients, but ARCHES study included only 67% de novo patients. So almost 33% patients had received prior local therapy. So when you look at all this, yes, there was a good overall survival benefit. 40 months in the enzalutamide arm as against 13.8 months in the placebo arm, and the crossover placebo arm, it was 23.9 months. So the hazard was 0.66, 34% improvement, great improvement. When you look at the subset analysis, they are claiming the disease it was improvement in both low volume as well as high volume, but patients who had received prior docetaxel, the confidence interval is crossing the midline, so no OS benefit. Patients of de novo disease who had not received prior ADT or orchidectomy, there was no benefit, and visceral metastasis, there was no benefit. Time to subsequent anti-neoplastic therapy was also improved, but when you look at the subsequent anti-neoplastic therapy, 8 to 12% had received docetaxel, not optimal. 7 to 4% receiving abiraterone, not optimal. 1% receiving cabazitaxel, not optimal. So post-progression treatment was not optimal. Treatment-related adverse events, yes, significant cardiac adverse events were there in terms of hypertension and increased ischemic heart disease and cardiovascular events. Falls, fractures, and cognitive impairment was there. So if you go for author's conclusions, the final analysis demonstrated that enzalutamide plus ADT has a long-term survival benefit as compared to placebo plus ADT in metastatic hormone-sensitive prostate cancer. Safety and toxicity was consistent with the previous analysis, and based of this analysis, it is confirming the benefit. But if you look at certain critical analysis points, patient selection is always the key in metastatic hormone-sensitive prostate cancer. It was a heterogeneous population, and as I described earlier, it was not convincingly representative of a high-risk population. No OS benefit in visceral mets if prior docetaxel was given and if not received previous ADT. And in the era of triplet therapy, just as Dr. Randeep was describing, there were some 15% patients who had received ADT plus docetaxel plus enzalutamide, which did not improve OS. So in triplet therapy era, enzalutamide can't be included based on this study. For low risk HSPC, it is a very good data supporting enzalutamide plus ADT, especially with the OS benefit even after the crossover. Toxicities are there, significant hypertension, ischemic heart disease, and cardiovascular events. So cardiovascular optimization, review, and follow-up is definitely required. Cognitive impairment and falls are also concerning, which we should see in our clinical practice. So in Monday morning practice, in metastatic hormone-sensitive prostate cancer, we should risk stratify our patients, high risk versus low risk. And this is not just only high volume or low volume as per the charted or latitude, but also whether visceral mets are present or not, especially liver mets, which makes it very high risk. De novo M1 disease versus previously received local therapy, and then prior ADT and Nadir PSA, which is important, PSA value, which is important, and Gleason score, which also may be important, although most studies have shown that the benefits are there irrespective of the Gleasons. Other factors like age, comorbidities, fitness, feasibility, all this needs to be concerned, but with a caution that if patient is not fit for docetaxel now at HSPC setting, he is unlikely to get more fit later. And if there is high risk HSPC, I think we need to go for the triplet therapy. And if it is unfit for chemo or not willing, then probably ADT plus abiraterone is the best option. Exception is liver mets, where probably I would still push for docetaxel with a high risk. And in low risk, I think ADT plus enzalutamide or any of the other hormonal agents with or without RT if limited mets is the way to go. With this, I thank you all.
Thank you, Vivek, for summarizing well. I think we will take the questions at the end of this session. I would now like to invite Dr. Tarachand Gupta. He is a consultant at Bhagwan Mahavir Cancer Hospital, Jaipur. He will be talking about, again, metastatic CSPC setting, a phase 3 randomized double-blind study of enzalutamide plus talazoparib, which is a PARP inhibitor, or enzalutamide alone in patients with DDR gene positive, or we can say BRCA1, BRCA2 positive metastatic CSPC.
Good evening all. Thank you organizers for the opportunity. So I am presenting the TALAPRO 3, which is ongoing trial. Recruitments are ongoing. This is a phase 3 double-blind randomized study of enzalutamide plus talazoparib versus placebo plus enzalutamide in patients with DNA damage repair genes mutated metastatic castration-sensitive prostate cancer. So we will discuss this study in these headings, under these headings. So we'll go with the background. Standard of care for the metastatic castration-sensitive prostate cancer involves the ADT plus access inhibitors, androgen access inhibitors like enzalutamide or abiraterone or docetaxel. And as already discussed by Dr. Vivek Agrawal, and this is the androgen receptor pathway in prostate cancer, which is the main cause of the prostate cancer cells proliferation. Prostate cancer growth is dependent on androgen signaling. Cytoplasmic androgen receptor binds to the dihydrotestosterone while releasing the heat shock protein, and that stabilizes the androgen receptor in the absence of dihydrotestosterone. Androgen receptor dimerizes and translocates to the nucleus. Activated androgen receptor dimers bind to the DNA at androgen responsive elements, recruiting a series of co-activators that facilitate the formation of active transcription complex, and gene transcription is initiated. So novel hormonal therapies, those are the androgen receptor inhibitors for first generation or second generation. These binds to the testosterone, binding of the testosterone to androgen receptor inhibition. This inhibits the translocation of androgen receptor into the nucleus and inhibits the androgen receptor binding to the DNA and transcription of genes. Second generation has the higher affinity than the first generation and provides the better inhibition and lacks the partial agonist activity. This is the time to metastatic castration-resistant prostate cancer from CSPC in a germline homologous recombination repair or BRCA2 defective cells. The median time we can see in germline homologous recombination repair defect, patients with prostate cancer has the survival of 8.3 months versus the 13.2 months which are having mild GHRR, or BRCA2 defected patients has the 6.2 months versus the versus 13.2 months in the BRCA2 wild type. Overall survival in non-metastatic setting, it is 11 years in alteration carriers and 18 years in non-alteration carriers, while in the metastatic setting, it is 3 years versus 6 years. The PARP enzymes detect the single-stranded breaks in DNA and contributes to the single-stranded break repair by the pyrylation, and then these attract the base excision repair complex, which repairs the DNA single-stranded breaks, and these once repaired, the PARP and the BR complex dissociate from the DNA. What does the talazoparib? It has a dual action. First, it inhibits the PARP enzyme. So this causes the persistent unrepaired single-stranded breaks and accumulation of double-stranded breaks in the homologous recombination deficient cells, and targeted. This leads to the targeted tumor cell death, and the normal cells remains unaffected. Second mechanism, it traps the PARP enzyme at the single-stranded break complex, where it inhibits the transcription and leads to the instability of the tumor cells. This was the talazoparib to see the efficacy of the single agent monotherapy and versus the placebo in a DDR defected metastatic prostate cancers, where the median follow-up of 16.4 months, there was the objective response rate was 29.8%. That means 31 of 104 patients. Talazoparib is also ongoing study. This is in first-line metastatic castration-resistant prostate cancer, where the previous treatment with the novel hormonal therapy or taxane-based chemotherapy for castration-sensitive prostate cancer will be stratified, and patients are unselected for the DDR. The primary endpoints will be the radiographic progression-free survival, and efficacy will be assessed by the radiography every 8 weeks up to weeks 25 and every 12 weeks thereafter. And radiographic progression-free survival will be compared between the two arms by alpha one-sided stratified log rank test. This is the talazoparib 3 program design. The purpose of this phase 3 randomized double-blind study is to evaluate the safety and efficacy of talazoparib in combination with enzalutamide compared with the placebo in combination with enzalutamide in men with metastatic castration-sensitive prostate cancer with DNA damage repair, homologous recombination repair alterations. So patients with castration-sensitive prostate cancer and documented metastatic disease by positive bone scan or metastatic lesion on CT or MRI, will be included with the performance status should be good, 0 to 1. Prior docetaxel up to 6 cycle is allowed, and the ADT of 6 or less than 6 months and 3 or less than 3 months of approved novel hormonal therapy in castration, metastatic HSPC, that is abiraterone, apalutamide or enzalutamide will be allowed, and patient should have mutation in HRR genes in 12 genes, one of these at least. So stratification factor will be the de novo metastatic castration sensitive prostate cancer versus relapsed metastatic castration sensitive prostate cancer, high versus low volume disease, BRCA versus non-BRCA mutation status. Patients will be randomized on patients are randomizing on talazoparib 0.5 milligram per day versus enzalutamide 160 milligram per day. If the patient is having renal failure, then disease dose is 0.35 milligram per day. Arm B will be the placebo plus enzalutamide, and the safety follow-up will be throughout the 28 days after the last dose of talazoparib, and long-term follow-up every 8 weeks through week 57, then every 12 weeks till the radiographic progression. Primary endpoints will be the radiographic progression-free survival. Key secondary endpoints: overall survival, overall response rate, and duration of response according to the RECIST 1.1 criteria. PSA 50, patient-reported outcomes, safety and PK, and other the exploratory marker, biomarker will be tested. So we have discussed these study endpoints. The first primary endpoint will be the radiographic progression-free survival. Others are the overall survival and many more. Key eligibility criteria, we have discussed already that prior docetaxel is allowed, 3 months of the novel hormonal therapy is allowed. Patient should have the HRR deficient gene, and the patient must have the metastatic disease at the diagnosis, and this should be the hormone sensitive. The specimen will be sent for the bio testing to the foundation medicine for the NGS testing for the following HRR 12 genes. These are there. Patient reported outcomes will also be collected for the URTC QLQ30, PR25, or 5-dimension 5-level scores, and the PJS and BPI-SF also. The countries participating in TALAPRO 3 are the 26 countries are participating. India is among these countries which is participating in the TALAPRO 3. Thank you.
Thank you, Tarachan, for it's more of a proof of concept study of combining abiraterone with PARP inhibitor. We will come to the next two abstracts, which are quite different. They are more based on PSMA directed therapy. For this, I would like to invite Dr. Charu. Dr. Charu is a nuclear medicine physicist, a nuclear medicine specialist at House of Diagnostic, Delhi. She will be talking about two abstracts. One is lutetium PSMA based therapy in CSPC setting, as well as lutetium PSMA based therapy compared to cabazitaxel in CRPC setting. Over to you, Dr. Charu.
Thank you, Dr. Randeep, for this opportunity. So I'll be talking about these two trials, and by the end of the presentation, maybe we'll have an answer to this question, that whether lutetium PSMA therapy has proved its mettle or not. So the field, we all know that the field of advanced prostate cancer has rapidly progressed, but despite surgery or radiotherapy, 27 to 53% patients present with disease recurrence. And usually ADT is the treatment of choice in these patients to halt the disease progression. And as we had seen in the pre-T session, that mainly the cardiac risk profile is of significant importance when the patient is on ADT. So that here comes the role of PSMA PET-CT scan, wherein we map the prostate cancer disease, and based on that map, we give them PSMA therapy. This is called theranostics. So PSMA is present in high quantities on cell surface of prostate cancers. More so, it gets upregulated by many-fold once the patient is on ADT. So that's why it becomes an attractive agent for both imaging as well as treatment of prostate cancers. So here, as you can see in this picture, once we inject lutetium PSMA, PSMA 617 selectively goes and binds itself to PSMA protein present on the cell surface of prostate cancers. Once this binding happens, this complex is internalized, and the cell and its surrounding environment is exposed to a lethal dose of beta rays emitted by lutetium-177, hence resulting in cell killing. So as you can see that this is a very specific treatment which will be delivered only to the sites that have prostate cancer, primary as well as the metastatic disease. So PSMA 617 is now FDA approved, and it can be given as a daycare therapy across all the nuclear medicine centers. So it's easily available now, but of course it depends on how much is the demand. So lutetium PSMA therapy has encouraging biochemical and radiographic response rates, reduced pain, low toxicity, and improved quality of life. More so in patients who progress on PSMA therapy. A re-challenge therapy has also shown to be giving a higher response rates as compared to systemic therapies. So as you can see over here, it's just a picture that I've taken from the web, that this patient had an extensive disease at baseline with PSA of around 100. Post 2 cycles of lutetium therapy with standard of care, the PSA went down to 0.25, and we can see that the metastases have nearly completely resolved. And further, the PSA declined to 0.12. So after 18 months of initial presentation, after 18 months of the PSMA therapy, the patient had a progression with the disease in left acetabulum. So the time to progression was 18 months in this case. Oh, yeah. So here are a few more examples. In the picture A that you can see, the PSA before therapy was 458 with a more than 50% reduction after 3 cycles of PSMA therapy to 158 and a visual reduction in the metastatic burden. In picture B, before therapy, the PSA was 61, again, a significant reduction to 10 after 3 cycles of PSMA therapy. So coming to the first trial, the PSMA addition trial, it's an ongoing trial. Results have not been published yet. Its aim is to assess the efficacy and safety of lutetium PSMA plus standard of care versus standard of care alone in patients with hormone-sensitive prostate cancer, metastatic HSPC. So standard of care, we all know what it is. So study duration will be approximately 50 months. It started in Jan 2021 and will be completed by around August 2024. So this study will enroll 1,126 patients. This is the design of the study. And they will be minimally treated or untreated hormone-sensitive prostate cancers. And they will all undergo a PSMA PET-CT scan prior to therapy to see what's the kind of uptake. And then the patients will be stratified based on disease volume, age, more than 70, less than 70, and history of any previous minimal treatment. They will be divided into 2 arms. One arm will receive PSMA therapy added to standard of care. The PSMA therapy will be given for 6 cycles. It is repeated after every 6 weeks. And the second arm will receive standard of care alone. Here, they have allowed that the patients on standard of care arm, if they have radiographic disease progression, they can cross over to the lutetium PSMA arm. The primary endpoint criteria is radiographic progression-free survival. And the secondary endpoint criteria are overall survival, PSA decline to more than or equal to 90% from baseline, time to development of CRPC, seen as continuous rise in serum PSAs or development of new lesions or progression of pre-existing disease, and composite progression-free survival. So the results of this PSMA attention trial will be very interesting to see, because this trial will tell us how effective addition of PSMA therapy to standard of care is in early treatment of hormone-sensitive prostate cancers. But the results will be out only in 2024. So next is therapy trial. This has already been published. The results have been published. This trial compared lutetium PSMA therapy versus cabazitaxel in patients with metastatic CRPC progressing after docetaxel. So the patients were required to have a progressive disease and a rising PSA with absolute PSA of 20 units or higher. 200 patients underwent this trial. And the key eligibility criteria were adequate, besides those two mentioned earlier, adequate renal, hematological, and liver functions. All the patients underwent both PSMA and FDG PET-CT scans. This was to see that we shouldn't have any patient who has FDG positive and a PSMA negative disease, which happens in a poorly differentiated setting. Measurable sites of PSMA avid disease should have SUV more than 10, and any one site should have SUV more than 20. Again, they were randomized. One arm received PSMA therapy and the other arm received cabazitaxel. The primary endpoint in this study was a PSA reduction by more than or equal to 50% from baseline. Secondary endpoints were progression-free survival, objective response rates, patient-reported outcomes, and overall survival. So as we can see from this table, lutetium PSMA did a fairly good job. The patients on lutetium PSMA arm, they had 49% objective response rates versus 24% on cabazitaxel. Pain responses were better. 60% had pain reduction on PSMA arm versus 43% on cabazitaxel. PSA reduction to more than 50% of baseline levels was also higher, that is 66% in PSMA arm versus 37% on cabazitaxel. Progression-free survival at 1 year was 19% in lutetium PSMA arm versus 3% in cabazitaxel. Also, grade 3-4 adverse effects were higher in patients on cabazitaxel. Other patient-related domains like diarrhea, fatigue, insomnia, hair loss, skin rash, all these were reported less in patients who were on lutetium PSMA, thereby improving the quality of life. Many other trials have also been done and will be done, like Vision trial. The results have been published. It enrolled 831 patients, and this trial intended to compare when we add PSMA therapy to standard of care in metastatic CRPC versus standard of care alone. So this trial showed that median radiological progression-free survival was 8.7 months in PSMA therapy plus SOC versus 3.4 months when the patient was on SOC alone. Overall survival was also slightly better, 15 months versus 11 months. Time to development of first symptomatic skeletal event, that is any pathological fracture or any bone disease requiring surgery or radiotherapy, was approximately 1 year in patients who had PSMA therapy added to standard of care versus 6 months in patients on standard of care alone. So Vision trial showed that PSMA therapy delayed the worsening of symptoms with no new or unexpected safety concerns. Treatment with lutetium PSMA was associated with grade 3 or lower toxic effects, and it also extended the time to symptomatic skeletal events. It prolonged the time to worsening of health-related quality of life and delayed the biochemical progression. So to summarize, lutetium PSMA offers a novel targeted treatment approach. Its promising results, coupled with low toxicity profile, make it a promising agent in early treatment of metastatic prostate cancers. And let's not use it when all the other options are exhausted, because once we do so, the patient already comes to us with a low bone marrow reserve, thereby limiting the number of cycles or the kind of treatment that we want to give the patient. Thank you.
Thank you, Dr. Charu. We will take the question and answer after the end, at the end of the session. Thank you, ma'am. So we'll come to the last talk of this session, and I would like to invite Dr. H.S. Darling. He's a consultant medical oncologist at Command Hospital, Bangalore. He will be covering 2 trials. One is PROPEL, which is olaparib and abiraterone, something similar to talazoparib combination, which Dr. Tarachand discussed as a proof of concept. And this is in the first line therapy in a metastatic castrate-resistant setting. And the second is again another PARP inhibitor, niraparib, along with abiraterone as a combination in metastatic CRPC setting. So he will be talking, both the settings are of CRPC. Over to you, Dr. Dar.
Thank you, sir, for inviting me here on the dais. So I'll be presenting 2 trials back to back. And I have a disclaimer. I think I am the only person who has come with the original slides. I have not made any changes in that. So these trials were presented in ASCO EU in San Francisco in February 2022. So they are very interesting, maybe practice changing, but right now they are contradictory to each other to much extent. Let us see what is there in them. So, Professor Fred presented this trial, PROPEL trial, which is a phase 3 trial of olaparib and abiraterone versus placebo and abiraterone as a first-line therapy in patients with metastatic castration-resistant prostate cancer. And so what is the background? They say that in a clinical trial setting, a metastatic CRPC patient when treated in first line has a median survival of 3 years. But in practice, that patient lives for only 2 years. So there is a major unmet need in this setting to advance the treatments. So we all know the PROFOUND trial, which was a phase 3 trial, and olaparib monotherapy demonstrated significantly prolonged radiological PFS as well as OS in patients with HRR gene alterations. So this trial is in all patients with alteration or without alterations. So this trial is based on a phase 2 trial which showed prolonged RPFS in patients with metastatic CRPC following docetaxel with the combination of olaparib plus abiraterone. So this was phase 2, and now we are talking about the phase 3, and it was irrespective of HRR status. So PROPEL is the first phase 3 trial which studied the combination of PARP inhibitor plus newer hormonal agents in first-line metastatic CRPC, irrespective of HRR mutation status. Now, this is a very interesting mechanism they have proposed for combination of olaparib and abiraterone. They say that PARP inhibition is reported to increase the activity of newer hormonal agents via androgen receptor dependent transcription, and it is complemented by newer hormonal agents which are reported to induce HRR deficiency, leading to increased susceptibility to PARP inhibition, which we all know the synthetic concept of synthetic lethality. And the combined effect of both works in patients, all patients, irrespective of HRR deficiency. That was the basis of this trial of combination. Now, what happened in the phase 2 trial on basis of which this trial was conducted? There were patients with metastatic CRPC, as we already saw, and they were unselected for HRR, and they were previously exposed to docetaxel. They were randomized to 1:1 ratio to the combination, and there was statistically significant improvement in RPFS with a combination. So we can see that hazard ratio was 0.65, which is very, very significant. Now, this trial, the PROPEL trial, it is a global randomized placebo-controlled double-blind phase 3 trial. So patient population was first-line metastatic CRPC. Docetaxel exposure was allowed in sensitive stage, and prior abiraterone was not allowed. Other newer hormonal agents were allowed if they were used more than 1 year back, and ongoing ATT was accepted, and ECO 0 to 1. Stratification was based on site of distant metastasis as well as prior taxane, yes or no. So randomization was 1:1, and full doses of olaparib and abiraterone were used. So olaparib 300 mg BD and abiraterone 1 gram OD versus placebo plus abiraterone. Primary endpoint, as we saw in the previous trials also, it was the radiographic progression-free survival, and there were many key secondary endpoints which you can see. Now, baseline patient characteristics were well balanced, but there are 3 important points which I want to highlight. One is that symptomatic patients were more in olaparib arm, and 90%, almost 90% patient was exposed to docetaxel previously. Median PSA, as earlier Dr. Agarwala also mentioned, we do not see patient in this setting with 17 or 16 PSA. So they had a baseline median PSA of 16, 17, which I don't understand why. And the HRR status was retrospectively tested. So there were about 27, 28% patients who were HRR mutated, and others were all HRR negative. The primary endpoint result by investigator assessment showed a very good response, a hazard ratio of 0.66. So 34% risk reduction of progression or death was there in the olaparib arm. And at 12 months, the difference was 8%, and at 24 months, the difference was 18%. And then same result reviewed by independent committee showed further difference. The benefit was even more. 11 instead of 8 months, it was 11 months, and the hazard ratio was 0.61. Subgroup, this is a forest plot which shows various subgroups. All of them benefited. Only in 2 subgroups the the boundary crossed the unity. One is more than 65 age and ECOG 1. And second is the patient who had below median baseline PSA. And global interaction test was not significant at 10%. Overall survival, this trial, it was a secondary endpoint, and it is the hazard ratio is 0.86, but the data is not mature. It is only has attained 28% maturity. So we cannot depend on that. And other secondary endpoints like time to first subsequent therapy and time to second progression, they also benefited in the olaparib arm. There was 10% improvement in overall response rate in the olaparib arm, and 40% patients had measurable disease, and the odds of benefit was 1.6 times in the olaparib arm. Safety profile, it was adverse events were almost same, but the discontinuation rate in olaparib arm was more, I think, two times more in olaparib arm, and there was no MDS or AML reported, which is a major concern in olaparib. And incidence of new primary malignancy or pneumonitis was same in both arms. Most common adverse events were anemia, fatigue, and nausea, which were 10% more in olaparib arm. Cardiac events and thromboembolic events were almost on the same frequency, but pulmonary embolism was 5-6 times more in the olaparib arm, but it was incidentally detected, and the drug was not, drug interruption was not there because of that. Quality of life was almost same in both the arms. So conclude, in this trial, olaparib and abiraterone combination led to 34% improvement in PFS, and the clinically meaningful as well as statistically significant benefit was there. All the secondary and exploratory benefit endpoints also showed benefit. Now we come to the second trial. So this trial is a sort of googly. The excitement which was produced by the first trial vanishes when we see this trial, the result of this trial. So this trial is named magnitude trial. So this is the first results of niraparib plus abiraterone. In that, olaparib was there in the first line setting. Here they tested the homologous recombination repair in instead of retrospectively. Here they tested prospectively. So the patient eligibility was first line metastatic CRPC, ECOG 0-1, and pain score less than 3 or equal to 3, and prior taxane was allowed, and others you can see. So in the interest of time, I will not be going through all of them. HRR genes were tested as mentioned. There were two cohorts. One was HRR biomarker positive and other was HRR biomarker negative, 400 and 600 patients. Both the cohorts were randomized 1:1 into niraparib plus abiraterone or placebo plus abiraterone. Primary endpoint was same, radiographic progression-free survival by central review. Now, this is the important slide. In bone marrow, in biomarker negative patients, they saw that there was no benefit when they studied the composite endpoint of 83 PSA events and 65 RPFS patients, and they saw that with added toxicity and no added efficacy, the independent data committee, they recommended stopping the enrollment in this cohort. So they continued with the only biomarker positive patients, and they divided them into BRCA1/2 positive or other gene mutation positive in HRR. So the primary endpoint of radiographic progression-free survival saw the benefit of, in the central review, they saw that the benefit was 10.9 months versus 16.6 months. Hazard ratio was 0.53, and almost same was there by the investigator review. In all HRR biomarker positive patients, again, the hazard ratio was good, although it was less than the previous one. So hazard ratio was 0.73 here, and by investigator assessment, it was 0.64. Here, this is the forest plot, and almost all the subsets are touching or crossing the unity. So the time to cytotoxic chemotherapy was, again, the benefit was seen in the niraparib arm. And time to symptomatic progression was, again, the hazard ratio was 0.69, 0.68. And overall survival, although it was not the primary endpoint and 27% of deaths had occurred, so overall survival again showed benefit towards the niraparib arm as hazard ratio of 0.76. And PSA, time to PSA progression was, again, there was 43% improvement in niraparib arm. And overall response rate was double in the niraparib arm in the niraparib, it was like 60% as compared to placebo, it was 28%. So quality of life was maintained in the niraparib combination arm almost equal to the placebo arm. So the authors concluded that niraparib plus abiraterone improves radiographic progression-free survival and other clinically relevant outcomes in patients with metastatic CRPC and alterations in HRR-associated genes. And they said that is contradictory to the olaparib trial, which we discussed earlier. There was no evidence of benefit with the addition of niraparib in HRR biomarker negative patients in this setting. So with this, I end my presentation. Thank you very much.
Thank you, Dr. Darling. It was quite an elaborated presentation and clearly shows that olaparib and niraparib, both being PARP inhibitors, are not the same drugs in prostate cancer, like they are not the same drugs in first-line ovarian cancer. So with this, we come to the end of our session. If there are any questions from the house, we can entertain 1 or 2 questions. Yes, please. And we will be definitely having a discussion in the, I mean, there will be a moderation by Shyam Agarwal sir also after that. So 1 or 2 questions we can entertain now.
So this
And
is
if
with
they're left
respect to-
unanswered, we can also discuss in the panel. Yes, please.
With respect to the arches and the piece, now that you give triplet therapy right off in HSPC, now are we defining HSPC? What is hormone sensitive? If we're right away giving chemotherapy, we're giving abiraterone and hormone and androgen deprivation. So are we looking at another paradigm shift in defining hormone sensitive and hormone castrate resistant? Because it's no longer how do you define hormone sensitivity when you're already giving all 3 combination together?
So these are the classical criterias. I mean, someone who's diagnosed with a metastatic prostate
So it's
cancer.
just a de novo cancer, metastatic
It's a de novo
cancer.
metastatic
There is
prostate
no,
cancer. Exactly.
there is no definition like hormone sensitive because
Yes, they are de
Yes.
novo metastatic prostate cancer.
prostate
Why we
cancer.
label HSPC or CSPC nowadays, CSPC, is to differentiate it from the CRPC setting.
It's just a
That is why it is
it's
labeled as
just a-
CSPC, so that you can differentiate from the
It's just a
CRPC
nine.
setting.
So
That
secondly,
is the prime reason that always it is said as CSPC, so that we don't confuse it with that. But the standard high risk, low risk, which was defined by chartered with some deviations in latitude, the chartered classical definition remains true in clinical practice, and most of the trials
but that was always sequential.
high
That
and low.
was-
No,
that
no, I'm
was
talking about
always
high and low
sequential.
burden remains classical. What was
Yeah, yeah.
taught in
Okay,
chartered, most of the clinicians as well as the newer trials adopt that high low burden criteria, which is
So-
visceral mets or nodal mets, or 4 metastases with 1
oligo
outside
and
the axis.
appendicular
That is high low. Yeah.
So this is to Dr. Charu. So you didn't cover the side effects of lutetium in this. We heard it's a lot of xerostomia and a lot of hypothyroidism following that. And is it dose dependent? Is it cycle dependent? How is it?
So it's a temporary effect, and there are solutions to that, and it doesn't last for very long. Xerostomia is there, and vomiting, nausea, so which can be managed well with the treatment options available. So it's not a limiting side effect. Myelosuppression, again, myelosuppression happens in those patients who have undergone multiple cycles of chemotherapy and when PSMA therapy is being used as a last resort. So that was the reason that these trials, the results of these trials show that if PSMA therapy is added early on with standard of care, it gives a better, it has a very low toxicity profile and gives better results.
But Dr. Charu, you don't feel that if you use PSMA upfront, I mean, as a medical oncologist, our concerns are that the patient may not tolerate docetaxel or cabazitaxel later on. These 2 molecules, both docetaxel and cabazitaxel, are very myelosuppressive.
So
I mean,
PSMA therapy, we can do with 2 agents. One is lutetium, which is a
Yes.
beta emitter, and the second is an alpha emitter. So alpha emitters, they don't cause myelosuppression because they are not able to cross the cell and affect the normal healthy bone marrow. So they will attack only the metastatic deposits in the bone, in the skeleton, but will not affect the bone marrow. So actinium PSMA therapy has also proven itself in a good way, but the availability is an issue for that.
but lutetium will marry, if you use a lutetium based PSMA, I mean, therapy,
Yeah.
there will be myelosuppression.
There will be myelosuppression, but it all depends on the patient profile. As we discussed, like if the patient comes with a lot who has undergone previously docetaxel, cabazitaxel, and then the patient is coming to us, then of course there will be more risk of myelosuppression.
Thank you, Dr. Darling. I think we will leave some of the questions for sir. I would now like to invite Dr. Shyam Agarwal, sir. Sir is the Director of Medical Oncology at Sir Gangaram Hospital, though he doesn't need any introduction. And he is known for one of the toughest panel moderations. So I will, so good luck to all the panelists. Shall I invite the panelists? Okay. So Dr. Vikram Shah Batra, he's a senior consultant uro-oncologist at BLK Hospital, Delhi. Dr. Vikram, please. Dr. Tanvi could not make it. Dr. Mohit, he's a consultant and colleague from Narayana Hospital, Gurugram. Dr. Dharmender Malik, he is a nuclear medicine specialist at FMRI Gurugram. Dr. Rajender, dear friend, he is heading the Department of Radiation Oncology at Max Super Speciality Hospital, Shalimar Bagh. Dr. Vivek Agarwala, he is heading the Department of Medical Oncology at Narayana Super Speciality Hospital, Kolkata. And Dr. H.S. Darling, he is the consultant at Command Hospital, Gurugram. Over to you, sir.
So thank you, Randeep, for this invitation and opportunity. And I welcome all the panelists for this panel discussion. So slides are basically made just now from the discussions which you've just had. So the idea is to try and, figure out what we can do maybe Monday morning based on the data which has been shown. So let's have the first slide. So I think the idea is to have a clinical kind of a discussion rather than theoretical discussion after having listened to all the speakers. Next slide. So I think the first slide is focused on, yeah, okay, thank you. Okay, thank you. So I think that's based on the first data which was presented on oligometastatic disease. So before so do you really, accept this entity of oligometastatic prostate cancer, Dr. Vikram?
So I do
how do we really define it if we have to define it in our...
So from
day-to-day?
urological perspective, yeah, it's the standard definition. We define it as no visceral mets, anything not, there is no acetabulum or any appendicular involvement. Typically axial skeleton.
Vivek,
and
do
less
you
than
accept visceral metastasis as a disease entity to decide on treatment differentiation between metastatic disease versus oligometastatic?
So, sir, I think if we define low risk, low volume disease, in that subset, we can define a subset which has oligometastatic disease. And there is definite role of local radiotherapy.
Yeah,
in
we'll
that.
come to that. So, Dr. Darling, you agree? I mean, normally when you say oligometastatic disease, you say less than 4 or 5 metastatic areas in the body. Whether it is visceral, as Dr. Vivek says that I don't accept visceral disease as a oligomets. So, is that okay if somebody has 1 or 2 or 3 lesions in the lung and the bone, and would you call that as oligometastatic disease?
No, sir. For treatment purpose, like to name, we can say that for deciding the treatment, I would count only oligometastatic when he has only bone-only metastasis.
So is that everybody agrees to this, or if there's a single lung nodule, you will not? So then you have to go, possibly you will not go for local therapy.
So practically, we don't find that patient will not have bone metastasis and he only has a single lung metastasis.
Right. So I find little shakiness here, not accepting a single lung nodule also as oligo. If 1 bone lesion, 1 lung nodule, why not oligometastatic disease?
Yeah.
So Vivek wants to say something. Anybody,
Sir,
please?
it would be a very rare situation, first of all. And suppose it would happen, I would, actually want to biopsy the lung nodule to see whether it is actually a prostate cancer, because, 1 lung nodule and only 1 bone metastasis, I would be first interested in proving what that lung nodule is.
We prove it. So medicine is something, you can expect anything in a patient when it
yes,
comes
sir.
to
I'll buy it if it's a young patient and in his 50s or early 60s and is a good GC. I would really like to.
So it's not a classical scenario, but then I will treat it as oligometastatic, only SPRT or something.
Right. So I think the point is, although there is
agree with Dr. Darling that if visceral, then we will not take it as oligometastatic disease. That's
no, but he's agreeing to if there is a single
in the specific scenario which you told, sir, if there is a single metastasis and we prove it and it is accessible by surgery or radiotherapy, I'll go for that.
Okay, so let's see this particular patient who is say 50, 55 years old. He has a prostate confined disease and the Gleason is 8, PSA is 40, and there are 2 bone lesions in the vertebrae. So how do we start the treatment from Dr. Rajender? Please. Yeah.
So it's a metastatic disease, sir, but it's a low volume metastatic disease. So we'll start with the.
Can I interrupt, sorry. So is there a difference between low volume disease and oligometastatic disease?
So,
these are very fine points here. I mean, do we really, sorry, you have to really dissect this. So what do you think? Yeah.
Mostly, sir, we say it's a low volume disease, as we discussed, without visceral metastasis, and bony disease confined to the pelvis or only to the appendicular area, which is kind of synonymous to oligomet. But mostly oligomets, we say if one or two visceral mets is there. But in prostate, when we say low volume, it should not be a visceral met, sir.
All right. So in this patient, what is your approach, sir?
Now, sir, I would like to add the point that not all low volume diseases are oligometastatic.
Okay.
There might be in the axial system, there might be more number of mets. So not all low volume diseases are oligometastatic, but the reverse is true, that all oligometastatic, bone only metastatic diseases are low volume.
Okay. So how do we start treatment for this, Dr. Batra, please?
If it's a young patient, I really believe in a recent trial which came, we radically treat these two vertebral lesion by radical local radiotherapy, give him ADT plus abiraterone for 3 months, evaluate him again. And if it is all subsided, he has a good PSA response, he doesn't have any other PSA, I'll go ahead with local treatment.
Right. So what he said was he starts with ADT and abiraterone.
Yes, sir.
So everybody agrees to this?
Yes.
Yeah. Is there consensus there?
Yes, sir.
Yeah.
You can add Anja as well.
So ADT plus one of the agents, either
Right.
enzalutamide or abiraterone, both are perfect for a low volume metastatic disease.
What about chemo?
Chemo, sir, is an option, but if you look at the docetaxel studies, what you see is that the overall survival is really not very significantly different for low volume disease, whereas for high volume disease, there is. So probably in a low volume setting, we can think of keeping
Spare the patient of
docetaxel
chemotherapy.
Based on charted
for later
data, we
use.
will not consider chemotherapy for these kind of patients.
Right. Just because this being low volume disease and in the Stampede and charted, you sort of demonstrated similar benefit with the newer hormonal agents.
There are some factors like PSA doubling time, and if from non-metastatic patient has recurred, has become metastatic, then in that case, chemo in young patient, fit patient, I may consider chemo in this case also.
Okay. So there are takers for chemo as well. Okay. Now, but I think the consensus is to give the hormonal therapy with either abiraterone or enza. So now the question is duration. Dr. Batra said 3 months. So are you happy with 3 months, 5 months, 7 months, 6 months, or before you come in for the local therapy? Vivek?
So I think, sir, 3 months to 6 months is a good time for deciding. I think what we are looking for is a good PSA response.
Yeah.
And if you get a good PSA response to, less than 4, depending upon what the initial PSA was. But I think what we all want is to get a good PSA response. The PSA, what I remember is that if the PSA is less than 0.2, the prognosis is very good. If the PSA is Nadir PSA is between 0.2 to 0.4, again that is another subgroup. And if the Nadir PSA is more than 4, then that is another subgroup. So I think PSA response is something that we are looking. Of course, in MRI also you want to have some response.
Right. I think the PSMA would be I think the reduction in the avidity would be an important criteria. So Dr. Batra, after the patient has had, so I think 3 to 6 months is reasonable consensus here for ADT. 3 months perhaps is not just as a single milestone. So what local therapy shall we be doing?
It all depends what his local stage is. If it is
it's confined to the prostate,
if it's a confined disease, I will choose for cytoreduction. I will choose for cytoreduction because as Dr. Bakshi also presented his studies, that there is less local complications later. It may or may not have a good overall survival, but it does have a good.
So cytoreduction means prostatectomy, right?
Yes, sir.
Right.
Cytoreduction.
And any takers for radiation?
Sir, I like to give those vertebral radical radiation as well.
So we'll do the SBRT.
Yes,
for
sir.
that.
SBRT, and
That is agreed upon. I mean, I think there is no difficulty there. So regarding the local treatment. Yeah.
But I have a point here that whatever trial they have taken in the trial which is showing the OS benefit, these are all retrospective. There was no randomized control trial comparing the radical prostatectomy plus standard of care versus standard of care. So this point should be taken as a pinch of salt. On the other hand, with the radiotherapy, you have HORA trial, which is showing that in the low burden disease, we have seen the benefit of local radiotherapy. So I would like to prefer local radiotherapy to prostate in this kind of subset.
All right. So one surgery, one radiation. Dr. Rajendra.
Sir, I am a radiation oncologist.
Okay.
So obviously I'll be going for radiation. The reason being when we face a situation that patient is metastatic. So we want to keep our complications as minimum as possible. And we all know that surgery as well as radiation both has its own comorbidities. So I would like to treat prostate with hypofractionated regime, which is say around 20 sittings, so that patient finishes faster. And at the same time, I would like to treat these bony lesions with SPRT, so preferably 3 to 5
that
sittings.
is okay. So radiation is your answer.
Yeah, and
Dr.
that continuous system.
Dharmender.
I think at present, this scenario, lutetium PSMA does not play any significant role.
Okay, okay. So he's a nuclear medicine guy.
That's why I have limited
Right.
on
Okay. I'm
cancer.
sorry. I just saw that later on. Okay. Okay. So you don't have a.
Yeah.
So I think the medical oncologist has a choice to refer either to the radiation oncologist or to the Vivek.
So I would be counseling against surgery in a metastatic
Against
setting.
surgery.
Yeah, I would counsel for radiotherapy and counsel against surgery.
Okay. Dr. Darling.
So in the light of a little bit data which we saw today, if the response is very good, I will consider surgery also at this stage, keeping in mind that if patient continues to do well, I still have the radiation option in the future to use.
Subsequently. Okay. Great. So Dr. Randeep.
The doubt, I mean, for the surgeon and radiation oncologist, your technique of radical prostatectomy will be same as a localized prostate cancer, and your doses of radiotherapy will also be same as a localized prostate cancer. I mean, radical doses will be given.
Yes.
In this setup, whatever the trials are there, the intent is radical local treatment.
Curative.
Absolutely.
Right. So I think we covered a fair amount of ground that oligometastatic disease
I think
needs to be
Yeah,
treated.
correct. So I think this question only we are discussing in the robotic age, because there is robot probably in the earlier age we won't be discussing because of the high morbidity of the surgery. But we need just as Dr. Mohit said, we need definite phase 3 randomized clinical trials to prove this point. And until we have that data, I don't think it remains experimental. It remains exploratory sort of.
The role of surgery.
The role of surgery. So,
but anyway, so there is a divided house, so which we need to.
We have data to the effect which says that it may not have an OS benefit. Now, there are trials which are ongoing as well as which have some data which suggest surgery.
Await the results.
Right. Okay. So we get it. So I think there is a divided house here. Yes, please.
Sir, I'm a surgeon. I'm at Tata Hospital.
Louder, sir.
Yeah. So the thing is, we talk about there being no evidence.
Now we can hear you.
Yeah, we talk about there being no evidence to do surgery in the oligometastatic setting or low volume metastatic setting. Where is the evidence to give radiation coming from? So in HORAT trial, the standard of care was ADT alone. Right now, we are giving ADT plus Abira. In the Stampede trial, the standard of care was ADT alone. 15% of patients had ADT plus docetaxel. There is no evidence to say you can give ADT plus Abira plus RT to a low volume metastatic cancer. So if there is no evidence to give RT at 3 months.
So in both the arms, patients did receive RT. It's not that only ADT alone arm received RT and the experimental arm or the control arm as well as both arms received RT.
Yeah.
And there is evidence there is randomized prospective evidence to that effect. So, we need randomized prospective evidence to the same effect in surgery also. If there is, who is going to not counsel for surgery?
That is what I'm saying. So there is no evidence to do ADT Abira right now and give RT 3 months later. There is no trial which gives you that data.
No, but there is a very good evidence by a HORA trial, by the Stampede
standard
trial.
of care was ADT alone.
Surgery is non-inferior to RT in any which way than local reduction.
So
no evidence, right?
this
Along with the local
is
trial.
an era where we are still debating in the high risk prostate cancer whether we should do surgery or not. And then I think doing surgery in a metastatic prostate cancer is a bit of an overstretch.
I'm not arguing for surgery. I'm not arguing for surgery.
In high risk, there is a definite subset of patients who have a definite advantage. No, this.
100% of high risk
So,
prostate
none-
cancer.
we are in a debate. We are in a debate.
Yeah.
We are in a debate right now, and all I'm trying to say is, as far as your high risk concerned, there is a definite subset of patient who requires all aggressive modalities together, and in sequential therapy and surgery does have a role.
So
And
Okay,
so also
let
in
me
this
just,
case-
so Dr. Mandeep, what you're saying for this patient is to just give ADT and abiraterone?
Sir, even we give RT to the patients at 3 months at my center. What I'm telling you is you don't want to give docetaxel to this patient because he's low volume, but that trial Stampede gave docetaxel in the standard arm. And
No,
the
so-
trial
but
Horror.
there's no benefit with that, no?
Yes, it did not see any benefit. So
Right.
where is the proof of benefit for ADT plus Abira right now and RT at 3 months later? Where has that come from?
So I think Dr. Mandeep, if we see data of Stampede, the benefit of local progressive free survival was there in both the low risk and high risk. But if you see benefit in OS also, it was there in low volume only, not in high volume.
Exactly. And
It
that-
was there in
and that
Stampede, but there
Stampede
was
paper-
benefit.
And that Stampede paper which gave RT had docetaxel in the standard arm, not Abira. It had only ADT or ADT plus docetaxel, not abiraterone.
So, Dr. Mandeep, I'm not a medical oncologist, but we are discussing roll-up radiation. So, roll-up radiation in low volume disease has both local control as well as overall survival in low volume disease from Stampede
So
trial.
the evidence for radiation is being extrapolated from something else.
Right, okay. So I think what you want is a new trial, you know, in oligometastatic.
So I'm not
or-
arguing for surgery. I'm just
Right, I
saying-
understand. So there are discussion points here. So,
We will get that evidence because there are trials.
okay, I think this discussion is kind of unending, and let's move on. The next topic, I think there are a few more topics. Can we go to the next slide? I think the slide is here. Okay, the question is again a controversial one for the medical oncologists and even the surgeons. Opinion on piece 1 and the Arasense study. So are you convinced, as Kareem Fizazi and the other is Vivek? Are you convinced? I mean, that because he says it should be the standard of care now for castration sensitive patients.
So, sir, high risk patients who are fit to receive chemotherapy, I think giving only docetaxel to those patients are something it is going to be out of the way now. If patient is fit for docetaxel and patient is a high risk disease, then there is no other reason why the patient can't be given docetaxel plus abiraterone or plus darolutamide when you have that data. So slowly, I think giving only docetaxel is something that is going out of practice, will go out of practice in high risk patients, high volume disease.
So you are in favor of
Totally,
the
sir.
3 drug, basically the
Totally,
ADT, chemo.
In the high volume disease, in the high risk
high risk
category.
category. Okay, Mohit, are we moving
I
towards
agree
that?
with
Sorry.
the triplet in the high risk, high volume disease. That's
Okay, so-
these are quite convincing with the OS data as well. So it's hardly
Dr.
any-
Darling? Or you want to keep the
Yeah,
newer
because
hormones in reserve for subsequent relapse?
Yeah, but we have data which says that patient benefits, PFS, at least PFS benefit is clearly there, and the toxicity is not, added toxicity is not much. So if financial issues are not much, then I would like to give triple agents in high volume, high risk.
There's no financial, I think docetaxel is quite cheap and so is the abiraterone.
Yeah.
These days, by and
Yeah.
large. So issue is not the toxicity, I mean the cost. The issue is the conviction, and maybe the approvals are pending, I guess. Vivek?
Sir, the data is there. I have started counseling and I have already done that for 2 patients.
I see. Okay, interesting. Randeep, you have done that?
Not yet, sir. But
Yeah.
only my major conviction is that if I put someone on ADT plus ABI, and that is a question to the panelist also, I don't know whether ADT plus ABI is better than ADT plus DOSI plus ABI. Are you getting it? I mean, I'm reversing the control arm. We know that, as Vivek said very rightly, that if you are really putting it high risk and you are starting someone on chemo, it may be out in another year and you may put everyone on triplet. But suppose I am not starting on chemo, I am starting them on abiraterone and enzalutamide. At that point, how do I convince the patient that adding DOSI is advantageous or continuing ABI?
So
we don't have that data.
So we already have the data from Stampede where ADT plus docetaxel and ADT plus abiraterone were combined, head to head compared, and the data is almost similar. There is clearly no clear-cut benefit from one arm versus the other.
Right.
So if you take that data and you extrapolate with this same piece one data, you see that the triplet is doing better. So I feel that, you know, if you are doing the same question, that if they had a third arm where it was only you know, ADT plus AB and not docetaxel, then probably from the Stampede we can have some idea that probably it would have been the same as the other country.
And we are almost clear that which are the patients in which we will be giving docetaxel upfront. There's no confusion on that. So it is only the question of adding abiraterone over and above docetaxel.
So the high risk patients
Yeah.
with visceral disease, with high Gleason, and those kind of factors. And
So if we are already upfront thinking of starting docetaxel, it is only a question of adding.
Great. So it's interesting to see how treatment is evolving, and so okay. So be ready for using 3 drugs, I guess. So in the Dr. Vikram.
My question is, yes, I'm fairly convinced with the 3-drug triplet, but how long do we go with this docetaxel, and what do we do after docetaxel? Do we give him on 6 cycles? Is that it? Because you can, if it is so responsive and PSA response is so good, we often go to 9 and 12 in a standard thing. So do we have the same liberty in this?
So 9 and 12 that we are talking in castrate resistant setting. Castrate sensitive setting, we always give 6 cycles if we are giving 3 weekly. So 6 cycles should be enough, sir.
Now for CSPC, I think it will be standard 6 cycles.
Yes,
followed by
registration is not complete.
Right. So I think that question is addressed, the number of cycles and so on. But the issue is, are we really convinced on the 3-drug for all patients? I think it has to be a young patient with high risk. It will be an issue for elderly people.
Yeah. So my one question to the panelists, like in CSPC, when you give docetaxel upfront and patient is responding well, even then you stop at 6 cycles, or you tend to continue for some more cycles?
So in castrate sensitive setting, you know, I think we stop at 6 cycles. There is no evidence to
My
continue.
experience with many such patients and many medical oncologists give it for up to 12, 18 because they feel that
No,
if
in
he's
castrate
responding-
sensitive, I don't think that is a correct practice, because the
Even in
benefit is not
CRPC, I think
proven.
the tolerance goes down, you know,
Correct.
after 6 or
Even in
maximum 8
CRPC, sir, it is proven that you give docetaxel up to 10 and beyond 10, then there is no additional benefit of that beyond 10. That is also proven. Although you may use until progression, and so that is there in the CRPC setting. And regarding the age settings, sir, I think the trial had a median of 65, 66 years. So if you take that median, I think you can consider it till 70 years of age, and beyond 70. I think then you have to, sort of risk stratify as to what will be the risks and benefits. But till 70, I think you can easily consider so far as age is concerned.
Other good thing was that in this trial, till 3 months randomization was allowed. I mean, sometimes we think that you start someone on ADT and DOSI and you are not happy with the response. It happens if you recall, it happens in a patient, at least in 10%, you are not happy that DOSI has gone and ADT, and in 3 months you can reassess. And that is at least in that high risk patients who have not responded well. In this trial, the inclusion was allowed till 3 months. We can add AB at that point.
Correct, sir. I mean, you may have
Best way
patients
to
who
use
are
it.
not.
I mean, best way to use it now.
With a very good PS, you start abiraterone and ADT, and in a month or so, 2 months, the PS improves, and then you can add docetaxel. So that can also happen. So the 3 month, gives you a very good margin to select your patients.
Right. So I think it is important to understand for all of us that the role of docetaxel is being, exploited all over. Whatever trials you had, which you had seen, for example, where they have abiraterone and PARP inhibitors, etc., all are allowing the use of docetaxel in the CSPC setting. So which I think in Indian context, so people try to, not give chemotherapy. Because, so you have the availability of abiraterone and enzalutamide. So I think that mindset, maybe even of medical oncologists, need to change, because you're losing that very important drug, particularly for, 65, 70-year-old, who may be borderline, with the ECOG. So I think the role of chemotherapy cannot be, overemphasized.
Yeah. So
Sir? Yeah, darling.
Please.
So in my practice, I always consider a patient like that in due course of time in cancer, patient is likely to deteriorate at that moment, considering chemotherapy will be difficult. So it's better that we sequence chemo followed by oral agent rather than oral agent. But ultimately it's patient choice. Sometimes they say tab ka tab dekhenge, abhi aap oral tablet de do. Most of them say like this.
Yeah, exactly. You wanted to say something,
regarding chemotherapy acceptance. I think among doctors there is no confusion, but among family members there is so many questions, especially when patient is 60 plus. So my questions to my medical oncology colleague: few people they give weekly docetaxel and few give 3 weekly. So if patient's family is afraid, can we give a weekly docetaxel in such scenario?
So weekly, bi-weekly, 3
Yeah,
weekly.
so weekly we are not using because it becomes a bit toxic. You know, the coming every week is again an issue. But 2 weekly we are using even in HSPC setting, although there is no big data to convince. But from the CRPC setting, we have extrapolated and we are using 2 weekly even in the sensitive setting, and the tolerance is better, similar to what we have seen in the CRPC setting. The tolerance is better and acceptability is better.
But in CSPC setting, I would like to use if I feel that patient will not tolerate 3 weekly.
Right. But we have the option of 2 weekly, which is as effective as 3 weekly and much better tolerated than the 3 weekly protocol. But I think the docetaxel, we really have to be there now. I mean, you can't avoid giving docetaxel unless the patient is really unwell and has a very poor performance status.
So there is one molecule, docetaxel, though, that is slightly better tolerated. We sometimes use that.
Which
also.
one?
Docetaxel.
Right. I mean the NAB one, the albumin.
But sir, in low risk disease, I would still sort of avoid docetaxel, because I think docetaxel probably becomes an overkill, and these patients can do just as good enough with abiraterone or enzalutamide.
Right. So I think that's a fair discussion on the issue of PEACE1 and darolutamide and dosi once that becomes available. Now, I think the era of PARP inhibitors. So I think the HRR mutations are to be tested. Should we test all of them or just, 1, 2, or 3 of them, which are relevant to maybe olaparib? Anyone? Dr. Darling or Dr. Mohit, what do you think?
At the CRPC setting, I would like to use all HRR and preferably.
So the question is when to do these tests?
Yeah, when patient is CRPC, because the TelePro data are not yet out. So
right.
At least in CRPC, when patient is CRPC, I would like to use HRR testing and all HRR testing, not only BRCA1 and BRCA2.
Okay, so all that gamut of 14 to 18 genes or whatever.
So sir, if you go by the guidelines, it should be done as early as possible. So even in a high risk localized disease also, I would like to do. When you do it later, when the patient is already CRPC and multiple bone mets, we struggle to get tissue. And sometimes the bone tissue is not good enough to get DNA. And the archived, patient is already post 3-4 years his initial biopsy, and the archived sample is also not good enough.
Absolutely.
And then
you have
liquid
those points
biopsy is
very
again
valid.
Yeah.
The other issue is the incidence of these mutations in the de novo specimen, that is at the time of onset, and then 5 years down the line when you do a new biopsy.
So again, there is evidence that it doesn't really change much. I mean,
there
if
is some increase in the incidence of these somatic mutations, and you look at you do the somatic test or the germline test.
So in prostate, I think if you're doing it, somatic becomes really important so far as the data is concerned, and the BRCA1 and 2 and the ATM is the most important ones,
right,
as per the study. But again, given the opportunity, and we would like to test for the entire gamut of the HRR mutations.
Dr. Darling, you want to add something?
I think yeah, for treatment purpose is tissue which is important, but otherwise to know the genetics of the patient as such and family counseling, I think first I will go for the blood testing, and then if that is negative, then for the tissue testing.
Some people do both together. I mean, you can go for somatic as well as germline.
I agree with somatic. We can do somatic first, or if possible together. Patient is agrees for together.
Right, because I think there are indications for doing the germline testing, patients who have family history and so on. So it is not necessary to do the germline mutations. But patients who are found to be having a somatic mutation, then in order to assess whether this patient has a germline mutation, a blood test would be called for. So I think that is one way of looking at things.
In prostate and ovaries, there is some sort of a difference. So probably in prostate, somatic really becomes very important.
Right, but if somebody has a somatic mutation, then whether the patient has a germline, then you have to do a blood test. So that is where the counseling will come in, because once you find germline, then the family would be exposed to. Yeah, Dr.
So
Batra.
for germline mutation, for example, if you have rare pathologies like not very common, like intraductal, so that's a straightforward indication for germline. And I think we are at an era where we should get high risk advanced metastatic cancers, all mutation tested right at diagnosis, because it will really help us plan our treatment, and maybe later also we can get it tested again, with all these tests becoming simpler and cheaper by the day.
Right. So I think the testing is important, and I think the guidelines say it should be done as early as possible, not perhaps at the CRPC setting, but then if you have not done it earlier, then it should be done. So what about this DDR gene, the DNA damage repair genes, which are now coming in and the trials are ongoing? So is that facility available in India? I mean, I've been reading this now for last few months, and I think the trial, they showed that they are using DDR genes to identify the subset of patients who could be given these, PARP inhibitors. So any idea anybody has on the DDR gene testing?
Sir, I checked out with medical oncologist only for the TelaPro-3. They wanted us to. So, but that was foundation only. So I think foundation is a comprehensive thing.
So I think, sir, the DDR gene testing is same as the genomic instability testing. The HRR mutation part, and then there is the HRD scoring. So is the DDR and HRD scoring same? Is what I mean. I have to go into the details of it.
So I think that's a new area for all of us.
DDR is probably the same as
We
HRD scoring.
We had only in TelaPro-3. Before that, we are always talking about HRR.
Right. So when
if
the trial comes positive, they'll ask for a companion diagnostic, which is going to be looking into those DDR genes. So I think we need to.
It's probably semantics, sir.
No.
We'll have to look into it, because
there are 52 DNA damaging repair genes, so which they are perhaps looking for. So so there is another technology involved in looking at those genes. Maybe that NGS is focused on the DDR genes. So
it's a companion diagnostic. So they are looking at the.
Yeah, I think the company which gets the drug will get you the companion diagnostic.
As far as I understand that if DDR gene is positive at current time in a CRPC setting, then I can't offer anything if it is HRR negative. That's what I understand.
No. So I think the DNA damage repair genes will include the HRR genes as well. So that's an extension. So 17, 18 genes are the HRR genes, and the other, 34 genes are going to be the
outside HRR. If DDR is positive, then I think at present I can't offer olaparib to such CRPC.
Correct. You cannot.
Those things
have to be. So do you offer olaparib to all HR gene mutation positivity or selective, Vivek?
I think, sir, the data is strongest for BRCA2, BRCA1, and ATM. But then when you run out of treatment options, then definitely yes.
Dr. Darling, your thoughts on?
Yeah, so in the trial which I presented, the magnitude trial, both the categories, BRCA1, BRCA2, as well as rest of them, all of them benefit.
So what about rucaparib? That's also available, which is cheaper.
Yes.
So what about rucaparib? To all HRR mutations or selective?
I don't have evidence for that, but we use rucaparib in
so I think also need to understand that, for example, rucaparib is approved after the use of docetaxel, and even the efficacy of olaparib is better post docetaxel, whether it is BRCA1, BRCA2, or ATM.
Yes.
So I think the approval is for all HRR mutations for olaparib and for rucaparib. And so I think we have that option if you have the HRR gene mutant.
I'm thinking that it is post docetaxel, as you told, right?
Yes.
But it is only approved for BRCA1 and BRCA2, not for all HRR.
Not for all?
No.
Okay.
Approval, FDA approval is for that.
Only for BRCA1 and BRCA2. Okay, thanks for correcting. Now coming to these combination, the PROPEL study which was presented. So that is very interesting. You have contradictory results from niraparib and olaparib combining with abiraterone. So any thought process there? I mean, Dr. Darling.
Yeah, so there was a review which I studied, and they also were confused that why is it so, and they ultimately landed on to that it is probably the study design and statistical calculation which has caused this. And there are some differences also, like the HRR was studied retrospectively in that, and in the first one it was studied prospectively. Secondly, they stopped the enrollment in that trial after seeing the events where almost half of the events were actually PSA progression. So it was not the radiological progression. At that only they stopped. And actually nowadays FDA is very strict. They want the study should be replicable to give an approval, and this replication failed. Actually, we don't know what is the cause, but it's surprising.
So I think it is important to look at the OS, because the real question is giving this combination or sequencing them. Is there any advantage of giving it in combination rather than sequencing? And only the OS can tell you whether there is an advantage or not. So based on the PFS, it is difficult to say that you would be using doublet rather than a single agent.
With the current data, when we don't have the OS data, then I think we should reserve olaparib for later line, not for the first line.
At the moment, we are waiting for the data for the overall survival, so as to prescribe.
Apart
this.
from HRR, for others, I think we should wait for the data.
Right. Okay, so coming to the last part, which is the radionuclide therapy. So I think we come to so your comments. I think so. What are the patients whom you wish us to refer to you for the lutetium, PSMA therapy?
Basically, as FDA has approved last month only for the castration-resistant CRPC prostate cancer, most of these patients are with the first or second line of chemotherapy failure, and after that with extensive metastatic disease. As we see in picture shown by Dr. Charum, none of the bone is left for the normal bone is not left. So we are getting this type of patient, and we are getting response in them. Also, we are adding approximately 6 to 7 months of overall survival in addition to the standard of care. So definitely
So any experience for anybody who treated these patients in the medical oncology or the surgical college?
So I think again, sir, the issue is widespread availability of these kind of treatment throughout, and that is the reason why we are seeing very less patients, and most of the patients are receiving in the much later lines of treatment. Once most treatment options exhaust. So I totally believe that if we are giving this treatment option in earlier lines, then probably we will have more benefit rather than giving it after failure of all 3-4 agents, and when the patient PS decreases.
Actinium is available in AIMS, and lutetium is available across at least 4 centers that I know. And actinium now for till last year it was only for bone mets, bone only disease, and they do fairly well on actinium. And I don't know about visceral mets. This was my.
So does it
question.
work for nodes? That's one of my question.
Yeah,
Does it work for visceral mets too?
For both visceral mets as well as the lymph nodal metastasis also, but predominantly we are getting the patient with the bone mets, so 90 to 95%. In liver mets, all the prognosis is poor as compared to the standard, but still the patient respond with liver mets also.
So it is approved for liver and other nodal mets if they are PSMA positive.
Yeah, if they are PSMA,
I would like to add one
primary criteria for the selection of the patient. Patient has to be PSMA positive on PET CT scan.
I think I have a point that we usually only offer PSMA PET CT. We don't combine PSMA and FDG PET when we select for the patient. We should do both. And if patients are FDG negative and PSMA positive, then only those are candidate for PSMA therapy. Another point I would like to add is the therapy is only phase 2 trial. So based on what decision we are taking, so far are based on phase 3 trial, which are showing the OS benefit. And now we are going towards phase 2 data. So I don't feel comfortable in using PSMA therapy earlier.
So does the guideline ask for the FDG PET as well?
As per the result of therapy trial, this was a standard criteria. Both FDG as well as PSMA PET were done, and patients who were on FDG were not taken in the trial. So primary for the patient is the PSMA positive patient. And as we look for the vision trial, it also gives you the additional benefit. And
vision was used after Doji and Angiopera. That's the third line onwards.
Yeah, that's why I'm saying we are getting the patient after the third line of chemotherapy. We get patient early during the course of disease. So that will definitely improve the overall survival.
So let me sort of rephrase. So if your predominant lesions are PSMA positive, so will you refer to them if you do both the PETs? FDG and PSMA PET.
My question is that where we ideally it should be all about sequencing of therapy. So after failure of taxane and Enza or Abira, ideally trial should be designed in such a way that Kabazi followed by PSMA versus vice versa. And then we'll know that what is the correct sequence. Because it's not about Kabazi versus PSMA, it's about Kabazi followed by PSMA versus PSMA followed by
Yeah, that was my other question. Dr. Kumar Prabhash, welcome, sir, please.
Thank you, sir. So one question for actinium versus lutetium.
Louder, louder.
Actinium versus lutetium. I think so. You said AIMS, they use it. Have you seen the difference in the responses? Because literature-wise looks like actinium, the kind of responses. For lutetium, the kind of responses what we have read now, we have used quite a bit of lutetium. That is in TMH, Tata Hospital, but we don't see those responses. But looks like literature-wise, actinium, you have far better responses. Any experience? Because
I have only 2 patients whom I referred from my own. I'm a private practitioner, so from where I referred to AIMS because they were under trial of actinium and they were still recruiting. And those patients are doing fine. And those were only
both responded.
Yeah, both responders. Both responders.
So 18
months
looks
into
like,
therapy.
that's what literature looks. The kind of regression you see with actinium, we have not
Sir,
seen
at
with
present,
lutetium.
cases are very limited for the actinium. Because of the limited availability, we don't have such data to comparison of lutetium versus the actinium.
And
But
they're getting actinium from which place? At AIMS, they're getting from BARC or
AIMS has
something?
actinium. Yeah, I don't
they
know
make
where
their
they
own-
source it from. I don't know where they
No.
source it from, but they have actinium and both patients received actinium.
Because if they're importing is a different issue. If they're making, then we know, then it will pick up
so
well.
lutetium is available both in the India as well as the foreign through
Yeah,
that can be
lutetium is
imported.
easily
But regarding actinium, it has to be imported. It's not available right now.
Imported.
So we have phase 3 data for actinium as well.
No, right now we don't have.
So they showed data that the lutetium is better than Kabazi.
Yes, sir. That's as per the therapy.
So should we refer our patients post docetaxel and Abira for lutetium?
Ideally.
Is that the message? Dr. Charu?
I would love that.
Okay, so I think so that's another so you can spare your patients from Cabazitaxel in the third line.
The question is that they are afraid that if we refer later, then the bone marrow reserve will down and they will not tolerate. And the same question is here.
But the data says that lutetium is better than Kabazi, period. So therefore you have to expose your patient to lutetium if the patient can afford that.
So regarding bone marrow reserve, the bone marrow depletion, or these are the transient effect. This is all observed only on 11 to 15% of patients. The patient who have poor bone marrow reserve, extensive bone metastatic disease, especially the marrow deposit, these patients suffer more of the bone marrow suppression rather than the normal patient with ECOG1 or the good performance status.
Okay, yeah.
Sorry.
Please.
So regarding practical experience, we have treated around 5 patients with lutetium at Max Saket. And I agree, sir, there is a kind of thrombocytopenia. They are temporary, say around 3-4 weeks.
So how frequently it is done? Once in 3 months, 4 months?
Sir, usually 3 months.
3 months, okay.
6 weeks is
6 weeks to 8 weeks is the standard treatment.
Depending upon the tolerance and the blood counts.
Yeah,
and so on.
recovery from the side.
So I think that's very interesting to see that there are so many options available for patients with metastatic prostate cancer, from chemotherapy to new hormones to PARP inhibitors. And no discussion is today complete without the immune checkpoint inhibitors, although the role may be much less in the prostate cancer. But I think the radionuclide therapy is really up and on at this time. So with this, we can close this session, Dr. Randeep, and thank you very much for the interactive discussion. Thank you, sir.
So Now we move to our next session, which is the session sponsored by Bayer. And we are discussing darolutamide in management of non-metastatic CRPC. So I request our chairperson, Dr. Shyam Agarwal from Delhi. Sir, please. You will invite the speaker. This is coming on the virtual platform. Okay. And I would request Dr. Kumar Pravash to come on the stage and chair the session, please, with Dr. Shyam Agarwal. Thank you, sir.
So good evening once again to all of you. So this is a sponsored program on this entity, which is now, we are beginning to understand, which is the entity of non-metastatic prostate cancer with the rising PSA. So I think there are newer issues here in the metastatic disease where we don't find anything on the imaging, but then the PSA is rising. So we need to understand as to what is the rate of rise and what are the treatment modalities which are emerging. So I think we have 2 or 3 drugs now, but we're going to focus on one drug here, which has been kind of launched by the Bayer, and we have an international speaker. Can I have his biodata here? So this is Dr. Neil D. Shore, and he is from South Carolina, and he is the medical director for the Carolina Urologic Research Center, and he practices at the Myrtle Beach in South Carolina. So he has a large experience. You can see more than 350 clinical trials, and he has more than 200 peer-reviewed publications with numerous book chapters, and he's on several board of various journals, including NEJM, Lancet Oncology. And I think we're going to hear from him before Dr. Neil Shore starts his speech. Dr. Kumar, are you going to say? I think he's going to be the moderator who has just come from Tata Memorial, and so welcome to Dr. Kumar Prabhash. So over to Dr. Neil Shore. Yeah, thank you.
Hi, everybody. My great pleasure to be with you today.
I'm having a little bit of a challenge with my screen here, and I was hoping that the folks from the control and tech support could load my slides for me. I'm having a technical issue here on my end, so my apologies. And if you could do that, that would be great, and I'll go through my slide deck. I was listening earlier to the discussion on PARP inhibitors, as well as in PSMA RLT. I thought it was really fascinating. I'm really honored to be with you today. I'm privileged to be here. Thank you so much, Dr. Agarwal and Prabhash and Sood and Bosky. So it's my great pleasure to talk to you about NMCRPC. I'll do this pretty quickly. I think you're probably pretty familiar with a lot of this data. What I think is particularly compelling right now is this subpopulation of the prostate cancer patient journey, what we call the non-metastatic CRPC, and how we can do so much better for these patients. The real question is, are we adequately identifying them efficiently in India? Are we treating them proactively? And why should we treat them proactively? So next slide, please. Disclaimer, next, please. The next is just my conflicts of interest. And what are the objectives of our talk today? It's really important, I think, for all of our colleagues to recognize that NMCRPC, or what we used to call M0CRPC, is somewhat of an arbitrary construct. It really is dependent upon our use of conventional imaging, a rising PSA in the setting of a castrate testosterone. By conventional imaging, I mean CT scan and technetium bone scan. I've been privileged to be working on darolutamide. I've worked on apalutamide, enzalutamide, abiraterone for the entirety of my career. What drew me to darolutamide when I was doing a presentation in Finland, and the drug was being developed by Orion Pharmaceuticals, was the distinctive different molecular structure of this drug versus apalutamide and enzalutamide, and in particular, in preclinical models, how it does not penetrate the blood-brain barrier. The significance, obviously, for that is possible at that time impact on neurocognitive spectrum. We'll do some cases at the very end, and actually, hopefully, for half of my presentation, we'll review cases with the panel. Next, please. So this roller coaster slide is extremely familiar to all of you. This really, one can talk about this for a full hour, but really when one focuses on the non-metastatic CRPC in the middle of the screen, where do these patients come from? They come from failed surgery, failed radiation, or combinations of that, and patients develop biochemical relapse. And that ultimately, they start androgen deprivation therapy, whether it's intermittent or continuous, with or without a first-line vintage AR inhibitor, such as bicalutamide. But invariably, these patients will progress to NMCRPC or MCRPC, if not followed diligently. Our MCSPC patients never convert to NMCRPC. They go straight to MCRPC. Next, please. So how do we define NMCRPC? I'm sure extremely familiar to all of you listening. Castration T level, depending upon the assay that you use. A nadir PSA, and in our trials, the Aramis, the Spartan, the Prosper, the patients had to have an absolute PSA of greater than 2. I think that if you look at the labels now for the approved indication, the product information for darolutamide, apalutamide, enzalutamide, there is no absolute requirement for a PSA of 2. We use conventional imaging, which frankly is the basis of all the approved survival prolonging drugs in advanced prostate cancer, based upon the prostate cancer working group definitions. PCWG1, 2, and 3. And so now we're entering into this really fascinating space of what to do about PSMA PET technology. These patients in NMCRPC are essentially asymptomatic, with the exception of their T suppression sequelae. The trials, the SPA trials, as their acronym listed here, mandated a doubling time of less than or equal to 10 months, but the product information, the label, does not include that. We can talk about that later. Next, please. This work that was done by Matthew Smith that I participated in with as well, really essentially the take-home point here is that doubling time is a very good biomarker when we're fortunate to have it in prostate cancer, because we know that the rapidity of doubling time is a very good surrogate for the onset to develop metastases. We saw this in bone health agent trials looking at zoledronic acid, and then also subsequently with denosumab. Next, please. This essentially is a little bit busy, but really what it tells you is that when you start developing metastases, whether it's predominantly bone metastases, which is the favorite landing site, host land for advanced prostate cancer, sensitive or resistant, the clock starts to tick very fast. Survival is diminished, and very importantly, health economic outcome reporting data demonstrates a marked increase in our healthcare costs, regardless of the country that you practice in. Bone disease leads to an earlier demise. It leads to skeletal related events. It leads to fractures. It leads to hospitalizations and a poor quality of life and increased healthcare costs. So we want to delay bone metastases in an NMCRPC patient for these clearly distinctive reasons. Next. So the unmet need, we know that patients who are castration sensitive typically do not die of the disease. They die when they develop resistance. And as that previous roller coaster slide showed, the time of duration of therapy from line 1 in MCRPC to line of therapy 2 or 3 or 4 is markedly abbreviated and ultimately leads to death. So the FDA recognized, as did the EMA and other agency approving bodies, that metastasis-free survival now became a surrogate endpoint for a registrational approval. Our typical treatment options before approval of the second generation AR inhibitors, or we can call them androgen receptor targeting agents or novel hormonal agents or androgen receptor pathway inhibitors, they really are the more powerful blockers of AR translocation from extra to intracellular, and thus shutting down cellular proliferation. It's the earlier generation AR inhibitors, the nalutamide, flutamide, bicalutamide, which are clearly inferior. So we'll talk about the goals of NMCRPC in a minute. Next, please. So this is a build slide. So let's build to these 3 bullets here. So what are the goals? I talk to my patients about prolonging survival. I talk to them about preserving quality of life. I talk to them about preventing complication of therapy. Those are the first 3 Ps. And then the 4th P I talk about is their preference value. How risk-seeking or risk-intolerant are they? Interesting, in this piece of the puzzle here, you see the PSA, which we all, I think, have euphemistically heard it said stands for patient and physician stimulated anxiety. But nonetheless, it's a real phenomenon. And I'll show you the data that is helpful for curtailing this anxiety. Next, please. So this is a compilation of these 3 outstanding trials. Aramis was the 3rd to report. I was involved in Prosper and in Aramis. I've done a lot of work with apalutamide in other studies and ongoing studies. The bottom line, these are 3 excellent androgen receptor inhibiting drugs. The question then becomes, are there any potential nuanced differences or significant clinical difference regarding safety and tolerability and drug-drug interaction, which may lead you to pick one versus another? The primary endpoint, MFS, when they first reported in all these studies, All these studies were a 2-to-1 randomization of the treatment combination arm to a placebo ADT control. You can see on the far left the inclusion criteria. Of note with Aramis, and I had the good fortune to be on the steering committee with Matthew Smith and Kareem Fazazi, our first hierarchical secondary endpoint was OS, which means for those of you who enjoy looking at the statistical analysis plan, if we didn't meet OS in the secondary endpoint, we would have had to stop. So it was a real a bold gamble that OS would be met. And this was decided upon prior to any of the readouts of Spartan or Prosper. Next, please. Here's the trial design. As I said, interestingly, of the 3 trials, this is the largest one in terms of a population of a little over 1,500 patients. A 2-to-1 randomization. Darolutamide is given in 2 tablets twice a day. The other Enza and APA are given as 4 tablets once a day. That's really the main difference there. And all these drugs can be given with or without food. Next, please. I go right to the KM. This led to our first New England Journal paper, a hazard ratio of 0.41, p-value less than 0.001. This curve separating early, about 80% of the initial analysis here. These were radiographic progression events, and only about 20% were death-related events. But what's very encouraging is one sees this near 2-year, at the median, a near 2-year delta from the time to developing radiographic progression with conventional imaging. Next, please. And then I bring you to our secondary endpoint. I will show you the final analysis, which ultimately led to a second New England Journal paper. And one sees here a hazard ratio of 0.69, a p-value of 0.003. So even though there was greater than 50% of crossover in the control placebo arm to receive darolutamide, and a comparable amount of patients receiving life-prolonging drugs in both treatment arms, there is still essentially this near 1-year difference in survival by starting darolutamide in the NMCRPC population. Next, please. Key secondary endpoints: time to pain, time to first antineoplastic or cytotoxic chemotherapy, a symptomatic skeletal event, all statistically significant, favoring early use of Daro versus just a wait and see approach. Next, please. And then additional exploratory analysis, the progression-free survival, and the PSA-free progression. I mean, you can drive a big truck through the separation of the curves there. The PSA 90s, PSA 50s, I'll show you on the next slide, are rather impressive. Hazard ratio of 0.13, getting back to the importance for some patients and physicians in the biomarker of PSA with outstanding decline. Next, please. And this slide really is another way of looking at that, the PSA response. It's pretty dramatic when you look at the sort of waterfall plots at the top right for the patients receiving Daro versus the placebo. It's rather visually impressive. And the amount of PSA decline of greater than 90% is 51%. And PSA 30s to 50s also exceptionally powerful. Next, please. So what about quality of life? We're taking, these are typically elderly patients. Are we causing harm? Where is the risk-benefit analysis? And we looked at bowel symptoms. You see the abbreviations for what we looked at. Urinary symptoms. Interestingly, these urinary symptoms, and you see everything to the left favoring the use of darolutamide versus the control placebo. Remember, those patients all continued on ADT as well, that there marked improvement in both GI and GU symptoms. We've presented this at recently at ESMO 2021. We'll be presenting this again at AUA 2022. And we have publications that are in draft and are in submission and will certainly come out later this year. Next, please. Now, as a trialist, and I'm sure many of you are, I've done lots of clinical trials, and I know so have many of you in the audience. When you look at discontinuation rate for adverse events, and you see a significant difference, that's a kind of a flag to tell you, okay, I've got to understand the AE management. Well, it's essentially comparable. So what that tells me, what this teaches me is the outstanding tolerability of this drug. And tolerability is everything to elderly patients. Fatigue is the bane of existence of virtually every oncolytic in every tumor stream. And I'm going to show you more data on that. Next, please. So look at the all grades and then look at the grade 3/4s done separately, and they're essentially comparable with a slight 5% difference in the grade 1, grade 2 for fatigue. When one looks at falls, fractures, rash, cognitive impairment, hypertension, the delta is really very narrow. We published a paper recently in the Journal of Urology. Susan Halaby is the first author. I'm the senior author, published in 2021, really looking at an indirect adjusted comparison of the 3 trials based upon their adverse events, based upon their DDIs, drug-drug interactions, and what's been published in the 3 respective New England Journal papers. And I would encourage you to look at those articles. Next, please. Additionally, neurocognitive. I mentioned all of the trials with darolutamide allowed patients to be entered in with seizure histories, or if they were on anti-seizure medication, or they had a history of a CVA. Not true for the other AR pathway inhibitor trials. And then with that, I think it's really remarkably impressive to look at the grade 3/4s. This just teaches that there's exceptional tolerability. Yes, we see a little bit more on the fatigue side, but virtually all of the other neurocognitive CNS-related AEs are comparable to placebo. Next, please. And by the way, this long-term data now has been recapitulated in the Arison's trial, which is a different patient population that was recently presented at ASCO GU by Matthew Smith. Okay, so concomitant DDIs. This is a busy slide. Apologize for that. But our patients are on polypharmacy, typically, who come in regardless of where you're practicing. They're on various cardiovascular agents, antithrombotics, lipid-modifying agents, sometimes analgesics, antidepressants. And I think what was particularly compelling here is that the incidence of adverse events were comparable regardless of the polypharmacy, and the polypharmacy was pretty well balanced between the 2 treatment arms. Next, please. NCCN guidelines. This is chaired by Ted Schaefer, the chairman of urology at Northwestern. You go to the middle and you see that APA, DARO, ENZA all have now strong rating for instituting clinical utilization in NMCRPC. Next, please. So in conclusion, this is an area, NMCRPC, we've called it M0 CRPC. Maybe we should really best be calling it M0.5 as opposed to MCRPC or M0, because we know there's microscopic metastatic disease. It's there. We have macrometastatic. This is micrometastatic. And we can talk a little bit more about that with the cases. The androgen receptor targeted agent therapies have now demonstrated the level 1 evidence, APA, ENZA, and DARO. And I really, this is how I approach it. I talk to my patients about these 4 Ps throughout the entirety of virtually every cancer journey, all throughout GU oncology, which is what your symposium is all about, which I think is fantastic. But at the end of the day, it's very important to optimize novel mechanisms of action. And by that, I mean, we have AR pathway inhibitors, taxanes, microtubule inhibitors, radiopharmaceuticals, radium, now the PSMA RLTs, which have distinct mechanisms of action. In some countries, we have immunotherapies. For example, in the US, it's the only country that has Sipuleucel-T, but there's also now pembrolizumab for microsatellite high instability tumor agnostic indication, and the PARP inhibitors. So what does that tell us? That tells us that for when a patient will succumb to CRPC, it's important that they receive as many novel mechanisms of action as possible. Sadly, in North America, recent data tells us that the average patient will succumb to disease receiving 1.7 therapies. There are now 12 life-prolonging therapies as approved by the FDA. Next, please. So for purposes of time, let's go right to the cases. And I certainly really looking forward to Dr. Sood and Bakshi and Prabhash, your comments and audience questions. Next, first case, please. Let's go through this relatively quickly. Next slide, please. So here we have a 76-year-old, I said Indian male. We're in India today, even though I'm here virtually. I feel like I'm over there. I wish I was there in person. But I'm sure for many of you, you see a patient like this. He's married a long time. He has a big family. He enjoys golf. He enjoys an active lifestyle. He likes to travel. He is, as with the limitations even of the pandemic. So like so many of our patients, he has this whole laundry list of comorbidities, diagnosed 6 years earlier with an elevated PSA, a palpable DRE, prostate abnormality, biopsy reveals Gleason grade group 5, the most aggressive. His extent of disease imaging workup is normal. Given the age, choice selection, he decides instead of a prostatectomy to have external beam radiation. ADT is administered. We can certainly debate whether you believe in 18, 24, or 36 months. And 2 years after stopping the ADT, he develops a PSA relapse, or what we call biochemical relapse. Scans are repeated, they're negative. Androgen deprivation therapy is reinitiated. Debate agonist versus antagonist. And then 3 years later, he develops NMCRPC from his initial diagnosis. And now that would assume a castrate level of T, a rising PSA from nadir, and his doubling time is less than 10 months. Interesting, in the product information, you don't have to have a doubling time less than 10 months, but we can also discuss that. The NMCRPC considerations, he is started on Nubeqa or darolutamide. Next slide, please.
Sorry, I can't help it. Sorry, I can't help it. Sorry, I can't help it.
We're having a computer. Are you guys hearing that? Somebody's talking to me on here, but did the slides come back on? I seem to have lost them. But maybe there was enough opportunity to see, and we can talk about the case. So I certainly welcome any comments right now from the panelists regarding NMCRPC diagnosis and therapeutic decision making.
So Dr. Neil, I'm Dr. Kumar Prabhash here. Thank you for a nice presentation and good learning. So this is slowly, in India, we do have a lot many advanced disease patients, but yes, we do have a good number of patients who are localized disease or locally advanced. And yes, there is an issue regarding when and how we pick them up. And once we pick them up, what happens to those issues? As on date, we have been debating that we want to treat the patients when we have a symptoms, but here we have a situation that patients are asymptomatic and we do see PSA and then we want to treat them. Yes, we have been doing with ADT. Till recently, we didn't have many effective treatment. But out of those 3 treatments you said, we do have one of them which is available in India and freely available. And this is another one which we are looking for. And yes, as you suggested, this looks far more attractive, considering that it is less tougher on patients, and especially when showing those side effects as compared to placebo has been similar. But we have not, I have not used it personally, but we want to know from you, in clinical experience, do you have a similar experience that hardly anyone has any symptoms on his side effects? And what we call in, we call here that, is it like a holy water that patients go through very smoothly? We know that we do have some drugs which is very patient friendly. And in your clinical practice, does it belong to the same group of drugs that it is very patient friendly?
Well, thank you very much for the question. Yes, I was involved in the phase 2 studies with Karim Fazazi, the Aridase and the Ara4s, and I was amazed at how well tolerated the drug was. And so I've been giving this drug, and I've given lots of Enza and lots of APA, and now lots of Daro. And its only approval right now is in NMCRPC. It's in front of the FDA now for MCSPC consideration with docetaxel. There are 2 large phase 3 studies ongoing at MCSPC without using docetaxel. There are MCRPC studies going on. I would tell you that, yes, it is, and I think it goes back to, it's a completely different molecule, and you don't get the blood-brain barrier penetration, which has been very well described in animal models, of course. Hard to do those studies in human models. But because of that, I use it, I don't just save it for my elderly and my frail. I give it to my younger patients who are marathon runners, who unfortunately may have advanced disease. And I personally have been using it off-label from the NMCRPC. That's just me. That's not Bayer telling you that, because of its tolerability. And so I would encourage you, when you have an opportunity, I still use APA and Enza. They're good drugs, but for some patients who have real concerns about the maximizing their safety and tolerability, I really like the Daro.
I think same situations, scenarios we do see in our country also, like the case which you have mentioned, post maybe radiation or maybe even surgery, when the patient would have biochemical recurrence, put on ADT. And like Dr. Kumar has just said, we do have all these options now.
Well, yeah, in the sensitive arena, it's fascinating, right? When patients who fail surgery, fail radiation, or both, and you're going to initiate for the first time, ADT versus now ADT with an AR pathway inhibitor versus an AR pathway inhibitor alone. We don't have level 1 evidence to support adding an AR pathway, the novel AR pathway inhibitors, but those studies are being done. They're being done with darolutamide, they're being done with enzalutamide and apalutamide. I think it's kind of tremendous, right? We've seen these drugs get developed in the sickest patients, post-chemotherapy MCRPC, and we've advanced proximally to the left of the curve. We're even looking at these drugs now, of course, in active surveillance. I have a paper coming out pretty soon. It'll come out in JAMA Oncology on a large phase 2 study where we looked at an AR pathway inhibitor for active surveillance patients. So there's no doubt your question, if I heard it correctly, we'll be using drugs earlier and earlier and earlier, but patients will be younger. They'll be on drug longer. So you really want to make sure that they can tolerate the drug well. That's pretty key. These drugs work really well, all 3 of them. They're excellent at preventing translocation of the AR receptor from the cytoplasm to the nucleus. They do that really well, but it's all about quality of life and tolerability. So we have to safeguard that for our patients.
Yep, thank you.
So I think the important question to my mind would be to pick up these patients, early. In order for that to be done, So they really need to be closely monitored for their PSA levels. And these patients are, as you said, would be treated for curative purposes when they, develop the PSA rise. So the question is, how frequently should the PSA be monitored in these patients who have been treated either with surgery or radiation?
Yeah, that's a really important question. As a urologist, I think a lot of our colleagues sometimes don't follow as closely as our medical oncologists are used to doing. So when I start a patient on ADT for biochemical relapse, I see them at a minimum every 6 months. And I want to follow their nadir. Of course, I always want to check to make sure that the ADT is working and they have a castrate level of T. As they get beyond a year, if they're doing well, and even to 2 years, I start actually seeing them more frequently because I know that the resistance clonal population will ensue. And that's when you have that great opportunity to start a drug like darolutamide. Patients are not going to come back and say, hey, I think my PSA is rising. We all know that. And so missing the opportunity, the second case, which I apologize, I think we'll probably run out of time, but the second case I had was an example of someone who missed the window to start a drug such as Daro, or could have been APA or Enza, who missed that window and then developed MCRPC that much earlier. And once that resistance develops, the biological clock is ticking that much faster, leading them closer ultimately to death, as well as all the proximal challenges here.
Thank you. Dr. Sood is here. Dr. Sood,
Yeah.
sir, any comment?
So I have only one comment that we are withdrawing ADT maybe after a certain period, maybe after 2 years in this case. Are we monitoring only with PSA or also the testosterone levels? Because mostly it is nowadays presumed that this testosterone levels will not recover after 2 years or 3 years of ADT treatment. But if you monitor it carefully, and if their testosterone levels are increasing back, coming back to normal, so in that case, I feel that risk is more. You are considering darolutamide for those patients in whom the testosterone is increasing or not increasing. But I feel in my practice also, I practice that we don't have darolutamide, but we give maybe enzalutamide or maybe even bicalutamide if the testosterone are increasing back fast after ADT is stopped. What is your opinion? Is this the right thinking?
Well, you raised some really great points. First of all, the age of the patient, so older men, baseline testosterone before we initiate ADT. So the lower the baseline testosterone, the older the patient, and the longer the duration of ADT are negative predictors for resolution to becoming eugonadal, to your point, even though when we stop it. So I'm a big champion for regularly checking testosterone levels, especially when I stop the ADT. For example, in this case, a radiation patient. I think starting for a BCR, a biochemical relapse, I have started patients on just bicalutamide alone who really hated the side effects of testosterone suppression. I mean, let's be clear, testosterone suppression is horrible for many men. For some, they don't seem to be bothered, and for some, it's really, really bad. And so de-intensification is a hot area of study. But at the end of the day, for somebody who has a bad phenotype, has biologically aggressive disease, who's had a castrate T, and the PSA is going up, that's a different phenotype. And for them, and only then will I then start a drug such as Daro or Enza or APA. We don't have level 1 evidence yet for monotherapy of an AR pathway inhibitor, the newer ones for just BCR alone, as you're describing. I have used Bica because it's inexpensive, but but there's really no level 1 evidence for that either. But sometimes we have to, we sit knee to knee with the patient or 6 feet from their knee with COVID. And we have to do what we think is best for them at that point in time.
Thank you. Exactly, this was coming to mind, so I thought I'll discuss this. Thank you.
So one last question from my side, and you did mention that the curve, you can get a truck inside it. So what happens to these drugs, in metastatic CRPC, when we use in second, third line, we struggle to get those 2 months, 3 months difference. And we used to not be certain that time, at least I was not certain how well it will do in HSPC. And looks like almost all of them, they move to HSPC, they do better. If they move to NMCRPC, they look excellent. What happens, why the similar drug starts acting in, and do you think, as was asked, the benefit when they get moved further earlier will be far better or different?
Yeah, it's a really important question because, we're all learning together. I'll make one statement. I'm not at all a big fan of sequencing novel hormonal agents one after the other. Once you've exhausted the experience with Daro or Enza or APA, and even for Abby for that purposes, maybe a little bit of benefit. You get a little bit more benefit if you sequence after Abby with one of the ARPIs. But I'm a big proponent of avoiding that and picking a novel mechanism of action. So if you start a patient on low volume or high volume MCSPC, and I think you have even more than we do in the US, I think somewhere your newly diagnosed prostate cancer patients are way north of 25%. You have to start them on a couplet therapy if you can, if it's accessible, if it's affordable, whether it's ADT and an ARPI or ADT and DOSI. Now great data from Arisens that triplet works well too in high volume. And then when they develop resistance, do they have an HRR mutation? Can you weave in a PARP inhibitor? I'm a big proponent of that. If you're bone only, would you go with radium because it's more accessible? I just gave a presentation at APCCC on the role for radium. It's not a binary thing that if you have to give radium or a PSMA-RLT. You can give radium, and then you can give docetaxel, and then you can give a PSMA-RLT under the current approved indications. The PSMA-RLTs will probably migrate pre-chemotherapy. We're looking at them even in MCSPC, but for now, you have options. And I think that, again, I would emphasize, to me, judiciously, efficiently giving the patient as many novel mechanisms of action is the key to their longevity.
Thank you, Dr. Neil. We really enjoyed your talk, and we did learn a lot, and we'll be very keen to have you again. Thank you so much. Thank you so much. We just got, time got over, so we're stopping, but we had a very nice discussion. Thank you so much again.
Thank you. Great pleasure to be with you, and have a great remainder of your conference. Honored to be part of it.
Thank you.
Thank you very much, Chairperson, and thank you very much, speakers, Dr. Neil. Now we move on to our next session, pharma session sponsored by AstraZeneca. And the topic of presentation is management landscape in first line metastatic CRPC. And I request Dr. Ranjit Sahu, Professor, Department of Medical Oncology, AIIMS, Delhi, for the presentation, please.
Good evening, everyone. Yeah, thank you. So I am thankful for the organizers to have given me this opportunity. And I'm feeling a little rusty because over the last 2.5 years, I have not attended a in-person conference. I was really concerned, would I be able to do this one? So the topic is evolving treatment landscape in first-line metastatic CRPC. I am focusing on mainly the HRR mutant CRPC because that is where the treatment is evolving the maximum. I do not have any conflicts to share. And this is actually been described quite a bit in the by the previous speaker. I will skip this. So in metastatic CRPC, when it is imaging wise, they are detecting metastasis. The workup is pretty much comprehensive these days. I have taken it from the NCCN guidelines, the latest version. We need to do a metastatic lesion biopsy because of the number of testing we wanted to conduct. Now this testing, it includes both MSI, or the deficient MMR, as well as the HRR mutations. If it is not previously performed, and this also has come up, the tumor mutation burden testing, because there are a lot of tumor agnostic approaches for immunotherapy that are developed over last few years. Now, to manage a case of metastatic CRPC, the initial treatment will determine how we are going to treat them further. We still see quite a bit of patients who had not received prior docetaxel or any other hormonal therapy. So they are only treated with ADT only. And the preferred regimens are anything between abiraterone, docetaxel, and enzalutamide, all are category 1. In patients who have received prior docetaxel, the preferred regimens are either abiraterone or cabazitaxel or enzalutamide. Now, this is one of those recent thing. Now, once these regimens are going and these drugs are going into the frontline metastatic CSPC, we will be looking at this sort of problems. Those who had only received novel hormonal therapy and no taxane, then the preferred regimen is docetaxel. And this is where the other newer drugs are coming up, and mainly as category 1 for olaparib. Rucaparib has not given a category. Now, if I draw your attention, olaparib is indicated for all the HRR mutations, while rucaparib is only indicated for BRCA mutated. Now, those patients who have received both docetaxel as well as prior novel hormonal therapy, the only drug that has been indicated here is cabazitaxel, which is category 1, even though the study that had conducted for cabazitaxel, which is an old study, these are not the patients that had been included in that study. But nevertheless, logically, cabazitaxel surely would work in such circumstances. PARP inhibitors are also indicated in such cases if they have HRR mutations. Now, this part we need to understand. Now, once we walk up our patients and they turn out to be HRR mutants, do they behave any different than those patients who aren't? Now, these had been some fewer studies. They showed that those who are BRCA2 mutant, which is the most common HRR mutation in CA prostate, they behave more aggressively than those patients who haven't. And this is another study where it has shown that they have, for the standard of care options, the outcome is not that great for patients who are BRCA2 mutant. So these had been some recent guidelines sort of how should we do genetic testing, whether we should do only germline or maybe somatic. Typically, they require different platforms. Now, for somatic, we require tumor tissue. For germline, we require either buccal swab, or it can be also done in the blood. It is prudent to go for co-testing because all these testings are still pretty new. And when we do this testing multiple times, then the results are more accurate. So we should do both. It increases the diagnostic yield. And if we know it is a germline mutation, then we go ahead and do the proper counseling of the patient and the attendants. Thirdly, there is no difference in responses and outcomes of patient with germline or somatic mutations when they are treated with PARP inhibitors. So if the patient is affording, it is always wise to conduct both the testing. Now, what should be the optimal tissue? For germline, it doesn't matter. But for the somatic mutation, a recent tissue should be more productive. Again, if it is an older tissue, then the positivity rate, it goes down. For tissue which is stored for less than a year, it is close to 70%. If it is stored for more than 10 years, it goes down to less than 50%. Thirdly, the metastatic sites have a higher yield than the primary. This is a little controversial because across the studies, there could be different inferences. And fourthly, although the most common method, core biopsies, they do not have that greater yield, but they are still acceptable. The yield is close to 50%. Now, this is the latest study of usage of PARP inhibitor in combination with abiraterone, acetate, and prednisolone in first line in patient across, whether they are HRR or non-HRR, it doesn't matter. They have treated it in all patients who are metastatic CRPC as first line. The dose of olaparib is pretty much standard, 300 milligram BD, as is abiraterone, that is 1000 milligram OD in empty stomach. The primary endpoint here is interesting. It is radiographic PFS. Now, over the time, we have understood that the best marker will be radiological PFS even in prostate cancer. PSA might not give you the exact detail. So now this has been acceptable as a surrogate endpoint. Now, this is interesting. Over all the patients, it has shown that the radiological PFS is better than the patients who are treated with only abiraterone and prednisolone. With combination, it increases. This is by investigator assessment, which is the radiological PFS is 25 months with olaparib and abiraterone, and it is close to 17 months with placebo and abiraterone. And in independent central review also, it is pretty much similar. The overall survival, however, it is not different. But I would say this is a study which is planned with the primary endpoint of PFS. For OS, we require a lot of follow-up here because the median is also not reached, even though there is some trend, but the median is not reached. So you should not interpret that. Interestingly, in this study, where they have received a median of 24 months of olaparib, there had been no incidence of MDS and AML, which is reported. It again tells us that this study requires a lot of follow-up to know how the overall survival curves are behaving. And second is, what is the chance of MDS AML? Because the duration of PARP inhibitor is pretty much good here. And the side effects are pretty much consistent what had been seen previously. Now, this part is pretty interesting. When they have looked into patients who are HRR mutant versus those patients who are not HRR mutant, the benefit is across. Please remember this part. This is another study which was also presented in ASCO-GU, and this was with the drug niraparib. Now, in this study, they have willfully used a low dose of niraparib because of the side effects. Okay, so they have used a 200 milligram dose of niraparib here. They have classified patients into those who are having HRR mutation, but versus those who do not have HRR mutation, and they have randomized it with niraparib plus abiraterone versus placebo and abiraterone in both these arms. Now, this second arm, that is patients who do not have HRR, this arm was this was taught for the futility analysis because of this thing. Those who do not have HRR mutation, addition of niraparib is not helping these patients. This is in contrast to what we have observed for olaparib in the previous study. And this part I can skip. When you look into the radiological PFS in patients, especially with HRR mutation, mainly the BRCA1 and 2 mutated patients, which is the primary endpoint of this study, it is pretty much clear-cut. Those patients who received niraparib at that dose, there is a radiological improvement in PFS, which is 17 months versus those who have received abiraterone, it is close to 11 months. And this is the primary endpoint of the second co-primary endpoint was across all the patients who are HRN mutant. Here as well, there is an improvement in radiological PFS. And this PFS is across all the subgroups. I won't go into the detail. So these are some secondary endpoints, which is like prolongs the time to cytotoxic therapy. We could actually skip it. Here as well, in the ITT patients, for the primary endpoint, there was no improvement in the overall survival with whatever follow we are having. So I can skip it. Yeah. So to wind up my talk, as of today, this is our practice at Institute. For patients who are metastatic CSPC, in last 3 years, we hardly have used ever docetaxel. We are pretty much confident with ADT and abiraterone. And ADT plus docetaxel is as good as a treatment option in these patients. But because of all this COVID-19 happening, I think abiraterone was pretty much a good drug to be combined. And in patients who have difficulty in procuring abiraterone, those who are poor, we use the low dose abiraterone with food. That part we have published, that when we give it low fat food, a 250 milligram OD abiraterone is as good as giving 1 gram abiraterone. But I think the future will be, it will be ADT, docetaxel, and possibly darolutamide or abiraterone in future. So most of these patients will be treated as, in the very first line. For metastatic CRPC, we continue ADT. We advise HRO workup. Germline first. Germline is very easy. Somatic can be ordered subsequently after a repeat biopsy. Docetaxel is the agent of choice. If the patient is having HRM mutation, especially BRCA mutation positive, we also advise to add carboplatin because these patients, they do not do nicely with the single agent docetaxel. So we add carboplatin with AUC of 5 in patients who are BRCA mutant, or when on a repeat biopsy we are getting some small cell carcinoma component. To come into the literature of single agent PARP inhibitor in HRR mutation, to summarize, patients who are BRCA2 mutant, the data is pretty much clear for both olaparib as well as rucaparib. For patients who are non-BRCA yet HRR mutant, it is actually unclear whether these PARP inhibitors are helping as a single agent. But having said that, there is now some modest information of PALB2. Those who are mutant PALB2, olaparib could be useful. They are almost as effective as in BRCA. Now, the PARP inhibitor combination with abiraterone, which has been discussed as abstracts, they are not approved as yet, but olaparib can be given in addition to abiraterone and prednisolone if it is approved for all patients irrespective of the HRR mutation. If these studies were proven to be positive, and we have long-term data that the risk of MDS or AML is not increased, we need to look more into it. For niraparib at a 200 milligram dose, which is approved in that, which has been discussed in that study, it is mainly for mutant HRR patients. I still feel there is a dosing issue. If you increase the dose to 300 milligram, you would have done possibly as well as olaparib. But having said that, using PARP inhibitor at that dose have got toxicity issues. And lutetium 177 PSA, we have used it quite a bit. but it is, as of today, it is to be kept for second line. But yes, in individualized patients, you could use it as first line. So that will be my last word. Thank you for the kind attention.
Will you treat someone who has a genetic background mutated? Would you like to check somatic, or you're okay prescribing Mulapar in the later line?
So the action, the efficacy is similar across germline or somatic, so it is okay, sir.
You would not like to check somatic, and you are
No.
comfortable using
Yes,
Mulapar
yes.
in the later line.
Yes, yes.
Thank you, sir. Thank you very much, sir. Now we move to panel discussion, which is the last thing for today. And I once again request Dr. Kumar Prabhash to please moderate the panel discussion. So would you invite the panelists, or I should do that. Thank you, sir. So in the panel, I request Dr. Tara Chand Gupta, the consultant medical
if we are willing to treat bone mets patient as an oligometastatic disease with local therapy, should be treating them with local treatment after some time? Node positive, pelvic lymph node positive.
CN plus, I would want to start with androgen deprivation and abiraterone right now.
Okay, upfront ADT plus abiraterone, and then followed by local treatment.
Followed by local treatment, for which the evidence is more in favor of radiation.
In favor of radiation. Robotic is there. Radiation, robotic. I had my colleague, I saw her, I think so she has left. She was there, she went to the room. So robotic, or because there's no competition here, so
the thing
Then sometimes we do think of doing a surgical thing.
Upfront or later?
No, later. Whenever you are going to take the decision, because always it is mentioned when you are planning surgery, do select well your patients.
Correct. So I think it is important to remember what has been said. See, if you would have asked me 15 years back, I doubt Dr. Ganesh and you would have said the same answer. Most likely ADT. That would have been by and large the answer. May or may not be RT. That also used to be answer. But outcome has changed. What was shown by Dr. Ranjit, CRPC, the curve was not dipping. I was looking, there was a good follow-up to around 24 months. If that comes again, CRPC around 24 months, and you're not reaching median, around 60-70% people. But I had an issue. Rucaparib, so what is that? Another drug? What? Niraparib. That was not there, but in olaparib combination abiraterone, it was not coming down. So if those kind of outcome you have, you want to see that can you have those disease patients without having disease free, and that's the reason we hear that in lymph node positive patients, if we can remove it, it's good. One can do that. It's a good option to do it.
Go ahead. To add one thing, sir.
Please go ahead.
Similar type of scenario I faced just 2 weeks back, only, in which a patient was having fever also, which we assumed that probably is a burning maturation which can happen. But fever was not settling in spite of the treatment of ADT, which we started in this patient. Then I thought that it might be something else. We had done a biopsy from this node, and to my utter surprise, it came out to be DLBCL triple expressor. That has changed upside down. It is a dual synchronous primary. So
I agree with you. I will make handle kar raha hu DLBCL with lung tumor. And then first of all, the whole debate went upon कि ये bone जो disease है वो DLBCL है या फिर lungs है mets है. And बता रहा हूँ, thankfully my radiologist said I think it's DLBCL. Then I put it on radiologist and started treatment. And thankfully the patient took treatment in Pune. So thankfully I was not liable. And patient has a CR. Everything has gone away. Then I asked my radiologist, ये बताओ why you were so confident it is DLBCL in bone. उसने भी बोला, after all going through, I realized that better to call DLBCL. So I agree with you. You get surprised, and next time I get concerned. So again, remember that you can have those second primary in this situation. Coming back to that was the surgery part we asked. Now from medical oncologists, which combination? Which we heard one was ADT plus abiraterone. Sunil, that only that, or we hear many more things now?
ADT plus abiraterone.
ADT plus abiraterone? Yes, sir.
Yes, sir. So, I mean, till now we are following ADT plus abiraterone. For this case, patient particularly in this era, I think ADT plus abiraterone followed by response assessment 3 to 6 months, then plan for surgery because of the lymph nodal involvement. And now we have the propel data as well. I mean, sorry. With that, I'll stop.
Okay.
So I do agree with my co-panelist, sir. So as far as oral survival benefit, the COUAA 302 trial, which have shown a oral survival benefit, which is better than any of the other drugs which we can think of in this type of scenario. In this scenario, I think enzalutamide also can be considered along with the ADT. Otherwise, one can argue.
So ADT with abiraterone or ADT with enzalutamide.
Absolutely.
Okay.
But oral survival benefit is like it's favoring it. Leverage is more for abiraterone.
Okay. Tarachan?
Sir, till now I have not used abiraterone. Only ADT I have given, but I may use with the recent, according to the recent data, ADT plus abiraterone.
ADT
plus now I am using only ADT.
But till now only ADT.
Till now I am using ADT now.
Okay. So Tarachand has been exception. No.
No, it will
Ranjit,
be
aap kya
ADT and
karte hain?
abiraterone, but
Ranjit.
it will be slightly different. I think what Mandeep was trying to say was that I would like to restrict abiraterone to 2 years, considering this as only one nodal disease as in the pelvis. So it will be treated slightly differently. This is one of the trials which I think someone presented from the Stampede also. That there is a retrospective. It was a retrospective analysis, and also in the NCCN guidelines, if you see when they are nodal disease, a localized, when they treat with the localized therapy, a nodal disease, or any of the 2 high-risk features such as PSA 8, 9, 10, or there is another 2 criteria. One was Gleason score and one was T4.
The Stampede study.
And another. So in these, either of the 2 of them. So these were high risk. N positive. If it is N negative, then T3, T4, Gleason more than 8, and PSA more than 40. Any 2 of these features. So in them, they have given abiraterone only for 2 years with ADT. So it will be treated slightly different of what we treat a metastatic disease like a bone mets or a low risk metastatic burden.
So let me put you on the spot a bit. If a metastatic disease, then ADT plus abiraterone?
Yes, yes, I would. It's a low volume disease, ADT plus abiraterone.
So,
Low volume, non-oligometastatic.
No. So Ranjit, you have convinced everybody. No docetaxel. So all medical oncologists, we haven't got one saying yes for docetaxel. So anyone in the audience, I can see some of my colleagues there. No, I was also used to be backbencher. Only no docetaxel. Everyone convinced. But coming back to, I take your point. I agree. All of them are equal. One can choose one of them. No one willing to choose ADT plus hormonal therapy and plus docetaxel.
Sir, I said low volume.
Oh, achha, sorry.
Low volume, non-oligometastatic disease. We will use ADT plus ABI or ENZA. But yes, if it's a high volume disease,
that was a consideration for everybody.
Yes,
My apologies.
yes. So that's why. If it's a high volume disease, I think across it will be the. I mean, we have already seen peace and Arasens as well as the subgroup analysis of enzamet, which came 2 years prior. Where already ADT plus enzalutamide plus docetaxel had shown a PFS advantage, and now the OS advantage with darolutamide triplet as well as with the PEACE one. I think there will be no doubt that if you are high risk prostate cancer, we would all like to use ADT plus docetaxel plus abiraterone or daro if it is available, darolutamide. Only my concern is that I don't know. The trial comparison has been done with ADT plus dosi. The trial arm is not having ADT plus abiraterone or ADT plus enza.
Yes.
So we don't know whether
if that was there, then what happens?
Yes, if the third arm, suppose I use ADT plus abiraterone as my control arm, and my experimental arm is ADT plus abiraterone plus dosi, whether there will be the same PFS or OS advantage as seen in PEACE or Arasens, that is only the hitch in the mind. But if I have to use and the triplet is for high risk, yes. Or I think Vivek in the last panel discussion, he has put it very rightly that if I have to use docetaxel in high risk, after PEACE and Arasens, it will be always triplet and no docetaxel alone.
Or not alone.
Yes, I think that was a very nice statement he made.
Okay.
Just one suggestion. Since here after the PET scan, we are aware that it's just a single lymph node, which is 2 centimeters. We expect, and everybody expects that it will respond to hormonal therapy.
Yes,
and subsequently, we are contemplating a cure option for him in terms of a surgery or maybe a local radiation. Do we really require abiraterone at this time? Because we know that if we give first dose of hormonal therapy, it is very high likelihood that once we repeat a PSMA after 1 month, you will not see any node present there because it will definitely respond. Subsequently, you give a therapeutic option to the patient. You do a proper lymph node dissection. You see all nodes are negative. So are we justified in giving abiraterone to this patient at upfront?
Both, but we'll come to others. Maybe we can take, we have got, surgical colleagues there, Ganesh. So question is that if you have lymph node positive patients, we started with ADT. So he's saying that, ADT may be good enough. We are over treating if we add something else. How comfortable you will be that only ADT and then you go for surgery, we say, give everything up front, systemic therapy and single lymph node. Let's take, I agree, 3 centimeter for my side, just to make it more interesting. You will say 1 centimeter, 0.5 centimeter,
yeah, I think what happens is probably the science changes very fast. It's quite dynamic. And if we are like, we should not be stuck 10 years or 15 years back. When I joined TMH as a fellow, any high risk localized, we used to always refer for NAHT, RTHT. There was no surgery. Clearly, in 2003-04, there was no surgery. Gradually, we graduated into that. And then these drugs came. And today, I mean, the Stampede data recently, which showed benefit in high-risk localized radiation with abiraterone. So why should we not think further that we can give abiraterone with ADT and then add whatever we want to add to, or even like some doubt which Amandeep was saying, like if we operate and find lymph nodes positive, we have three options in guidelines: either wait and watch, or offer radiation, or offer hormone therapy. I mean, hormone therapy and radiation, or hormone therapy. So maybe that abiraterone might get added there also.
Correct, correct. So I'll now
for 2 years.
For 2 years, yeah. So we heard from two surgical colleagues. Then now coming back to medical oncologist colleague. So you had this same situation, 3 centimeter, and he says, hey, you give ADT, or you give ADT plus one more hormonal therapy, and then operate, or ADT and then operate. And if there is a merit, he has a valid question. What you're going to say the patient that what benefit you're going to give?
What Dr. Bakshi sir is referring to is that Stampede data where the overall survival is positive and the hazard ratio is somewhere around 0.65, and there is around 8% absolute OS advantage, and that is what answers the advantage of adding abiraterone early. See, what you see, if last 5 years, if you have observed closely, it is a bit odd concept which is not there in oncology, at least in medical oncology, which is, I mean, this concept is different, is that you throw everything upfront. We never do that in medical oncology, but in prostate, it has evolved very differently. In breast, we don't do it, we do it sequential. In prostate, we learned that way. But the whole data in the respect of OS, I'm not talking about PFS, is now evolving, that first we started with ADT, then we started with ADT plus docetaxel, and now we have come to ADT plus docetaxel plus ABI, because everything is boiling down to the OS. And the same what Dr. Bakshi is saying is that when you add abiraterone in a very high risk localized prostate cancer, it again boils down to OS, and that is what we give extra to the patient.
Anyone?
Intent is not response rate here.
Yeah, I agree with you, and I'll come to that some more, clarification on that. Anyone wants to add it? Why adding? As told by Dr. Randeep, anything you want to add to that? Anyone in the panel? So none. Then what has happened is, so what we have thought about, if you remove something, tumor, you cure patients. That is not true. That is our perception. And in prostate, T1, T2, I do agree. T1, T2, by and large, if you remove, they usually don't die because of prostate cancer. They die mostly because of competing interest, or there is a very high. Lymph node positive, it changes. And for all practical purpose, what I'm aware of, except 1 or 2 malignancy, if you take the absolute definition of cure, none of the cancer we cure with any treatment. And what with the absolute definition is that the mortality when you treat those patients should be similar what is there in the population, general population. That has not been reached. One I read for CML, that was in Sweden, someone reported. I'm sure it won't be happening here, unlikely, because that is one is that is what I remember. We have not read ALL. ALL, what have people start dying because of complications. ALL, pediatric ALL is highly curable. People don't die because of disease. Abroad, 90% they are like survivors, but people die because of something else. So, so cure has an issue. We need to understand that if you remove it, that doesn't mean they get cured. And in this situation, where we have evidence that you add life to the patient, you try not to withhold that treatment. Where your outcome is not so good. So I do believe that local treatment adds value. But again, the context changes, and you want to have your treatment, whatever is effective, add it, don't miss it. So again, this patient got treated as a metastatic disease. Looks like we treated 20 years back, most likely. That's the reason only ADT was given. And then, यार ये कैसे केस दिया तुमने मुझे? अभी तो ये बोला ये कौन सा केस? बहुत ही पुराना लाके दिया. बोले कि जैसे डॉक्टर साहब आप ओल्ड हो वैसे आपने ओल्ड वाले केसेस लाए. But anyway, then it started increasing. After 10 months, the PSA started increasing, and the scan revealed, there is a metastatic disease. Okay, so any choices? अब दो पुराने वाले हैं. Randeep, remember when we were together in TMH?
Life was simple. There was only one docetaxel.
I agree with you. सबसे आसान था क्योंकि patient वही afford कर सकता था. And there was no question about
I mean,
any
old
other.
times lung cancer, if you talk, life was so simple. Just patient comes and he receives
I tell you all my
paclitaxel, carboplatin or pemetrexed carboplatin, goes on docetaxel and finishes. Life has now become so complicated, and it is earlier it was only docetaxel. You are right. When those times it was very simple. So this patient has now ADT and now progressed on ADT. So it's become a CRPC. now.
CRPC, and there is a bone mets is there.
Okay. So we continue ADT and add abiraterone if there is only bony metastasis at this point of time. Yes.
Okay. Anyone else similar?
In addition to
Go ahead.
before starting therapy, I would like to go for testing.
Okay.
Mutation testing for and tumor mutation burden and testing for HRR.
HRR, tumor mutation burden. Yes, yes. Anyone else?
Exactly, sir. So at this point of time, I just want to take some time in deciding further line of treatment at this point of time. So obviously we have options in the form of abiraterone, enzalutamide, docetaxel. But how do we choose among? So obviously, clearly one agent doesn't score much over the other agents. But what we try to see as medical oncologists in day-to-day clinical practice, what I feel, sir. So abiraterone scores over enzalutamide in terms of, when we are seeing like a patient with seizures, CNS neurological disorders or gait disorders, or all those issues. And enzalutamide scores over abiraterone in terms of poorly fragile diabetes and baseline edema, hypokalemic issues, all that. And both these agents score over docetaxel in terms of when there is pre-existing neuropathic issues. So these issues we take into consideration and we'll plan further.
So it is very important comments what was made that you have multiple options, look like similar efficacy, but then also you choose those patients in those certain group of patients where it is important. Coming back to testing, anyone wants to add to it what Dr. Sunil said?
So most important thing is, first of all, we have to figure it out whether patient can be enrolled in a clinical trial.
Okay,
if a clinical trial is going on or not. Then if a clinical trial is not there or accessibility is not there,
yes,
you have to think in the patient-related factors and the disease-related factors.
Agreed.
As far as molecular testing is concerned, HRR testing right now, we are having multiple options. We are having Cohen'S testing available. It's available right now.
Okay, yes,
So
available is also is important.
Treatments cannot be considered treatment until it is accessible and affordable to the masses. So right now we are having HRR testing for which all of us are having consensus that we should do in a patient who are having a proven metastatic CRPC setting and take action accordingly.
Okay.
Right. So this was your question actually. That
Yes. What are the tests? So I heard HRR, TMB. Anyone else? BRCA also, but HRR part of HRR. Anyone else? MSI. Absolutely. Don't forget. NTRK. Now, I thought I'll add from my side something. NTRK. Yes or no? Maybe. I agree. So. So idea is that what I think so panelists are trying to convey that you do have certain treatment which you may or may not want to give now, but you have certain way which may be very effective. What Dr. Ranjit said, MSI, if it is positive and if the patient can take immunotherapy, 6-7 out of 10 patients will respond. So that's something you look into. So it is not a common, but if it is there, you have a very good treatment. NTRK again, prostate cancer, uncommon, more uncommon than MSI. I consider that's the reason Ranjit was not convinced to do it. But if you have positive, then 7-8 out of 10 patients, they respond to that tablet. And remember, many of these tablets are available on compassionate grounds. So don't miss it if you have a chance. TMB again is important. You have a tumor agnostic marker. We debate that, is it really tumor agnostic? That's a separate debate. But yes, that choice is there. But ये TMB कैसे करें? Anyone? How? Because again,
there are some data. Yes, it is a basically tissue-based TMB. You are right, and one of the largest data set we all know is.
कितने जीन का करें? 10 जीन का करें, 50 जीन का करें,
Sir,
100 का करें?
Maybe go. I mean, the depth has to go. I mean, the depth has to go to 500x. It has to be if you talk about the depth, I don't know the number of genes, sir, in the TMB, but the depth has to be at least 500x. Now, I thought you were talking about liquid TMB versus tissue TMB. Okay. Only tissue TMB biopsy.
अभी क्या होता है, आप टेस्ट भेज दो ना, अगर लैब को बोलोगे, वो TMB रिपोर्ट दे देता है. But problem है कि
this is actually the challenge that you ask that हम करते हैं. आप पूछो, sir TMB करते हैं, कैसे करते हैं? The person who is representing that lab is not aware कि the exact technology what is it.
Correct. So important thing to remember is that unless you have a per patient जो output है, जो आप टेस्ट करते हैं, उसकी output वो बोलते हैं TMB होता है कि म्यूटेशन पर मेगा बेस. You should have around 1 mega base of output. Generally 0.8 is also taken, but उससे कम है तो you don't get a good TMB report. So that's something to remember. So 52 gene panel जो हम regular करते हैं, that's not good enough. So remember that doesn't give you a good TMB report. One debate is separate, that TMB based treatment हम करें कि नहीं prostate में, that's a separate debate. But yes, you have a drug approved. So if you're doing it, ask for that, what kind of output you're giving for single patient. So usually, unless you have a few hundred genes, non-hotspot. But again, best part is you can ask what is your output for per patient, and those NGS when they do, if it is around 0.8 to 1, you can have TMB. I thought that which test we do, we need to know what kind of report we get. Coming to HRR, we thought we do, I'm sure we should do, HRR. Question is that any lab gives HRR plus NTRK and other together?
I don't think so, sir, because NTRK is more of a, the somatic panels cover NTRK, and fortunately, Indian labs are now covering NTRK because of the compassionate access of entrectinib, and as well as people are getting NTRK. But I don't think so. The HRR is a completely different panel in all the labs. They all include those 18, 19 genes of CHEK2, PALB2, ATM, BRCA1, BRCA2 and all. But that panel is never combined with the NTRK one. In the somatic, I don't know, in the somatic that whole 19 genes are covered or not of that HRR. I don't think so.
So they do. So the problem
maybe
with
all of them are not there.
So the HRR bolte hain, they do cover, but not all of them. You have to ask them, you have to see them कि वो सारे cover कर रहे हैं कि नहीं. वो problem क्या होता है? HRR is HRR, especially BRCA, becomes a very big gene. तो अगर उसको साथ में डालोगे somatic में, NTRK is part of somatic, so they will be always part of those 52 gene panel or 23 gene panel or 20 gene panel, whatever you do. The moment you add HRR, it becomes very expensive. So usually you will see it is separate, and then you have to do it separate. And therefore, prostate, they don't want to put it because usually panel, they look after lung and make panels, lung or colon. That is the target at this moment. And you do have many other sites, but that is the primarily which drives this testing. So HRR, they will make it separately because they add it. So lung ke liye bhi HRR is a part of the panel, then it's damn costly. So today, if it costs around 10,000 rupees for 10 gene panel, think about HRR they add, it will automatically become 15,000 or more to it, because the output is pretty high, because these genes are very big. So that's again one of the issues. An idea what I'm trying to convey when you're doing testing, remember that there is a logistics to that testing, when we do and what we order. And what Randeep was saying was important. If you do, and we had a discussion, germline kare ya somatic kare. Agar resource unlimited hai, dono kar dalo. You add some value to it. Aap ek karoge to you get something more out of other one. But resource the limited hai desh mein, isliye that is one of those. If you do somatic, you will pick up germline. Agar germline hai, to aapko har ek cell mein dikhta hai, you will pick up germline, except that sensitivity thoda agar आप blood में करते हैं तो you do pick up some extra. Otherwise, usually you will pick up.
Sir, one question I would like
to
ask everyone. So we have a HRR sequence nowadays.
Yes.
So many patients do it. The problem comes when there is a BRCA variant of unknown significance or tier 3. It is given tier 3. So how others approach it?
Anyone, I'll answer later on. I may ask. Yes,
Sir, in general, as per the literature.
What the question is, BRCA and your report आ गई mutation and it is in tier 3, मतलब उसके unknown significance है. अब क्या करें?
Yes, sir. So, it is not about particularly about prostate, sir. When we talk about the BRCA VUS, so I think the literature mentions it as not positive, neither positive nor negative. It has to be closely under monitor. That means, so they will be, regularly monitoring. Adding into the list. This VUS may go into the BRCA positive. So till that time, we have to wait. That's what I think.
Anyone else? Randeep.
Very valid point, and I realized over 6-7 years there was a patient of breast cancer who had a mutation classified as VUS, and then 5-6 years again I did from the same lab, and they said that this is now pathogenic. So I asked them, is it the ClinVar classification? And the database keeps on adding, and every 5 years that VUS may go into negative or positive. So if you have a VUS, there are 2-3 ways to go about it. I mean, one is that if you can send it to Myriad, if the cost is not a concern, which is always is, you can send it to Myriad. You may get some answer, but yes, the database is more of a European or more of an American. Second is that you keep it under follow-up, that is best. And after 2 years, you can again send a test. Third is that family history may play a role. If there is a very strong family history, you can classify this VUS as pathogenic. But the problem comes that if you have a strong family history with the BRCA VUS, are these tests strong enough to use olaparib? That is where I get stuck, because there it is more of medical legal, that how are you using in a VUS? Suppose someone has a father and a brother with a breast cancer, and there is a 2 family members first degree with breast cancer and prostate, and you have a VUS. Does that classify to use abiraterone? That is where I get stuck in the, I mean, other scenarios like ovarian.
So very important issue raised. So when you have a VUS, there are 2 significance. One is your treatment part, which you are bit concerned ki olaparib de ki nahi. You may wait till the 4th line, 5th line, but finally you may give it. So that was the easy escape. Second situation is a problem. Like if you have it and then you took a family history and 1 or 2 people have it, now you get stuck. So that becomes a challenge, and that is where your genetic counseling becomes important. And coming to Sunil's question, for me there is an easy way out. We have a molecular tumor board. I'm telling you, it is very helpful. If you don't have it, you have to do this test, get one. It really, so you learn a lot. One thing I do learn a lot every Wednesday, 9 to 10, we have it. And second part is, you have a collective decision. So anything goes wrong, you have a chance to blame it on Rio for anything. So, but first part is important. You learn a lot. So, no, Sunil, you know that, huh? He was just teasing me. We were together just around a few months back, and he knew that 9 to 10 we have this molecular tumor board. So this was regarding the testing part of it, what we do and whatever we follow. So everyone chose docetaxel. Given, and this is the reason why people use it. This is my time, younger guys, these are very pretty old, trials which led to these treatments. So patient was given enzalutamide.
I mean, will you use abiraterone plus olaparib if the HRR comes positive at this point of time? If sir goes to the backslide,
yeah.
So it is a CRPC setting.
Yes.
We already have the data presented of magnitude as well as the propel. So would you like, suppose HRR positive, will make it simple. I mean, sir, sorry, I can ask this.
It's a good question.
So will you add abiraterone here? I mean, AZ Astra people will be really interested to know.
Sir, I think with the available data as of now, the propel definitely is an interesting study to look at. Although we don't have the OS mature data, only 26% data we have, but we have good radiological PFS benefit in terms of around 8.2 months with olaparib plus abiraterone, and irrespective of the HRR, that's one. I think that's good.
So. Okay, because it didn't require. But coming to niraparib, I forget the niraparib. That was a negative study, but and I always look for a concept. Is it has been this has happened earlier? So it has happened earlier also, that if you have BRCA negative and HRR negative in breast cancer, and it has worked. So are we looking to the real concept? No, it looks like it works in HRR negative also. I don't know what anyone thinks. Ranjit?
When we do a lot of androgen inhibitions, these cells become sensitive to PARP inhibition. So that is one hypothesis.
Okay.
So
that's same way working in breast cancer.
Yes, absolutely. So that could be a hypothesis how it works.
Yeah. So it looks like you have now more than one study showing that, and maybe 1 or 2 more, and then we'll realize no, it is the way to go about it. Coming back to so everyone chose that we give it or we won't give it. What Randeep asked. PARP inhibitor plus abiraterone, yes or no? You can answer only yes
at
or
this
no.
point, no.
No. Anyone else?
I will wait.
No, yes? No.
We definitely are waiting for the long-term this one, sir, but can be considered.
No, as of now.
No, as of now. So this is the label does, this is the FDA label रहता तो most likely Sunil agree कर देता. Achal, I'll give you some data to it. So I don't know what happens. Sorry बोला. अच्छा चारों टेस्टिंग तो दोगे इसी ने बोला हाँ. देखो हमने तो बोला भी नहीं था. So I think so. If you take docetaxel and abiraterone, the kind of data they got approval. Remember, we are giving already something here, and then we are adding something, and then it is changing median by almost 8 to 9 months. And 8 to 9 months changing median in CRPC, it has hardly ever happened. Don't get me wrong. I'm saying that you have to use it, and I'm just putting data to it. I agree. It is possible that OS doesn't come positive, and then whatever I say has got a very limited value because OS doesn't change. Then we can say sequential use is absolutely fine. We are not saying sequential use in prostate cancer. What Randeep said was because of OS is benefiting and substantial. So we say, hey, push everything up front. So PFS data I was just putting, that doesn't mean I'm using. Sunil, मैंने change नहीं किया practice. जब से तुम गए हो वही practice in the same way I've been doing.
For PFS, we are exposing the patient for extra toxicity also if we are not getting OS. So then we can use in later lines also if it is approved already.
I agree with you.
It also made this point that we don't know how the MDS will evolve, and maybe we know that with ovary there is some 2% data of MDS. We don't know how it will happen in this. Every setting is different.
Correct.
So he also made this point that we don't know if you are starting using from this point another 2 years, 3 years, AB plus olaparib will keep on continuing, and we have some MDS waiting for us.
So we did discuss about those different tests and different treatment options. Now we'll come back to again surgical oncology colleagues. So we heard we have all these options, and if we start seeing those HSPC data, and if we see them, and this is like almost by and large most of the subgroups, you do see a whole lot of people long-term surviving. Do you think you'll be tempted for these metastatic disease, not only lymph node positive, and I'm not saying oligometastatic also only, that we know that we do have some concept. Coming back to local treatment for them, that patient 4 years surviving after treatment, hardly any disease seen anywhere, maybe 1 or 2 bone mets is seen or lymph node is seen, but prostate, you have the disease, because we do know with whatever systemic therapy we give, unfortunately, disease doesn't go away completely. CRs are very uncommon. Is it tempting?
For now, I think there is not much data on it, that whether later on, like 4 or 5 years later, can we add a local surgical option for this kind of patients? But subsequently, if a patient has been having
I'll give you an example.
good suppression.
I'll give you an example. Sorry, just interjecting, just putting perspective. I'm using germ cell tumor. It's not germ cell tumor, but I'm using how the treatment becomes effective. A modality starts changing. So you have germ cell tumor, you give BAP. We are very happy about it, very proud, excellent treatment, never changed for last decades altogether. Nothing moves beyond BAP there. But you have a residual disease, 1, 2, 3, 4 places. And if you can resect, we resect. So, and here you have to start changing that outcome, which used to be around 16 months, 20 months. Now we see 5-year survival. So if you have like someone surviving a group of patients, 3 years, 4 years, 5 years, in that context, I'm asking. Sorry, I interjected you.
So I think definitely this option is going to come up, because the removing the prostate will give us an opportunity to study it more in a better way in terms of what kind of changes is happening inside the prostate, what kind of mutations are developing, and then more specific mutation guided therapy will evolve based on this kind of data. So definitely this is a possibility, and it needs to be further studied in this context.
Okay. Amandeep, anything from you? So if it's 3, 4 years, 5 years, and then you have 1 or 2 places, you did your PSMA PET, and these are the only places you have a disease. And you say, yaar, yehi bacha hua hai, बाकी जगह तो बड़ा हमारी जो टैबलेट वगैरह है, इंजेक्शन बड़ी अच्छी काम कर रही है. If someone takes care of this, and this is what we did in germ cell tumor, those cisplatin refractory, we say, बाकी जगह cisplatin has worked very well. If we remove those cisplatin refractory disease, and you have a good number of patients surviving.
think this is hypothesis generating right now.
Hypothesis.
I think
So-
this is the concept behind the role of radical prostatectomy in metastatic prostate cancer setting, where they want to remove the factory so that the tumor burden
Why,
is
Amandeep,
reduced.
you are saying it is hypothesis generating already phase 2 data of oligometastatic prostate cancer.
Exactly.
Yeah.
I mean, it's oligometastatic if you
said
उसने ना, he
अरे,
out-
5 years.
No,
Sorry.
he says outsourced to RT. Na. That's a problem.
Then outsourced to RT.
So I was like, Amandeep will own it, but he says no, the data is for RT. So RT.
Kumar sir rarely throws the ball in your court. He was throwing, you still did not catch it.
So he is he's a good goalkeeper. वो उसको pass on कर देता है बाहर.
German trials are coming up with this data, where the role of radical prostatectomy in metastatic prostate cancer setting is definitely there, and they do see some overall survival advantage.
Okay. So just I was putting because this is the way. This is everywhere I've seen. The moment your treatment starts changing, patients' outcomes start changing. You say the modality and a clinician starts behaving in a different way. You know, we have learned. I'm a medical oncologist and I treat lung cancer, so I've learned in lung cancer. You know, stage 4 patients. We used to say, "Pata nahi chemotherapy dena hai ki nahi." That used to be thinking. Man, in mere umar mein, not in Randeep's time, things started changing, and now things have changed a lot. Now we say we have given treatment and there's a disease progression. Now good number of people operated and RT तो खैर देते ही हैं. You know, अमन जी वहाँ भी उन्होंने outsource किया RT वालों को. SBRT देते. I keep saying my surgical colleague, then please remove it. But now they're listening. They just operated one patient, and so this is the way it changes. Those average life of 6-8 months, they started surviving 4 years, 5 years, and there's a disease, so they don't remove the primary. So think about a concept. You have a disease. Disease is there. It is responding, but it is residual. That disease is not increasing. You have 2 new nodules, remove them or give RT to them. But I never knew this kind of treatment will happen for lung cancer. Just giving example the way treatment evolves. So I think so. 20 seconds left. Any comment by anyone else?
The same concept also goes somewhat for the colonic cancers also.
Absolutely.
Yeah,
right.
because that is the backbone of their treatment to start with. And anytime it recurs, they go in and resect it out.
Yeah, correct. वो liver में, lung में, और transarterial catheterization करके chemo देने के लिए liver के लिए. Yeah, I agree with you. Thank you so much. I enjoyed the discussion. Hopefully you guys enjoyed it. Thank you so much. Thank you. Oh, go ahead. Shoot. I'll just take less than a minute.
There is one query that I received from the patients that suppose I have done NGS from Edge Genome or Core Lab, वो पूछते हैं कि सर बाहर वाले लैब में भेज के कुछ होएगा फायदा. So I don't know the answer.
Okay. So first part, easy one. So first part, NTRK, whatever we have done, prostate hardly we have done, because prostate problem, HRR takes such a precedence that going back and asking patient to again do a somatic panel beyond HRR becomes tough. So hardly I have done. But in general, whatever I have done, I have got 2 or 3 NTRKs. So not many, uncommon, far uncommon than what I read in literature. So you are absolutely right in that. So NTRK, we do read it, but really it's uncommon. So absolutely right. What you have raised, that what you commented upon. Second part you said, med genome diya to bahar bheja ki nahi. See, I am not I'm not the best person to comment upon each lab. Some lab I have worked on, and some lab I have access to data, so that I can say that they are good. So I can say it's the way we call about generics, na? There are, so we have a testing also, we have generics. So some of them are very good, absolutely as good as anyone in the world, except that you can argue that it's a 52 gene panel, and others may do 500 gene panel outside, but some of them are excellent. But you are absolutely right, not everyone is excellent. There are some labs where we have asked for raw data and they don't share at all, and that you become a concern, because I saw from lab multiple times double mutations. So the moment you start getting abnormal reports, be careful. So this is one of the lab I don't want to name. I got more than one patient with double mutations. I said, okay, it happens. I said, share the data. We'll just show to our scientists. If they agree, then we'll endorse it. We say, hey, we have seen that data and it works. But then I do get concerned. So only problem is that, if I take a name of the lab, it becomes a bit awkward. That's the reason I'm not taking the name of the lab. But there are some very good labs.
Sir, one more question. You gave the example of germ cell tumor that after BEP there is residual disease, you undergo surgery. So do you do the same with a lung cancer patient who's supposed treated with alectinib and the patient has only 1 or 2 nodules left? Then would you offer that patient surgery?
Till now, no. I totally agree with you, and absolutely, this is expected from. See, this is the importance of having your students and colleague. So, absolutely expected a question. I totally agree with you, and this is a question asked by many patients. The kind of benefit we expected with oligometastatic disease in lung cancer, it will take me a bit of a time to answer. Is that okay if I take a few minutes? So, so oligometastatic disease has a 3 concept. You have a oligometastatic at presentation, oligometastatic residual, and oligoprogression. What we are certain today, oligoprogression treat, it benefits. Not randomized trial, big one, but you have enough data that, and because there is an unmet, do it and it benefits. Now, coming to oligomets at presentation. Oligomets at presentation, 2 randomized trial showing overall benefit, they had to be stopped. Trial was stopped in lung cancer because interim analysis was so good. But the problem is that they did it with first generation TKI in the older treatment. By the time systemic therapy progressed so much that that concept is not picked up so much. So today also oligometastatic disease, people are very careful to treat. Now, third is oligoresidual. At this moment, no, there is an issue regarding giving local treatment.
But in prostate, you'll give.
I didn't say that. I was challenging Amandeep and them to take it up. So I didn't say that you need to use it. I never said that. I said that I was challenging. Is it useful to do it? We'll be using it tomorrow. Most likely, you can. I will stick my neck out, and maybe you can catch me after a few years. But by the time I'll be elderly. So, so if the patient start living 5 years, 7 years, 10 years, and if they keep failing at that place, most likely we'll do it. So at this moment, what we know, we are very happy having 5 years, 7 years survivals in lung cancer, same in prostate cancer. What we are learning, where they are failing. Once we learn that where they're failing and we intervene, then my feeling is that local treatment will be coming in those situations. Because see, problem with the systemic therapy is where, like immunotherapy, one advantage that you do get CRs. We don't get CRs with these treatment, what we are giving. We if have got CRs, then yes, germ cell tumor, majority of the patient doesn't go for surgery because cisplatin gives CRs to us. That we don't see it. So local treatment, if we are able to take care and we learn where they start failing, most likely it will come in. So I'm not saying tomorrow to use it. No, definitely not. Definitely not.
Thank you. Thank you, sir.
Thank you. And my apology.
Come to the end of day 1. Thank to all the delegates, as well as on the behalf of my co-organizing team, Dr. H.S. Darling, Dr. Aditi, and Dr. Puneet, I would like to welcome you all for the dinner. Please join us for the dinner. The tomorrow session starts at 9 a.m.